హలో. 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 మళ్ళీ స్టార్ట్ చేయనా? లేకపోతే హలో. హలో. వస్తుందా? ఓకే. హ్మ్. ఓకే. ఓకే. ఓకేనండి. థ్యాంక్ యూ.
So a possibility of a bacterial pneumonia was considered. A possibility of a bacterial pneumonia was considered and a child was vancomycin was added. Subsequently, this was the initial X-ray. So as you can see, there is haziness in the left mid and lower zones and suggestive consolidation, and there is a, although it is not clear, there is a clear line which is suggesting a this we can do. No? Okay. There is an option 2. Yeah. So this was the initial X-ray where we can see that there is a haziness in the left mid and lower zone, and the possibility of pleural effusion was there because of the sharp line which we can see. But however, there was no mediastinal shift. As you can see, the trachea is also in the midline, and the heart also looks, the position of the heart looks okay. So we did an ultrasound just to document the quantity of effusion. It was showing only minimal pleural effusion, and the predominant finding was a consolidation. So we continued in the same treatment. Child was on HFNC and antibiotics. Although child there is an initial X-ray where we can see that there is a haziness in the left mid and lower zone, and the possibility of pleural effusion was there because of the sharp line which we can see. But however, there was no mediastinal shift. As you can see, the trachea is also in the midline, and the heart also looks, the position of the heart looks okay. So we did an ultrasound just to document the quantity of effusion. It was showing only minimal pleural effusion, and the predominant finding was a consolidation. So we continued in the same treatment. Antibiotics. Although child there is an initial X-ray where we can see that there is a haziness in the left mid and lower zone, and the possibility of pleural effusion was there because of the sharp line which we can see. But however, there was no mediastinal shift. As you can see, the trachea is also in the midline, and the heart also looks, the position of the heart looks okay. So we did an ultrasound just to document the quantity of effusion. It was showing only minimal pleural effusion, and the predominant finding was a consolidation. So we continued in the same treatment. Antibiotics. So subsequently, as air entry was less and with dullness and percussion, we assumed that the pleural effusion would have increased. So this was the X-ray on day 3. So we can see there is diffuse whiteout of one side. There is some mediational shift of the heart to the other side. So possibility of a moderate to severe effusion was considered, and ultrasound was done. Ultrasound was done. We should moderate effusion with no septations. So this is important because whenever we are dealing with the paranamnic effusions, we have to decide whether it is a only clear fluid or whether it is an empyema or something like that. So we need to do an ultrasound, which is better in terms of delineating the findings. So after this, we inserted chest tube, and there was 150 ml of serous fluid was drained. It was not frank pus. So meanwhile, we had sent an nasopharyngeal PCR for the etiology of the pneumonia, and which was suggestive of pneumococcus. It was a high levels or positive, and the pleural fluid was sent for analysis, and which revealed 7,000 cell count with 90% polymorph. Sugar was less, protein was high, suggestive of exudative effusion. However, Gram stain was normal, and culture was also sterile. We also sent the pleural fluid for the analysis, and which was suggestive of same the pneumococcus. So the diagnosis of pneumococcal pneumonia was confirmed. So briefly regarding the paranomic effusion, so it is accumulation of pleural fluid secondary to pneumonia. Most likely it is in the bacterial pneumonia when things are more complicated. In viral pneumonia, generally it's a clear fluid. It can be either simple fluid or complicated or empyema. So this is one of the classifications given to categorize the various stages of pleural effusion. So as we can see that there are around 7 classes, starting from non-significant effusion, typical effusion, then borderline complicated, complicated, and empyemas. This classification is mainly based on the 2-3 parameters. One is the X-ray findings. Second is the pleural fluid analysis. We can see that the pH, based on the pH, if the pH is more than 7.2, then it is not a complicated. If it is less than 7, that is a complicated pleural effusion, and glucose and LDH. So that I will be showing the next slide. So by definition, empyema is accumulation of pus in the pleural space, which comes from a Greek word, and most often it is associated with the pneumococcus, as in our child. However, in developing nations and post-traumatic cases, Staphylococcus aureus is the common organism. And mostly it is seen in infants and young children, and the frequency of empyema is, if you see the literature, it is on the rise compared to previous. In simple bacterial pneumonias, the frequency of complications of pleural effusion and empyema is less than 10%. However, if you have necrotizing pneumonia, the frequency can be as high as more than 80%. So the pathogenesis is the pleural effusion and the progression is in the 3 phases. The first 1 to 3 days is an exudative phase, where the inflammatory process leads to the accumulation of a clear fluid in the pleural space with a low cell count. So that is a simple paranomic effusion. Subsequently, it is a fibrinopurulent stage which ranges from about 10 days after that, where there is deposition of fibrin in the pleural space, leading to septations and the formation of the loculations. So at this time, pleural fluid evaluation will show increased increased WBC, decreased sugar, all those findings which we have seen in the previous slide. And subsequently, it is organizing phase, where fibroblasts infiltrate into the pleural cavity, and it is formation of the thick membranes which will prevent the expansion of the lungs. So that which is called the thick peel, and this will cause trap lung, which will cause further worsening in the form of no improvement in the clinical condition. At this stage, if you are treating properly, it may improve. Otherwise, you may end up in either surgery or chronic empyema. So the etiology most commonly is infective. Sometimes other causes like post-traumatic. Although it is infective, it is primarily a trauma. It is not a simple pneumonia which started having this complication. Sometimes in underlying malignancy, post-surgery. So those are other causes where you can have a pleural effusion that can complicate by spread infection. So most commonly pneumococcus and other organisms are there. So clinical features, we can have 2 patterns of presentation. One is like this child. She presented with fever, cough, cold, some bit of work of breathing. There is mild effusion, which increased in next 24 to 48 hours. So that is a common presentation. The second presentation is when you have a child with pneumonia, there is no effusion at admission. You started an appropriate antibiotics, and after 40 to 70 hours, you see that child is not improving. So at that time, when a child is not improving, then you have your checklist, whether you're giving correct antibiotics or not, whether any other cause is there, and any complications. Complication can be lung abscess, pleural effusion, necrotic pneumonia. So that is the second scenario. If the child remains unwell about 48 to 72 hours after the initiation of treatment, then you should think of complications, and you should do at least a repeat X-ray and ultrasound chest as required. So for diagnosing pleural effusion and empyema, the simplest investigation is the X-ray. X-ray will tell you briefly at least the effusion is there or not. So you will see various signs like obliteration of the costophrenic angle. That is the earliest sign. And once the fluid increases, you may see the meniscus sign. And then subsequently, as in our case, there will be a whiteout of the one side. However, X-rays cannot differentiate whether it is empyema or simple effusion or a complicated thing. So these are the few X-rays which highlight these findings. As you can see, this here, the left diaphragm, costophrenic, cardiophrenic, both the angles you're not able to see. This can be simple pneumonia also, but when it is not seen, if you see at least a small line kind of this thing here, then you think of possibility of an effusion. So this is the meniscus sign, where you can see when the effusion is slightly increased, then you see that both the tips of the effusion margin are slightly high. So this is like a meniscus. And this is the third case where you have diffuse whiteout. When completed pleural fluid is there, you will have diffuse whiteout with a mediastinal shift to the other side. Then second investigation is the ultrasound. So ultrasound, although it is not mandatory, but definitely it will help in the case of whether it is complicated or not and further management. So guidelines say that it should be used to confirm the presence of pleural fluid. It will tell about the size of the effusion, presence of septations, and any loculated fluid is there or not, and echogenicity of the fluid. And it is suggested that better to place chest tube with the help of ultrasound, especially when it is a mild effusion. If it is a moderate to severe, you may not be requiring ultrasound guided placement of chest drain. But if you feel that child is not improving, it is a mild effusion, you want to drain it, then definitely ultrasound will help. So these are the two videos. Please. This is a child with what are the effusion? The first one. So you can see this black thing is the pleural fluid. You can see it is clear, like there is no increased echogenicity, there are no septations. So it is a simple effusion without any significant complications. Sorry, this is kind of rotated. Can we turn it? So I'll try to. So this is the pleural fluid. So you can see in between there is some echogenicity. We'll come.
Stop.
So this is the echogenicity. So you can see echogenicity or septations kind of thing in the ultrasound. So that will definitely help us in further management. And moving on to CT chest. So we see most of us does generally upfront CT scan. So if it is a simple bacterial pneumonia and no much of complications, generally you don't need to do a CT scan, because CT scan has some limitations compared to ultrasound in case of pleural effusion. It cannot differentiate parapneumonia effusions reliably. And for identifying the septations or fibrin strands, generally ultrasound is better than CT scan. And it also has radiation exposure and all the other things. So it is reserved for only complicated cases, like when child is not at all improving, and you're planning for a surgery and there is a possibility of a lung abscess or necrotic pneumonia. Those are the conditions you will do CT scan. So whenever you do regarding the pleural tap, as per the guidelines, there is no, if you're thinking of it as a parapneumonia effusion because of bacterial pneumonia, then probably there is no much role for a repeated thoracocentesis, but small effusion is there you want to see. So you can do one-time pleural fluid analysis, and we can send for the routine workup, which include cell count, sugar, protein, Gram-Stein culture. So although most of the places it mentions pH, then it is very difficult to do pH in case of pleural fluids, and we can do LDH also. And as per the unit for unit protocol, we can send for bacterial PCR. And if you're in doubt whether it is simple bacterial effusion or not, then you have to do other workup like a TB workup and all, depending on the clinical condition. So this is the differentiation of pleural fluid analysis from transdate to empyema. Generally in transdate you have cell count less than 1,000, whereas in empyema it is more than 10,000, but often it is more than 50,000. Your sugar is very less in empyema, protein is elevated, LDH is elevated. So these are the differentiative feature from transdate and empyema. So regarding the management, most of the time initial management will be almost same. So we should start the child on IV maintenance fluids, oxygen if hypoxemia, analgesics, and antipyretics. There is no role for routine chest physiotherapy in case of pleural effusion, especially when acute phase, when there is pneumonia and effusion, the routine physiotherapy is not recommended. And antibiotics, we have covered the common organisms. Two organisms are pneumococcus and staphylococcus. We should be covering for both of them. And subsequently, once you have cultures and all and clinical improvement, then either you may have to upgrade or downgrade. If the culture is positive, then you can downgrade. Meanwhile, you have to see the overall clinical condition of the child. And duration, most of the times, if it is empyema, it will be 4 to 6 weeks. Initially, for 1 to 2 weeks, depending on the clinical condition, it's IV antibiotics. Once things are fine, you think you can discharge the child, we can shift to oral antibiotics. So, chest tube drainage. So once you have a pleural fluid and things are worsening, then definitely there is a good role for chest tube drainage. But does every child with parapneumonia effusion need chest tube? No, not every child will require. If it is a mild effusion, no significant distress, child is clinically improving. Most of the times you don't even do thoracocentesis for evaluation, because some effusion can be there which can be managed with only IV antibiotics and all. But if the child has some of these at least, so there is a moderate to large effusion, then probably that is definitely an indication for chest tube insertion if it is associated with a moderate to severe distress. And ultrasound, if you are seeing septations or loculation, that means there is already a complicated process is going on, and that will not improve with only antibiotics. And if you did a tap, then obviously if it is a frank pus, there is no discussion. We have to go for chest drainage insertion. So, and some of the pleural fluid characteristics. So if it is bacteria is positive from the pleural fluid, that is an indication. pH is less than 7, LDH is very high, and glucose is less than 40. So we have to do a chest tube drainage. So whether it should be a blind or it is ultrasound guided, it depends upon the clinical condition. Small effusion, ultrasound guided is definitely better because we will not be able to go where exactly the pus is there. Large effusions, then we can do blind guided. So some brief points regarding chest drainage is, anybody who is well trained in chest tube should be placing the chest drainage. And routine measurement of platelets and all is not generally required. But if you have a low platelet or coagulopathy, then better to correct before inserting chest drainage. And ultrasound should be used to get thoracic drain placement, especially if it is a small effusion. Drain size. So most of us, what we feel that pus is thick, so we should be like placing a large tube and all. So whatever the evidence, some of the studies which I've seen in pediatrics, they have shown that small drains are as good as large drains. So if you are placing it as a guided, ultrasound guided, then you can use small also. If you're thinking you're not ultrasound guided and if you feel you may not be able to match with that, then you can use a large bore tube. The main disadvantage of large bore tube is that the pain will be more, discomfort will be more. So with small, that is little better. And insertion site, so ultrasound guided, they will mark wherever the maximum effusion we can place. Otherwise, you're placing blindly, you should place in the safe triangle. Safe triangle is like which is bounded by the pectoralis major anteriorly and fifth intercostal below and the latissimus dorsi posteriorly. So that is the safe triangle where you have to place the chest drain. And once you place a chest drain, you have to connect it to a drain bag. Routine negative suction is not required. Only rarely, rare cases where like a thick fluid is there and you think it is not coming, then only will require a negative suction. Otherwise, routinely we don't need a negative suction. And if the drain is more than 10 ml per kg, if you have inserted chest tube and it is more than 10 ml per kg, generally it is better to clamp for some time. And after 1 to 2 hours or so, you can again reopen and to see whether the drain is persistently high. Once things are in place, you put a drain, child is improving, so you have to daily monitor the drain output. And whenever there is no drain output, there's multiple things can be there. One is a mechanical cause. Look for a king tube, block tube, or displaced tube. If there are no mechanical causes, then it might be that pleural effusion is completely resolved. You can get an X-ray and see the child, either clinically, radiologically, if it is fine. And if the drain output is less than, say, 10 to 20 ml per day or 1 to 2 ml per kg per day, with clinical and radiological improvement for 2 to 3 days. And then you can consider chest tube removal. So in the index child, so this was on day 3, immediately after chest tube insertion. As we can see, there was some opening up of the upper part of the lungs. The mediastinal shift also is a little better. Then subsequently on day 5, and things are again plus minus. So there is, as you can see, there is some clearance in the lateral part. So this happens when you are in a supine X-ray, because most of the children will be lying down, so we can't get a sitting X-ray. So the fluid tend to accumulate posteriorly, not like completely side. So this can be that finding. So there is no further drainage of fluid, no mechanical issues. Child was not worsening and not much improvement. And repeat ultrasound showed only mild effusion was there, no septations and all. So this was the clinical scenario. So at this point of time, now we knew pleural fluid was not frank empyema. Cultures, although PCR was positive, culture, by definition, culture was not positive in this child, and X-ray is up and down. So we did a CT scan to see whether any complications like necrotizing pneumonia or empyema, chronic empyema, where empyema where pleural fluid is thickened or not. Sorry for this. Actually, they got turned upside down angle. That's it. Copy by I say play. नहीं सर प्ले करते So this is the right side. You can see that there is no lung at all. So the video is not clear. So this is the lung on the right side. Sorry, this is the left side. There is complete opacification of the left side. So in lung window, you will not be able to see what exactly is there. Whether it is consolidation, whether there is a effusion, it will not be able to make out. Next, mediastinal window. So you can see na. So compared to the other side, this is a normal lung in the right side. So this brighter part is the consolidation, and the lighter the hypodense part is the fluid, and the left lower lobe. So it is not clear. So you can see this is the cavitation. So left lower lobe was very bad. There is consolidation with air bronchography in the left upper lobe with 3 areas of necrosis. There is a cavity with necrosis of the left lower lobe and part of the lingula. Moderate empyema was there. So it is a necrotizing pneumonia with cavitation with empyema. So child was continuing the same antibiotics. Meropenem was added as child was not improving. There was a loculated cavity. So we inserted a second chest tube in that, and urocanals were instilled. So the decision not to give before and give now was mainly because initially it was not typically behaving like an empyema. Pleural fluid was clear. The evaluation also was like exudative effusion. It was not like a frank pus. But as child progressed, we gave for 24 to 40 hours is not improving. Then CT was more of pleural thickening and all. We gave urokinase, and clinically child was, like as I said, it was like just okay and some improvement. So when will you use fibrinolytic agent? So the guidelines say that whenever there is a complicated parapneumotic effusion. So how do you say this? Either there is thick fluid with septations and ultrasound or loculations, or there is an overt pus. So if it is a frank pus, then fibrinolysis will definitely help. Or septations are seen, echogenic fluid is seen, then you should go for fibrinolytics. And they have significant role in the early in the course of illness. Some studies say even up to 14 days they will be beneficial, but if you're not going for a early surgery, then definitely fibrinolytics will have a role. So with these three are the fibrinolytics which have streptokinase, urokinase, and alteplase. Which one is better? So the evidence shows that urokinase is the one which has less side effects in terms of allergy or fever or something like that. So urokinase is little better. However, it is costlier than streptokinase. Alteplase, although it is better, it is much more costlier. So alteplase generally we are not using routinely. Streptokinase or urokinase depending upon the availability. So the adverse effects include fever or blood stain, pleural fluid, discomfort. Some anaphylaxis can be there sometimes. So in the indexed child, so this was the progression of X-rays. As you can see, full whiteout. There is some opening up of the lungs. Whether it is a cavity which is opening or it is a normal lung, difficult to explain on X-rays. But there is no much improvement on the X-ray. However, clinically, the CRP, which was initially 170, it has decreased to 70, 50, 12. PCT has decreased. WBC was better. So clinical improvement was there, but lungs were causing trouble. So I will not show the CT. It was showing the same complete necrosis of the left lower lobe. So like this. So this is the left lower lobe. You can see na complete cavitation. This is not normal aeration. As you can see, this is not normal aeration. There is complete necrosis of the left lower lobe, and this is the complete necrosis. Normally, consolidation you will see like this, something like this. So left lobe was completely gone. Left lower parenchyma is completely replaced by a large cavitating area. So we are given enough time for the child, but child was not improving. Then we planned for a surgery. So in pleural effusion empyema, when will you consider surgery? There are two approaches. So if you feel it is a complicated effusion and empyema is there, either you can go for early surgery or you can go for the thoracostomy tube, pleural fibrinolytics and surgery. So whenever there is failure of chest tube drainage, antibiotics and fibrinolysis in the form of child ongoing sepsis is there, fever is persisting, CRP is child is not improving, persistently the effusion is not improving, and it is causing a significant respiratory compromise, or there is an organized empyema like in this case, and bronchopleural fistula is there. These are the indications. Once conservative management has failed, then you will go for surgery. Surgical operation options, three options: VATS, which is video assisted thoracoscopy surgery, mini thoracotomy and decortication. VATS is a minimal invasive surgery which in the early phase of the illness, which is beneficial for surgical aspects. Whereas in this case, at this point of time, when so many things are there, you are left
Hello.
Failure of fibrinolytics. If there is significant pleural thickening, which we can see in either ultrasound or CT scan, there is a necrotizing pneumonia, as in the index case, or there is a lung abscess. These are the conditions where your fibrinolytic
Lower lobe. Upper lobe comes outside. Your
upper lobe is expanding well. As you can see, it's quite reasonably fair enough.
So to summarize, whether you are suspecting of allergy mutation or later test case, definitely they have some otherwise, if the suggestion of infection is there, go for intravenous antibiotics. Facilities where early surgical option is there, like foreigner, they generally go for early VATs, then go for early VATs. Otherwise, go with the antibiotics, chest tube drainage as required, as we have discussed. And if the ultrasound is showing echogenic fluid, loculation, septations, and pleural fluid is frankly suggestive of empyema and all, then you go for intrapleural fibrinolytics and see the child is improving or not. Child is not improving, go for surgery. It's VATs or open surgery, then it depends upon the surgical expertise. If the child is improving, then continue all those things. Generally, the fibrinolytics we give for 3 days. Sometimes we extend for 5 days also. And total duration of antibiotics will be 4 to 6 weeks depending upon the course of the child. So to summarize, so high index of suspicion for pleural effusion should be there, especially in children who is having moderate to severe respiratory distress and child is not improving clinically after a period of time. Early use of ultrasound helps in decision making. Chest tube drainage in children with moderate to large effusion, as I told, moderate large effusion, distress, and the pleural fluid features are suggestive of acute infection. And fibrinolytics, we should be using complicated pulmonary effusion. Early VATs where facilities are available. Most of the times, empyema, although it troubles, mortality is generally less. And once things are better, they have relatively good short-term and long-term outcomes. Thank you. So sorry for the glitch and all. There are so many like videos and all we could have seen better. So any queries? Anything you want to ask? Yes. Okay. Thank you.
I hope you all are having a good morning. So going ahead with our session, I would like to invite Dr. Parag, who is Clinical Director of Pediatric Intensive Care Services and Department of Pediatrics at KIMS, Cuddles, Kondapur. The topic which Dr. Parag will be discussing is very, very crucial in saving a child from death. So ECMO or no ECMO after ARDS, evaluate, intervene, and decide immediately. Without further ado, Dr. Parag.
So though ECMO looks really bad things, we should think about ECMO when the things are not moving. So we'll try to see one case and briefly, I'm not going into detail of too much of physiology and all those things. Is it working, brother? So the only thing is in a pneumonia or severe ARDS, when they are going on ECMO, we are not doing anything. We are just giving rest to the lungs. So we are just buying a time so that by ventilation or by doing some supra-physiological things, it could be high frequency oscillatory ventilation, it could be high pressures, we can actually save the lung from getting more damage. So just to give a simple example, that a child who is on a pneumonia, child is having pneumonia, not maintaining oxygenation, we put them on ventilator. Remember, all ventilator causes injury. So it's not like that a child is on pneumonia and you're able to maintain the 100% saturation. That means it is helping the lung. No, it is actually damaging the lung. But it all depends upon the strength of that lung, how much damage it can accept. Okay, and over the time, whatever the etiology, it could be a bacteria. If the bacteria started improving, or because of the antibiotic, lung will start improving and probably will have an overall better effect. Okay, so whatever ventilation we do, post-surgery, elective, non-elective, we are causing trouble to the lung. There is no doubt about it, okay? And that's why this came into, can we give a rest to the lung? So briefly, a small baby came to us, cough, cold since 3-day, breathing difficulty, has a consanguineous marriage. Everything was fine, but had an NICU stay of 6 days. It was documented as a TTNB and had a small kind of a PD at that point of time. So doesn't work on that, but first echo, PDA, ASD was there, repeat echo on day 13. There is a small PDA again, advised cardiology follow-up, nothing things. And because of the cough, breathing issue and poor feeding, admitted outside, where actually received some oxygenation therapy. The work of breathing increased and then subsequently intubated and had a 1 episode of GTCS and subsequently sent to us. So at admission, child was kind of an okay, heart rate was fine, ventilated, 15 on 6, that means 15 plus 6, that means 21 total pressures on 6. FiO2 was for 80%. Blood pressure were okay for a child of a 3.5 kg and saturation was good. So other things were looking fine. There was no kind of any murmur. So, but before the child got kind of a problem, the child had a murmur. Anybody can tell why the murmur disappeared here? Which was there before the child had a pneumonia. Now the murmur disappeared. Anyone? Can murmur disappear PDA if it is there before? Either PDA is closed within 3-4 days, that's why it is disappeared, but it is not, because in a PDA, it is a left to right shunt. And whenever you have a pneumonia, your pulmonary vascular resistance will go up. And because of that, there will be an equalization of some pressure and this will go down. So that's why whenever you see there was a PDA before and the murmur is disappearing, that means the lung pressure are increasing or pulmonary arterial hypertension is happening. So definitely this is a respiratory failure. Yesterday I told you non-elective mechanical ventilation. So respiratory failure, decompensated shock. So the child was on meropenem, so continued meropenem. Levipil was given for seizures. Can you not touch that, please? Okay, empirical oseltamivir at that time, the H1N1 was very prominent. Okay, so we put the child on PRVC mode. Epinephrine, norepinephrine was required. 1 minute, just click on that. So this is a chest X-ray. You can see definitely a little bit of hyperinflation on the left side. Right side upper lobe, there is a pneumonia. And FiO2 was 60%, tidal volume was around 25, PRVC, PEEP of 5. These were blood gases, looks fine. CO2 was a little bit low, so we came down on the rates as well as tidal volume. And WBC counts looks on the lower side, probably kind of we are dealing with the viral, CRP was negative. So echo, there was a small ASD PFO, hyperdynamic circulation, nasopharyngeal swab came, human metapneumovirus positive and cultures were sterile. Because of the brief seizures, we wanted to make it sure that we are not ruling out meningitis. Already child has received, so CT was done, which was okay. So continued on mechanical ventilation, peak pressures were around 30 to 32, very high, FiO2 requirement 70 to 80%, and intermittent CO2 was getting high, and the child was having desaturations, which is quite commonly we see in any bronchiolitis or viral pneumonia. So because of that, and upper lobe, are we dealing with, there is a left-sided hyperinflation? Are we dealing with some congenital malformation because child had all those kind of a tissue, which was done, nothing else, but you can see prominently, there is a moderate pH. So remember, pH doesn't mean that you have to treat, but any pneumonia will have some pH, okay? So this was on CT, will not go in detail of that, you already. So what has happened is day 3, child started worsening. So leukopenia, high fevers, antibiotic were upgraded, CRP went up. So specifically, we are dealing with something hospital-acquired infection, or the child had a viral harboring some bacteria, which has become difficult. So you can see the things started worsening, FiO2 went up, rate, PEEP, everything went up. And X-ray became really bad. So it could be a mucus plug, but fever, all those things such as go is in a favor of this one. So over the time, you see day 3, 2 blood gases were there, and these are the ventilatory settings. So you are on 50% FiO2, went down to 100%. The PF ratio, which was almost kind of a 200 here, went down to 70. Okay, because 100% FiO2 started keep on de-escalating. So you can see it is going down. But then day 5, almost you can see we started high frequency oscillatory ventilation. So you can see frequency of 8, map of around 20, amplitude of 65, which is reasonably a very good setting for this child. But still, what you can see is there is a metabolic acidosis building up, hypoxia is there, and CO2 has started up. So here, what has happened is because of all those things, refractory hypoxemia, high frequency oscillatory ventilation started. In spite of that, there is not much of an improvement. So what has happened, we started inhaled nitric oxide. But in spite of inhaled nitric oxide, the things were almost same. And oxygenation index went into 70. So I have a question. Oxygenation index on INO and without INO. Is there any difference between the two? So one thing I wanted to, whenever we are talking about oxygenation index, anywhere in any book, we are off inhaled nitric oxide. So in the book says if the oxygenation index is more than 30 to start high frequency or whatever ECMO, it is without inhaled nitric oxide. And if you're having the same situation with the INO, that means things are really, really bad. So none of the guidelines consider inhaled nitric oxide with any conventional ventilator. Now we can give inhaled nitric oxide with conventional ventilator also. So because there are delivery systems are different. So it is without that. So what I wanted to say is here is the actual child became refractory hypoxemic. At the same point of time, CO2 removal is requiring a lot of pressure. So either it could be worsening of a pulmonary arterial hypertension and lung. And you can see lung is become bad. So what I can do? We have prone this child. So usual escalation ladder in this ARDS patient is what we do is we do a conventional ventilation. When we call it the conventional ventilation fails, I'll talk about it, but anybody knows when we say, okay, this is the maximum I can go, or we can keep on dialing the pressure. Conventional ventilator also gives 60, 70 pressures. Na? You do AMBU, na? How much pressure AMBU generate when we are doing it normally? Anyone? 40 to 60. If you're doing it one hand, it reaches around 40. And if you're doing it two hands, it reaches 60. So 60. Anybody has seen any patient on 60 pressures on ventilator? No. So there are some limitation of ventilator. Most of the time, what we do, we do a P plateau. Anybody know what is P plat? Plateau pressure P. Very good. Very good. So what happens is there is a peak pressure and plateau pressure. So when the ventilator delivers the air inside the lung, the pressure will go up. But this pressure is going up, but this pressure will get disseminated. This air will disseminate into the lung. It will go into the alveoli. And after some time, because alveoli are a little bit distensible, so peak pressure will be very high. Let's just imagine a peak pressure is 30. After sometimes it gets disseminated into the lungs and alveoli, the pressure little bit comes down. That is called the pressure seen by alveoli or the pressure experienced by the alveoli is called P plat. And that is more important because in asthma, there is an obstruction. So peak pressure might be very high because you're trying to push the air inside, but the P plat might be less. So P plat is the pressure seen by the alveoli. So everything depends upon the P plat. Okay. So what happens is we try to maintain or do on conventional ventilation when the P plat is less than 28. But once it goes more than 28, that means we are having a failure of probable conventional ventilator. But the second thing, how to help them? If we don't have high frequency, we prone them. We'll again talk. I'll talk about guidelines also a little bit. We prone them. And if the proning also doesn't help, then we think about high frequency. High frequency is not a diamond in the crown. When I can't see anything, I am pushing on the wall, then I tried. I just buying some time so that I can help this child, or I might consider doing ECMO. So this child, when we have a refractory hypoxemia, what we can do? I have tried everything, inhaled nitric oxide, everything. So there is a severe ARDS, refractory hypoxemia, OI is bad, shock is also there, epinephrine, norepinephrine. I'm not able to have. And echo is there is a RV dysfunction, moderate TIA, severe pH, lactate is increasing. So how I can help this child? This child is going to die. I cannot do anything. So then we made the decision to put this child on ECMO. So we put an EVA ECMO. So again, you can consider there is a two type of ECMO. VV. What is VV? Veno, venous. So we are not bypassing. So we are not bypassing heart as well as lung. What we are doing is we are putting an extra thing into the body. We are oxygenating and putting the blood back into the. So what happens is let's just imagine femoral artery. We are removing the blood. It is getting oxygenated. It is going into the RA. The blood still has to go to the RV, still has to go to the lung. But the blood which is going into the lung is oxygenated now. Okay. But in a VA ECMO, what happens is we remove a blood from here, we bypass both heart as well as lung and put it into the artery. Got it? Again, small time. So we tried, again, there are some specification, pediatric ECMO circuit, VA ECMO. So what we tried from both. Right carotid, we put a cannula which goes to the arch of aorta and one internal jugular vein. Okay, IJV. So we did that, and there is a lot of team involved in that. This was the cannulation. You can see the child is on very high doses of inhaled nitric oxide. There is a high frequency going on, all those things together. So child was put on. So immediate post ECMO, he had a child has a stormy course, good flow, things were fine, we were happy, and suddenly flow started going down. So when the flow started going down, without going into the much of a physiology, there is something wrong. That means I'm not able to kind of suck enough blood and give enough blood into the body. So there is something happening, something wrong. And the child started having hypotension, because if I bypass heart and lung, I should feel a little bit better. Oxygenation is better, heart should become better, but it was not happening. So we give a lot of saline and all those things, still the things were not improving. So hypotension. So we were saying what exactly happening? And then we identified there is some issue. Then we did an echo. So what is happening echo? You can see this is an RV, this is an, and what is there here completely? There is a hemopericardium, huge. It might be during the procedure or something like that. You can see there is a huge blood around the heart, and you cannot see the ventricle at all. So what we did is immediately our cardiologist came, and then we put a pictal catheter, and after that we could see the heart is a little bit better. All those things started going down. So this was that pictal. It is very difficult to put a pictal in this child. The reason is you are fully anticoagulated. You can bleed anywhere you prick, they will bleed. So then we got these things. The things started improving. So gases, immediately after ECMO, you don't, what you do, you giving a rest to the lung. You are giving just minimum pressures. Just imagine just in your mind, something very, very minimal. We don't want to stress the lung, just to keep the lung open, because everything is done by the ECMO. That is the reason I wanted to give a rest to the lungs so that the lungs improve over the time. So they are different. PO2s are really bad and the lungs become really bad if you do an X-ray. See, this is the bad lung, but we are able to maintain the oxygenation, blood pressure because of all those things. Okay. So we were fine that we are able to achieve. So we don't want to achieve 100% saturation. Everything in the body is DO2, VO2. That means if my delivery is fine and my utilization is fine, I'm fine. Okay, I don't need 900 saturations. Okay, so here child was having normal acidosis, no lactates and all those things. So we were happy. So we are able to achieve, you can see all those things. There are child had a multiple issues and we were ventilations, and subsequently there is a little bit of improvement in the lungs over the time. You can see initially it was completely white out, some lung is improving. We did a bronch and saw, so peak pressures were a little bit better. Ulta ho gaya. So we tried to give this child to ECMO off trial. Off ECMO trial means try to come down on the ECMO flow or stop the oxygen on the ECMO. Okay, but child was not persistent CO2 retention. Then we said, oh, why persistent CO2? So conventional ventilation to remove the CO2 is a high frequency is a better option. But we were wrong. We should not do that. The whole aim of ECMO is it should come on the minimal ventilatory settings and I should be able to take off. But we gave a trial. We are able to achieve the CO2, but we felt really uncomfortable and putting child off ECMO on this one. So this was a trial of this, and lungs was little bit better, plus minus on the day 13 and day 20. It takes long time. Other issues child had all over the ECMO, those are different. And then we can see on day 20, so lungs is much, much better. We are on minimal settings, cultures are sterile, things were fine. So this was on the day of decannulation. We are thinking really good. So pH is good, oxygenation is good, and the flow, ECMO flow. It is very difficult to understand ECMO in a short span of time, but this is a minimal kind of a support we were giving to the child. Okay, so minimal respiratory, minimal cardiac support, and child is maintaining. And if we wanted to see off ECMO, what we do, the two lines which were going here, we just clamp them. So there is no blood coming out and going in. So child is off ECMO. Okay, so we did that trial. And when we do that, we intermittently keep on opening up so that the cannula doesn't clot, and the child success. So we successfully, this was the place of a cannulation. We successfully decannulated this child. This was immediate post muscle relaxants and all those things were there. So your peak pressures were 19, FI it is 45%. So we are happy. Okay. So we were fine post decannulation. We were happy. Peak pressures were good. Oxygenation index came down to 3.3. But the child subsequently had some, again, post decannulation, this tube which was there, things were fine. So we removed this pictal pericardium, SCT normalized, things were good. But child had a extubation failure. Most likely that was because of the negative intrathoracic pressure. The child was having some upper airway kind of an obstruction, and probably there was a PDA because lung pressure came down now. The PDA became more active. So child had an extubation failure. This was the first extubation. And then there was an extubation failure within 12 hours. Child started being bad, lung became bad. We have to intubate. And then what happened is we identified this is mainly because of that negative pressure and PDA. So negative pressure pulmonary edema. So manage with this. And then we did a PDA closure. This was again a challenging PDA closure because we require a very small device. So you can see their small device here. PDA closure was there. And then subsequently child was extubated. So we had a good ECMO experience about that. But rather than going into that, we have a complex of patient. We did a eCPR, VA ECMO, VV ECMOs, and all those things. We'll talk about it. So this is a situation when we call VA. What is the goal of an VA ECMO? Is very simple. So we are giving rest to the heart and lung, and the heart lung function is done by some other machine. But there is a difference. There is a difference between the ECMO machine and heart. What is the difference? Anybody? So heart is a pulsatile structure. So there is a systole, diastole, but ECMO is not like. ECMO is like your cooler pump, continuous structure. So it's not like that. If you completely stop the heart, put the child on ECMO, you will not see systolic and diastolic. Unless and otherwise heart start contracting, you will see a single line. Example, sometimes if you are having an exposure to cardiac surgery, go into when they put the person on cardiopulmonary bypass, they don't have systolic, diastolic blood pressure. It is straight line. It's a mean arterial blood pressure. Okay. So this is the problem with that. And it's not physiological. Our vessels are not meant for a continuous centrifugal force. It is meant for this. If I keep someone on ECMO for a longer time, I will get systemic inflammatory response syndrome because the endothelial cells are not meant to take the continuous flow. So there are different kind of things you see, but this is the thing. Extracorporeal life support is one is extracorporeal membrane oxygenation. It could be VA and VV. What is VA is we are removing the blood from vein and putting the blood to arteries. That means bypassing heart and lung. VV means I am not bypassing, but I'm oxygenating so that the blood going into the lung is oxygenated. Then what is interstitial lung disease? Interstitial is just I'm bypassing the lung. Okay, most of the interstitial lung disease, they don't have a pump. What happens is we put one cannula into the pulmonary artery. So heart pumps blood into the pulmonary artery. Through the cannula, blood will go into some circuit which will oxygenate and give remove carbon dioxide, and the other cannula is into the left atrium. So that heart is functioning fine. I am just bypassing the lung. No pump, heart is pump, membrane oxygen. And then we have a VAD. VAD means there is no lung involved. It is just supporting any of the right ventricle or left ventricle. Okay. When to start ECMO? So there is some score called as a Murray score. You don't have to go, but what is important is there is a PF ratio, chest X-ray, PEEP, and compliance. PF ratio, chest X-ray, PEEP, and compliance. And then there is a scoring system. Something 3 and 4 is really bad. Okay. When to start ECMO? So previous 90s indications were different. Severe respiratory failure, very, very sketchy. Cardiac arrest, failure to thrive. But over the time, people started realizing if I put everyone on ECMO, what will happen is whether they are going to come out or not, we don't know. And then will be a loss of resources. So what has happened is ESL was given good indication. Whatever there is in the red is the most important red bracket. So hypoxic respiratory failure, consider PF ratio less than. So start considering if you have some patient in your unit whose PF ratio is 100 and you are given enough time, 6-7 hours. So start thinking this is a child who might require. Starting early ECMO is really important within 7 days. If you start late, it doesn't help. So consider it's a definitely an indication if it is less than 100 for 6 hours. CO2 retention, despite PPLAT more than 30. As I told you, PPLAT less than 28, it's really bad. Severe air leak, you have multiple air leaks. You are not able to ventilate because they are kept on having a leak. Lung transplant, you are thinking about there is a pulmonary arterial hypertension in a child. Immediate cardio. So we know that there is some normal person has immediately collapsed and is not getting revived. It is okay to put them on ECMO because they have a good survival. There are no contraindication as such, but there are relative contraindications. There is a high pressure ventilation. Most important contraindication is brain. So there is a severe brainstem dysfunction. There is a huge anticoagulation that you cannot put, like a dengue. They are bleeding from everywhere. I will not put them on ECMO. Okay, so these are relative, and absolute is any which we cannot use anticoagulation. There are certain patients who had some other issues like factor 5, factor 8 lead deficiencies, and they're bleeding, and we cannot anticoagulate them. So virtually no absolute contraindications. So there are few relative contraindication with the poor. So more than 7 days. Remember, this is really important, which we can actually really control. Immunosuppression, CNS bleed, major CNS damage. I would not offer ECMO specifically in the Indian case scenario. Poor outcome is you have multi-organ dysfunction, age. Those are all. So again, when we have hypoxemia, and cardiogenic shock. So this diagram is very important. So you have a hypoxemia, you are not maintaining oxygen, and shock is there, and all other heart failure things are you have optimized. So this is we know. So your lung is also bad, your heart is also bad. So we know arterial, but there is no shock. There is no shock, or you are able to control the shock, and mainly it's a hypoxemia which is causing the cardiac dysfunction. Then you'll consider veno-venous. So there is no need to bypass, because it's a huge deal. Because if there is a small even bubble goes into the artery and goes into the brain, it's gone. So then if you have only refractory hypercarbia, and though there is no hypoxemia, with hypoxemia, you'll consider veno-venous. And this is, but there is a without hypoxemia, then there is a something called as which is like a dialysis, which is we are not doing it. It is just to remove the CO2. ECOR, they call ECOR. Indian context, there are so many things important. Is patient is sick to initiate the ECMO, organ damage. When we talk about ECMO, it takes at least a couple of hours to start initiate the ECMO, reversible, irreversible, all those things are important. And another thing is in ECMO, there are 3 indications. So first is recovery. Like I'm putting the child on ECMO to have a recovery. Second is or transplantation or decision making. So it's not possible in India for a decision making. I cannot waste so much of money. So mainly I would put the child on ECMO for recovery. I know that this child is going to recover and the child has no other organ damage and all those things. Then I will put the child on ECMO. So don't go into the detail. The only thing I wanted to say, there is a huge history of ECMO. The only thing which has percolated ECMO all over the world is H1N1 pandemic, 2009, which has helped us to keep this. And now about high frequency conventional ventilation and ECMO, there are no studies. There are so many studies, no into detail. Nobody has shown that ECMO is better than conventional ventilation or ECMO is better than high frequency or inhaled nitric oxygen. No studies. And I have completely, so this is about ECMO versus conventional mechanical ventilation. There is no difference in the survival. And yeah, done. I will come to that main. So most of the studies are not suggestive of any improvement in ECMO. So now studies showed any adult or pediatric, but better to start in the first 7 days. Most studies were ECMO and conventional ventilation. There are no studies of high frequency and ECMO. Adult has stopped using high frequency oscillatory ventilation. So this is the most important thing I would say. So if you see high frequency, no benefit. Okay, harm in the adult ARDS or small pediatric RCT. Consider high frequency. When to consider in ARDS is if the P plat is more than 28. That's it. There is no advantage of high frequency or conventional ventilation, but most of the time it helps us. That's why we use it. So same thing about, prone positioning also. So though there is a little bit of reduction in the mortality, it can be considered early rather than late. And whenever you are considering 16 to 18 hours. Same thing about INO. There is no meta-analysis, nothing, but we use it because we use it to take a decision whether we can put the child on ECMO. So this is the crux of the story. Prone positioning, high. When to try? Prone positioning, moderate to severe ARDS with conventional ventilation or high frequency, you can try. High frequency, moderate to severe ARDS with P plat more than 28. I know ARDS with PAH or RV dysfunction, then you try it, otherwise doesn't make sense. And after starting, I know within 20 minutes, you'll come to know whether it's helping or not. Early or late, prone, and most likely early, high frequency, and I know late. Mortality benefits, nobody has shown mortality benefits except prone positioning. Oxygenation benefits, all of them have oxygenation benefit, but no mortality benefit. Reduction in the mechanical ventilation, no. And PICU stays, no. So definitely here, this makes the kind of a very important strategy as compared to other. Thank you.
Thank you, Dr. Parag, for this incredible presentation and yet again teaching us with important points in ECMO. we are running late and we will be switching over to our next section, that is pediatric nephrology. I would like to invite our pediatric nephrologist, who is a specialist and a very good friend of mine, Dr. Sindhu Kaza. Madam is going to talk about approach to hematuria in children. Uh, Followed by that, our section on dialysis and critical care nephrology will be taken care by Dr. Suman. Sindhu ma'am.
Good morning, everybody. Thank you, KIMS Cuddles, for this opportunity. Always happy to be a part of you. I'm Dr. Sindhu. I'm a consultant nephrologist here at KIMS Gachibowli. So my topic is simpler than Dr. Parag's, but it's a very important topic. And hematuria, the definition of hematuria is blood in urine. Okay, it's a very disturbing sight for both the child and the parent. You need basically a theoretical knowledge and experience to handle a patient with hematuria, nothing major like understanding physiology and all, but you need to know what is behind it to approach to the patient. So my topic will go as definition, assessment, and approach. So what are the objectives of my talk? So first thing, it is important to establish whether the hematuria is a significant medically or not, because all hematurias are not. The second thing is, when should a primary care doctor refer the patient to the specialist nephrologist? And third thing, most important thing is unnecessary, not to subject the child to unnecessary and painful battery of investigations when you see a blood in urine. So this is, everybody knows about this. The cause of hematuria can be anywhere from kidney, urinary tract, bladder to the urethra. So there are two types of hematuria. One is gross and one is microscopic. Meaning, gross means it's visible to the naked eye. And microscopic means patient's urine will be normal and you'll only be seeing the blood cells in the microscopic examination of the urine. So this is a gross hematuria and this is microscopic hematuria. Simple. First, you should know that hematuria is of two types, a gross and microscopic. So gross hematuria is visible to the naked eye. So what is the color of the urine? It can be red, it can be pink, it can be brown, tea colored, smoky urine. We'll come to all those types. And cola colored urine. So the color of blood does not signify the amount of blood loss. It means if you say it's more brown, it doesn't mean the patient is bleeding more. If it is pink, it doesn't mean the patient is bleeding less. Because as less as 1 ml of blood in 1 liter of urine can change the color of the urine. So never go by the color of the urine because this is more clinically significant. Okay. Now, microscopic hematuria, like I told, in this, the patient's urine will be normal, but your microscopic examination will be showing RBCs. So are all RBCs microscopic hematuria? No. Up to 5 RBCs can be seen in the urine. Anything more than 5, more than or equal to 5 RBCs per high power field is the definition of microscopic hematuria. And one sample. See, microscopic hematuria, patient will not have any complaint. It is incidentally detected when patient comes for some other problem or when you do the urine examination. So just don't jump to conclusion by seeing one microscopic examination. You have to confirm it in at least 2 samples. Okay. And microscopic examination of the urine is gold standard, how you diagnose the microscopic hematuria. So when you see microscopic, does that mean it is not significant? No, it is also significant. Now, hematuria, first important thing, whether it is gross or microscopic. Second thing is the hematuria can be transient, come and go, or it can be persistent. And hematuria can be symptomatic and asymptomatic. Patient might have blood, but no complaints. Patient might have complaints. So first we have to see whether it is gross or microscopic. Next, whether it is persistent or transient. Next, whether it is symptomatic or asymptomatic. Okay. Is blood the only reason the color of the urine changes? No, there are many other causes. The most common causes are pigments from drug and food. Can you name some foods which cause color in the urine? Exactly, beetroot and dye, the coloring agents which we use in the food. Any drugs you know which can cause change in the color in urine? Rifampicin, nitrofurantoin, antimalarials, chloroquine, bladder sedatives, phenazopyridines. Okay, these are the common drugs. Okay. And metabolites. What are the metabolites, you know, which I have put some pictures, you can guess. Metabolites. Homogentisic acid. You see the black color of the urine, alkapnuria, okay, porphyrias, okay, melanin sometimes. Your bile pigments. You see yellow color urine in patients with jaundice. So there is some metabolites. And hemoglobin and myoglobin. Hematuria is an intact RBC. Sometimes there might be hemoglobinuria, free RBC. The hemoglobin RBC is lysed and you can have hemoglobin in the urine. And the other one is myoglobin. So this is very important thing because I think most of you might also have experience when you eat beetroot, you suddenly see your motion is pinkish colored, your urine is pinkish colored. So don't jump that all colors are blood. So you need to have an idea that blood in the urine, the color of the urine can be these simple reasons like food, drugs, and some important reasons we have to evaluate. So what is the initial step? So whenever you have a patient with hematuria, the first thing is dipstick, which can be done bedside, okay? The dipstick is very sensitive test. So if it is negative, it reliably rules out your hematuria, okay? So dipstick is either positive or negative. So only 3 conditions where your dipstick is positive is blood, hemoglobin, myoglobin. That's all. Remember these 3 things. Your all pigments, metabolites, your dipstick will be negative. If it is either RBC or hemoglobin or myoglobin, only these 3 conditions, your dipstick will be positive, okay? So the next step is centrifugation. You have to take 10 to 15 ml of urine, rotate it at 2000 rotations per minute for 5 minutes. Then you see a sediment and a supernatant, okay? So this is a simple table. So once you centrifuge, if you see the sediment is red, it is hematuria. If you see it's a supernatant, which is color change, again, you have to do the dipstick and see whether it is other pigments or whether it is a hemoglobin or myoglobin. So dipstick and centrifugation. So what are the etiologies? So we can divide the etiologies into glomerular and non-glomerular, okay? So what are the glomerular causes? The most important or the most commonly what we encounter or you encounter clinically is a post-infectious or post-glomerulonephritis, streptococcal glomerulonephritis, okay? Then other causes are IgA nephropathy. TBM, what is TBM? I wanted to put it as a shortcut. What is TBM? Thin basement membrane disease. Okay, it's also called as benign familial hematuria. Alports, systemic lupus erythematosus, ANCA vasculitis, HUS, IgA vasculitis, good pastures, and these are the least common causes, FSGS and MPGN. So here, the things which you can see in asterisks, they are the things which can cause, like your IgA nephropathy, thin base membrane, Alports, they can present as recurrent hematurias, okay? And the other, some can be familial, like your Alports can be familial, thin basement membrane can be familial. Some things are only related to kidney, like your IgA nephropathy. Some things can be systemic, like your SLE, IgA vasculitis, okay? The non-glomerular causes, this is also, I have put it in the order of most commonly seen things. Urinary tract infections, most common causes of non-glomerular hematuria. Trauma, irritation to the meatus or perineum in small children because of your bubble baths and using of soaps and all. Nephrolithiasis, stones, exercise. What is CACOD? So what all you see in that in children? Vesico-ureteric reflex, posterior urethral valves, polycystic kidney disease, okay, renal dysplasias, etc. Hypercalciuria, drug-induced hemorrhagic cystitis. Can you name the drug which can cause hemorrhagic cystitis? Cyclophosphamide. Any other drug? Infection. Okay. There is something called as eosinophilic cystitis, secondary to your NSAIDs. It can also sometimes cause hematuria. Okay. Nutcracker syndrome, bleeding problems like hemophilia or hemoglobinopathies like sickle cell trait or disease, tumors, Wilms tumor, especially in children, renal cystic disease, and tuberculosis. These 2 slides are the most important slides in the entire talk, because if you know the causes, then only you can take the history, then only you can evaluate. If you don't know the causes, you don't know what to evaluate, what to take the history. Okay? Because if you know the causes, then you'll ask family history. If you know the causes, then you'll ask any drug history. You'll ask any systemic manifestation. So these 2 slides are very important, the glomerular causes and the non-glomerular causes. Okay. Sometimes, despite extensive evaluation, no etiology will be found. Okay. And you have to remember that the blood source of blood can be the other tracts also. like the vagina or the rectal fissure. So never forget to do local examination. Okay. So the causes of hematuria in newborn are a bit different. The renal vein thrombosis, renal arterial thrombosis, polycystic kidney disease, the obstructive uropathies like our posterior urethral valves, urinary tract infections, bleeding and clotting disorders, trauma. Okay. So like I told you, the hematuria can be persistent and transient. Usually the common causes of transient hematuria are urinary tract infections, exercise and trauma, whereas persistent are glomerulonephritis, hypercalciuria and nutcracker syndrome. So can anyone define what is hypercalciuria? How you diagnose hypercalciuria? What do you do? Yeah, no need to do 24-hour. Calcium creatinine ratio is good enough. So how much should be the ratio to tell it is? More than 0.2. Okay. What is nutcracker syndrome? Which renal vein? Yeah, left renal vein between and aorta. So what will be the nutcracker syndrome? It can be present as gross hematuria. It can present as microscopic hematuria. Patient can be symptomatic. Patient can be asymptomatic. Patient sometimes they can have, especially boys, left varicoceles. Okay. So evaluation, like I said, once you know patient has blood and you know it is gross or microscopic, it is not other reasons like your pigment or drugs or food and metabolites, you are sure this is blood. So you know the causes, the glomerular causes, the non-glomerular causes. Now, then you will know what to ask. The history, the physical examination and the urine analysis. Okay. History, like you'll ask any history of trauma. You'll ask any history of new onset of fever, dysuria, frequency suggesting of urinary tract infection. You'll ask any history of severe flank pain with radiation suggesting of a stone. You'll ask any swelling of feet, decreased urine output suggesting of glomerulonephritis. You'll ask any family history, any sibling history, hearing loss, Alport's, thin basement membrane. So you should know the causes very clearly to evaluate the patient further. Okay. Physical examination. The 5 important things which you see in physical examination. First is blood pressure. Okay. Second thing is any edema or something. Third thing is per abdomen examination to see any mass, cyst or malignancy. Okay. Fourth thing, any systemic examination, rashes, purpura, like for your IgA vasculitis, HUS, any purpura or anything is there or not. Okay. Now urine analysis, like I told you, your dipstick and centrifugation. So evaluation of urine sometimes might suggest the underlying etiology and potential sites. So our aim is to differentiate whether the bleeding is glomerular or non-glomerular. Okay. See, most of the times the cause of hematuria is simple and it is obvious with your initial history and evaluation. Okay. The problem comes when it is not. So I will tell you how to deal with them. Okay. So glomerular, extraglomerular, there are some differences. We'll come to it later. See, in glomerular, presence of more than 30% dysmorphic RBCs means you of 100 RBCs, more than 30 RBCs should be of distorted shape and size. Then low you say it, dysmorphic RBCs, or 5% should be a specific cells called acanthocytes. I'll come to it later. Okay. So how do you differentiate glomerular and non-glomerular? In glomerular, the color of urine is red, brown, cola colored or smoky urine. Whereas in non-glomerular, you'll have red and pink urine with clots. Clot is always lower urinary tract. Clot is never a GI glomerular bleeding. Proteinuria, glomerular, it will have significant proteinuria, whereas non-glomerular can have proteinuria, but it is never more than 2 grams. It's always subnephrotic proteinuria. Okay. RBC casts will be seen in glomerular bleeding, whereas non-glomerular will not have any RBC cast. Morphology, dysmorphic RBCs with isomorphic RBCs in non-glomerular bleeding. Dysmorphic means altered shape and size. Isomorphic means all RBCs are of same shape and size. Believe me, your people who are interpreting CUs, this is very important because identification of this RBC cast and morphology requires experience and expertise. Not everybody can do that. Okay. So this is an RBC cast. See this one. RBCs together. So RBC cast is always glomerular. So if you see an RBC cast, it is a glomerulonephritis. Okay. So what these I told, like what are this? The vesicle-like protrusions with ear. This is phase contrast microscope. These are called acanthocytes. Either you should see 30% dysmorphic RBCs or at least 5% acanthocytes. What are these called? Acanthocytes. It looks like a Mickey Mouse. No? Mickey Mouse ears. It's called a Mickey Mouse ears. Okay. This is an isomorphic RBC. So all RBCs are of same shape and size. This is a lower GI, non-glomerular cause. Okay. But like I told, you need an experienced person to identify this. Normally, dysmorphic RBC acanthocytes require, especially acanthocytes require phase contrast, but an experienced person can diagnose it in light microscope also. So don't always believe your CUEs. You should have some experience and expertise yourself too. So how do you approach? Now you know what is a hematuria, what is gross, what is microscopic. You know that hematuria is transient, it can be persistent, it can be symptomatic, it can be asymptomatic. You know the causes, glomerular causes, non-glomerular causes, you know how to differentiate. So how do you evaluate? Do you evaluate everybody? The first slide I told you, no need to subject every child to unnecessary battery of investigations. So how do you approach? So you should know these three things. When the patient is having asymptomatic isolated microhematuria, whether the patient is having asymptomatic hematuria and proteinuria, whether the patient is symptomatic. Compared to asymptomatic isolated microhematuria, asymptomatic hematuria and proteinuria suggests a significant underlying kidney disease. So you should never take it lightly. So first you should come to conclusions of all your initial theory, physical examination, urine analysis. You should come to these three things, whether I should evaluate further or not. So if you see a patient with asymptomatic microhematuria, this table is there in UpToDate and it is very useful. You have to follow it just stepwise. If a patient has asymptomatic microhematuria, you have to first confirm it with another 2 urine samples. Okay. If the patient's physical examination is normal, patient is not having any blood pressure, patient is not having any renal dysfunction, patient is not having any proteinuria, you can monitor like every 3 to 6 months. If it is persistent beyond 1 year, then you have to refer to a pediatric nephrologist for further evaluation. If it is subsiding, so what are the important things here? You see blood pressure, renal function, proteinuria. Okay. If these 3 things are not there, you can monitor the patient once in 3 to 6 months. If it is persistent beyond 6 months or 1 year, you can refer to a nephrologist for further evaluation. If any of these things are there, like I told, so this is the flow chart. If patient has proteinuria, if patient has high blood pressure, or patient has renal dysfunction, you can't just monitor them. You have to evaluate them. So how do you do a protein quantification? Usually in children, 24-hour urine is not needed. Early morning first spot urine creatinine and protein ratio is good enough. Up to 2 years of age, you can take, if it's more than 0.5, you have to evaluate proteinuria, the ratio. If more than 2 years, if it's more than 0.2, you have to evaluate. If patient doesn't have this level of proteinuria and microscopic hematuria, again, no BP, normal renal functions, less than 0.2 grams of ratio, you can follow them up. If patient is having any of the problems I told you, or if proteinuria is significant, like in children, it is like anything more than 4 mg per meter square per hour is significant. Anything more than 40 is nephrotic. You don't wait in such cases. You have to evaluate them immediately. Okay. Now, if patient is symptomatic, patient is already symptomatic, then you have to immediately follow him up. No need like come later. So now, like I told you, you have to go for history of trauma. If there is history of trauma, do a CT scan to see whether there is any significant bleeding from which part and what to do. Any history of urinary tract infection, like recent onset of fever, dysuria, frequency, urgency. In very small children, they might not have these symptoms. You people are more aware than me. They will just present with irritability, okay, decreased feeding and all. Okay. So if it is a urinary tract infection, treat the UTI, follow up the CUE later. Okay. Sense of any local examination is very important to see any signs of meatal irritation, especially like I told you, because of detergents and chemicals, the bubble baths, use of soaps and all. This is just reassurance and symptomatic treatment. If any stone, you have to treat the stone. Treatment of stone is like an adult only. You see what is the size, where is it located, how troublesome it is, whether it is medical management or surgical management. But like in adults, we usually go for CT KUB, but in children, ultrasound is good enough to diagnose and X-ray KUB. But sometimes if it not picks up low-dose CT, you can go ahead with low-dose CT. Okay. Then glomerular causes, hypertension, edema, cola-colored urine, proteinuria, dysmorphic RBCs, refer to a nephrologist. So we'll evaluate further C3, C4, ANA profile, ANCA, and kidney biopsy. Okay. If none of these are there, the other reasons are hypercalciuria. Usually children with hypercalciuria, they might be having family history of stones in their parents or siblings. And these people, they can develop stones in future, symptomatic stones in future. It will take years. It doesn't happen like that. So if it is hypercalciuria, test parents or siblings for hematuria. Okay. Hemoglobin electrophoresis for your sickle cell disease or trait. Okay. The diagnosis is apparent, treat according to it. Okay. So like I told you, red flag signs. What are the red flag signs where you don't tell patient nothing to worry, come later for follow-up? These are the red flag signs. If patient is symptomatic, if patient has high blood pressure, if patient has swelling of urine, reduced GFR, significant proteinuria or persistent hematuria, these are the red flag signs where you should evaluate the patient immediately and no follow-up. Okay. So coming to parent education, the first question the parent will ask is, should they be worried? They need not panic, yes, but they should definitely consult a doctor because you are the one who's going to decide whether it needs detailed evaluation or not. Okay. Should child see a doctor? Yes, definitely child should see a doctor. Will child need test? You know when to evaluate in detail, when to not. Okay. Will child need treatment? Depending on the underlying cause. What problems should you watch for? The red flag signs. Okay, persistent hematuria, declining GFR, significant proteinuria, never ignore. Okay, don't ignore the warning signs.
Thank you, Cindy ma'am, for the crisp presentation. Now, we'll be talking about renal replacement therapy in pediatric ICU. Disclaimer, I'm a pediatric intensivist, not a nephrologist, but I have a special interest for critical care nephrology. So we will be talking about. So in next 20 to 30 minutes, we'll be talking about different scenarios where you'll be thinking in the terms of renal replacement therapy and what the different options we have in the renal replacement therapy. So this a child which we have managed 4 or 5 months back, a 14 years girl child who came with generalized weakness from 10 days, cough from 3 days, and increased work of breathing from 1 day. So she at presentation to ER, she came in hypoxemic respiratory failure and hypotension. So initial blood gas showed metabolic acidosis. You're obstructing the view, Abhishek. You're blocking. Initially, ABG showed metabolic acidosis with hyperlactemia and respiratory compensation. And if you see the X-ray, although it's been obscured by the breast shadow, there is a cardiomegaly with bilateral fluffy infiltrates. It is suggested of pulmonary edema. So this child, initially the child presented in. So we are very clear, right? What we need to do on this situation. We need to immediately intubate the child in hypoxemic respiratory failure and cardiorespiratory failure, in fact, if you ask me. So here, all the child presented in hypotension initially. After initial stabilization, like after ventilation properly, the child started slowly to rise the BPs and went into hypertensive records. And day 1 urea was 91, creatinine is 2.4. You have a HB being 7.2, platelet count 4.5, which is normal, and you have a cola colored urine, and the ASO titers which were sent started to be very high. So do we have any differential diagnosis, or you have only single diagnosis? It is post-streptococcal glomerulonephritis with AKI and hypertensive emergency. Hypertensive emergency because you have a cardiac failure secondary to hypertension. So we didn't had much problem with the, the diagnosis part. Now on day 2, the child had oliguria, not responding to Lasix, and the urea creatinine is elevating. And they went on ventilator, you are requiring higher pressure supports because of significant pulmonary edema she had. There is no urine, not responding to Lasix, your pulmonary edema is increasing. And now you have hypertension also. What is the next step you will think over here? You have significant pulmonary edema, not at all responding to Lasix. You have to go for some, right? Like you have to make some intervention to reduce your pulmonary edema and to improve the AK. So you are going to do something called a renal replacement therapy. So I'll not say dialysis, it's a renal replacement therapy where you have different modalities. For this particular patient, we have started on hemodialysis. That is SLED we started. There is a difference between hemodialysis and SLED. HD is which you done for 3 to 4 hours. SLED is something which you do it for 6 to 8 hours. So here, I'll just show you this child required high ventilator support. This is the dialysis machine. You have a filter over here. The blood will be coming like this. You have a catheter placed on the femoral line, then the blood will be coming through like this, through this line. You have a filter. After filtration, this will come back to the patient. So we'll go a little detail later. So for this patient, we have done SLED. So while we are doing SLED, the pulmonary edema has come down. The lungs are getting better, but meanwhile, she also had ventilator-associated pneumonia. She had different other complications. But even after 10 days of SLED sessions, her AK did not improve. Her creatinine max went up to 9.1, and she had absolute anuria. 10 days of SLED sessions, still the child is on ICU, on ventilator support. There is no urine. What will you do? You keep on doing SLED sessions or HD, or what is the step that we need to do over here? So at this moment only we, Sindhu madam, we have had discussions. So it's been 10 days of SLED sessions. Like what shall we do over here to make the child better? The other mode we can. So here, either if it is an adult, probably since this is not a CKD, this is more of AK, we just thought probably giving a trial of peritoneal dialysis. We are expecting this 10 days, there is no improvement. We thought probably giving a long-term management would be beneficial. Hence, we have gone for a 10 cough PD catheter incision. This is different from the regular PD catheter that we place. This is the 10 cough PD catheter which stays for a longer duration. So we have started doing peritoneal dialysis, and slowly her after 10 days of peritoneal dialysis, suddenly she started to pour the urine very much, and her AK improved drastically. And after 10 days, her AK is completely improved. Urea creatinine completely normalized, good urine output, and we have removed the PD catheter also. And we have discharged on day 24, day 25. I made the presentation very crisp regarding the patient, but she had all sorts of complications. She stayed nearly 28 days in the hospital, where she had all complications, like she had hypertensive emergency and she had status epilepticus, press changes, many other changes, which I'm just skipping of things. So the point which I want to make it over here, initially we started something called SLED for this patient. Soon we changed it to something called peritoneal dialysis. This is case one. This is another case where a 5 months baby presented with acute onset of vomitings, poor feeding, lethargy. And you have on examination, you have something called ketotic breathing, and your urea creatinine and electrolytes are fine, but you have hyperammonemia, which is around 350. So we all know this. What are we dealing with? Probably we are dealing with a case of inborn error of metabolism, most likely, right? So we have given enough fluid resuscitation. We have started on dextrose containing fluids. Still, will you hold with just like fluid management, bicarbonate? If you calculate the anion gap and you plus or minus, you'll give bicarb, you give metabolic cocktail. Do we need to just continue on those aspects, or do we need to consider anything else over here? So how many of you agree that just to continue this management of IV fluids, metabolic cocktail, bicarbonate therapy, how many agree to start on renal replacement therapy for this patient? So I just say that this child he's having an encephalopathy and a very high ammonia levels. If you leave like this, it is going to damage the brain significantly. So here, undoubtedly, without any discussion, this child needs a renal replacement therapy. The question is, which type of renal replacement therapy? Either peritoneal dialysis, and the previous child we have done something called SLED. Here, whether you will go for a SLED HD or you go for CRRT. We'll discuss about this. This is a third case. A 2-year-old child came with dengue shock syndrome and had shock after fluid resuscitation. Also, shock is not improving. Started on inotropic support. Despite starting on after starting of inotropic support, BPs got stabilized, but still the child has developed an AKI and anuria. Nearly she started to have anuria for 6 to 8 hours. There is no urine output, and there is significant fluid overload because you give a lot of fluids in dengue, and there is a significant fluid overload and pulmonary edema, and the child got ventilated on mechanical ventilation. Again, there is anuria. What is the difference between the first case and this third case? Here we have someone, a 2-year child, who has a hypotension, anuria. We have a hypotension requiring inotropic support, and this is a 2-year child. So will we, all of you agree that this child needs renal replacement therapy, or you just want to continue on ventilation? You have no urine output. You have progressive increasing AKI. So we need to consider renal replacement therapy. Again, the question comes, what type of renal replacement therapy you want to consider here? Either peritoneal dialysis, hemodialysis, or continuous renal replacement therapy. So that is what we are going to discuss in next 10-15 minutes. So the main objectives would be looking for what are the indications for renal replacement therapy in ICU, and what are the pre-RRT management that we need to do. Third, what are the different types of RRT, and how do you choose a renal replacement therapy? So indications, you have something called renal indications. Renal indications is you have AKI, to which AKI, if there is persistent hyperkalemia or persistent metabolic acidosis less than 7.15, or you have a high urea levels, which is causing the complications like uremic complications, or if your urine output is oliguria for 24 hours or anuria for nearly 12 hours, or you have a fluid overload, which is not responding to the diuretics. These are the renal indications for a renal replacement therapy. Non-renal indications for renal replacement therapies, you have hyperammonemia, refractory acidemia not managed with medical management. You have poisoning or severe sepsis with septic shock. A bridge to liver transplant would be the non-renal indications for renal replacement therapy. You have something called urgent, like you don't wait much for the treatment. If you have severe metabolic acidosis, cardiac dysfunction, not responding to medical management, or severe hyperkalemia, pulmonary edema on ventilator support, or you have uremic complications, this is the time you will think of, we need to start renal replacement therapy as soon as possible. Probably this one slide is the most important slide of all the slides that we see, that is pre-RRT management. Before you think about the renal replacement therapy, you have to do primarily few other steps so that your renal replacement therapy is needed or not to decide on. So if you have, you need to optimize your intravascular volume status. You maintain good map so that your renal perfusion gets better. But if you have some hemoglobin being less, you correct the hemoglobin. You avoid nephrotoxic drugs or renal modify the drugs, and you reduce the more the fluid overload, the more the load, and it will cause renal failure further. So reduce your fluid overload %. So this is how you do pre-renal RRT management. Types of RRT, you have a peritoneal dialysis, intermittent hemodialysis, which has got both H hemodialysis and SLED. Third, CRRT. These are the different modalities. Now the question comes, which to be used in different scenario. So principles are different. We got diffusion, ultrafiltration, convection, absorption. I'll miss this. If you want to have a solute transport, you need to have this mechanism. Solute, you need ultrafiltration. So this slide, I'll tell you. So normally you have something called smaller molecules, middle molecules, and large molecules. Smaller molecules are water, all your electrolytes, metabolic acidosis, your urea, ammonia, or smaller molecules. So if you want to clear smaller molecules, you need a mechanism which has a diffusion. Like you have it for peritoneal dialysis, hemodialysis, and CRRT. Both has a concept called diffusion. If you want to remove the middle molecules and large molecules, you have to choose a mechanism which has got a convective clearance. That is predominantly seen in CRRT. Right? So you have to choose for what you are doing the renal replacement therapy. So PD, we all know it works. PD, I'll just tell you about what are the, it works on the principle of diffusion and ultrafiltration. So how does it help? It takes out, if you have a fluid overload, you can do peritoneal dialysis. It removes the water, number one. Number two, you have electrolyte disturbances, severe metabolic acidosis, or you have something called hyperammonemia, only the urea being high. These are the indications because these are all small molecules, right? All the electrolytes, metabolic acidosis, and your ammonia, all small molecules, all can be cleared by peritoneal dialysis. So you can choose this as a modality if you have these sort of problems. The main advantage would be it's very easy to initiate compared to hemodialysis and CRRT. And what do you call it? It's a very less cost. And in children, you have a large peritoneal surface and it works really well in compared to the adults. And the most importantly, you don't see this type of rapid shifts in dialysis disequilibrium. If you have a rapid osmolar shifts like you have in HD, then you develop something called dialysis disequilibrium syndrome, which you don't see in peritoneal dialysis. So since it is a low cost, can be managed anywhere. All of our ICU sisters know, most of us know like how to manage PD. So it is a reasonably good option. Probably when you will not consider much is if you want to clear it rapidly, very rapidly, then that is the time which you will not consider peritoneal dialysis. So it will clear slowly. Your clearance of solutes or clearance of water will be slow in peritoneal dialysis. And if you have on top of it, if you have something called multi-organ dysfunction syndrome or shock, where your renal perfusion will be compromised, the PD efficacy will come further down. So the important point which I want to make it on peritoneal dialysis. So hemodialysis, so it works on the principle of diffusion. Diffusion, you know, it moves from higher concentration to lower concentration. And then ultrafiltration is something which water moves along the pressure gradient. These are the two principles involved in hemodialysis. So basically you have something called, this is an adult picture. So blood flow, this is arterial which flows from one side. The blood will be coming through the filter. There will happen some mechanisms and after that, the blood will be returned. So here you both diffusion and ultrafiltration will happen in your filter, simply. This is a dialysis machine, this is a filter. So complications, so most dreaded complication that we are feared for starting hemodialysis. I think most of us here, we don't do much of dialysis for small children. Reason is you have a very less blood volume. The moment you take out the blood volume, it goes into the child goes into the hypotension. So most dreaded complication is intradialytic hypotension. Second is there is a rapid osmolar shifts which leads to dialysis disequilibrium syndrome. That is the reason if you ask me in an infant or smaller age group, I will not be that comfortable in starting a hemodialysis. So hence, but comparatively advantages, but if you want to have a rapid removal, yes, if you want to rapidly remove the water, solutes, HD works better than CRRT and peritoneal dialysis, but it has got its own disadvantages. Third, we'll talk about CRRT. We have next session on the same topic on CRRT, so I'll not go details. So what is CRRT? It is a slow removal over 24 hours in a day. It continuously runs. You have a very minimal blood flow, very slow removal of the solutes and water. Water, if you want to remove more, you can remove it. If you want to remove slowly, very slowly, you can do it in CRRT, where you in HD you will not be able to do. This is a continuous process where you will remove the water or the solutes very slowly. It's a continuous renal replacement therapy. So hence your hemodynamic stability is much better in your CRRT compared to hemodialysis. So these are the basic components. This is the machine where to which this is a separate filter. And as I said previously in HD, you have something called dialysate fluid running from the water source, that is an RO. From the RO, the water goes into the filter. So it's a simple, and so hence your cost will be very less in hemodialysis. But whereas in CRRT, instead of RO, we'll be using something called Prismasol bags, a separate filled bags, which will be hanged over here. You have a filter fixed over here, the bags filled over here. The both will go in opposite directions to the blood flow, the dialysate and effluent. So this is for this maintenance of the filter, you need to do something called anticoagulation, and you need to place a big catheter onto the femur or the IJV. So this there are different types of CRRT. The most commonly used modality is CVV HDF, which I'll not go through, but just going through. This is a filter, right? So there is something dialysate which runs in one direction. There is a replacement fluid runs in other direction. So through which both the diffusion, ultrafiltration, and convective clearance will be happening. You don't need to know the complete details, but just I'm telling you. So for a prescription, I'll skip the prescription part. So this again the slide. So in comparison, you have a PD, you have hemodialysis, you have CRRT. So if you have, again, if you want to remove small molecules, both your peritoneal dialysis, hemodialysis, and CRRT works. If you want to remove middle molecules like inflammatory markers like IL-6, there are tumor necrosis factors where your inflammatory syndrome is very high. That is the point you'll think in the terms of CRRT, not HD or peritoneal dialysis. If you have hemodynamic instability, someone is in shock, so your HD is out of option. Right, your options would be either peritoneal dialysis or continuous renal replacement therapy. For PD, you don't need any anticoagulation. For CRRT, you need anticoagulation. If you are using SLED, which is done over 8 hours, then you might need anticoagulation. So cost, the main important factor would be coming finally is a cost factor. Peritoneal dialysis is cheaper. HD is relatively cheaper compared to CRRT. CRRT is costly. If you ask me how much cost, if you're starting for a 10 to 15 kg child, a CRRT, the cost of only the bags, a filter together, it makes around 30 to 35,000 per day. That would be the running cost for a CRRT. So with this, we'll come back to the same scenarios that we have started initially. So here, this is a child who had suspected IEM with severe metabolic acidosis and hyperammonemia. So we will start on renal replacement therapy. Everyone will agree to it. Now, question is, which renal replacement therapy you want to use? You want to use hemodialysis, PD, or CRRT? This is a small child, very small child. So I'll not use hemodialysis. You have either peritoneal dialysis or continuous renal replacement therapy. But since the child, it's given both the options for me, since both can be done, undoubtedly, both can be done. But if you see the encephalopathy is so significant, ammonia levels are so significant, if you start your PD, for the PD to clear all your ammonia, it may take almost a few hours. And meanwhile, your brain can have more damage. So hence, both the options are okay, but I would prefer to start on continuous renal replacement therapy in comparison to PD, considering only the efficacy part. But to start either of the things, if you don't have an option of CRRT, yes, at least we should not waste our time in thinking about CRRT. We should start on peritoneal dialysis. So this is the third child who had dengue shock syndrome, aka on inotropic support. Right? So what do you think? What should we consider? What should not be considered? Yes. The child is in hypotension requiring inotropic support. Hence, your HD is out of option. Again, you have hemodynamic dysfunction. Both the options of peritoneal dialysis and CRRT can be considered. But shock, your perfusion to the peritoneum will be very less. So the efficacy will be less. So hence, in this patient also, the preferred option would be a continuous renal replacement therapy. So these are the children which we managed with HD, CRRT, and peritoneal dialysis. So if you have any questions, we can get. So the main take-home message over here we should go is, for what reasons we are thinking in the terms of renal replacement therapy. So when is the time you'll think of renal replacement therapy? So renal replacement therapy or not, I don't think they are, we should not have much hurdles to start on renal replacement therapy. You counsel, you start. You don't have an option, send to a place where you have an options of doing this probably. Right? Any questions? Right. Thank you. I'll call the next speaker, Dr. Avinash, who is a consultant pediatric intensivist at KIMS Cuddles, Kondapur.
Thank you, Dr. Suman. With the in detail understanding of how the functionality of dialysis work and how it is saving lives in ICU, now we are going to our next topic of dengue, coming and complicating as a multi-organ dysfunction syndrome. I would like to invite Dr. Avinash, who is consultant pediatrician and pediatric intensive care consultant in KIMS Kondapur, KIMS Cuddles Kondapur. This very identification of mods and right time to intervene brings in the difference in health of child and his well-being. Dr. Avinash.
So good morning all. So in this session, we shall discuss about dengue with mods. So first we'll see about a case what we managed in our unit. And here is a 12-year-old boy who is admitted with us with fever since 5 days, now febrile since 1 day. He came to us on day 6 of illness, that is day 1 of critical phase. He had pain abdomen, abdominal distension and vomiting since the last 3 days. He has generalized swelling all over the body since 2 days and decreased urine output since 1 day. He was referred from other hospital on day 6 of illness and outside dengue IgM was positive. He received around 1500 ml of fluid, 1 PRBC, 1 SDP and 2 FFP outside in the other hospital. So this was the vitals during at the time of presentation. His airway was open and maintainable. He's having tachypnea, respiratory rate of around 40 per minute, SpO2 of 90% on NRM, and bilateral decreased air entry was present. And circulation wise, his heart rate was 160 per minute and pulses were weak. CRT was around 5 to 6 seconds and NIBP was around 90/76. Child is drowsy and pupils were equal and reacting to the light. Child is having cold peripheries and GRBS was 50 milligram per deciliter. So based on this, the child is having severe dengue. So child is having respiratory failure and child is in compensated shock with a narrow pulse pressure is present. So the BP was around 90/76, narrow pulse pressure is present. And child is drowsy and GCS is 9/15. So the child is also having this acute onset encephalopathy at the time of presentation. So how we managed this initially, we started the child on NRM, we placed a cannula, we sent investigation, and we started on bolus of colloid of around 10 ml per kg over 1 hour. We initially considered intubation for this child. Whenever we start intubating such kind of children, now we have to anticipate physiological difficult airway as the child is having hypoxia and the child is also in shock. And there is a risk of bleeding is very high in such kind of children. Always maintain a backup while intubating any kind of children. So proper personnel should be intubated. Okay. And once before intubation, the child has to be continued on apneic oxygen and child has to be given low dose of ketamine, okay, to have the less disturbances in the blood pressures, and then go ahead with starting with inotropic support before intubation and go ahead with intubation. And after that, we performed an 2D echo, which was showing collapsible IVC and multiple B lines in the both the lungs. And after that, child was shifted to the PICU. So after shifting to the PICU, his vitals were like heart rate was 160 per minute, saturation was around 88 to 90 and bag and tube ventilation. NIBP was 82/65 and peripheries were cold. And CFT was above 5 seconds and ETCO2 was 52 mm of Hg. Abdomen was distended and bilateral air entry was decreased and we did a catheterization for the child, for urinary catheterization. So we initially started with 70% maintenance of IV fluid, around 70 ml per hour. And 20% maintenance, we started as a 20% albumin. And we started intermittent fluid boluses of 5 ml per kg of 5% albumin to maintain the blood pressure and to maintain the pulse pressure above 30 ml per kg. So then we continued on mechanical ventilation, PRVC mode. We started with a tidal volume of around 300 ml, rate of around 22 per minute. After maintaining an optimal PEEP, I time of around 0.8. And we targeted the driving pressures of less than 15 and PEEP flat of less than 28. We started initially on broad spectrum antibiotics because it is like a different spectrum of dengue. Possibility of sepsis will be high whenever the child is in shock. So we started on broad spectrum antibiotics. We titrated inotropes to maintain the blood pressure of around 90/50 and we monitored intra-abdominal pressure and we started on sedation. 2 hours after admission, we placed in right IJV and right arterial line was placed and hemodynamics were almost like same. Heart rate was 164 per minute. CFT was 5 seconds. Blood pressure was around 94/77 and we started an epinephrine infusion, 0.2 microgram per kg per minute. So we continued on mechanical ventilation. We did an ABG. ABG was showing respiratory acidosis and metabolic acidosis with severe hyperlactatemia is present. Saturations were still 90% only. So till now, he is cumulatively positive by around 2,500 ml after giving multiple fluid boluses and all. Since the last 2 hours, the urine output is just 20 ml in the Euro bag. So these were the labs. So he is having hemo concentration. Hemoglobin was around 16.2. There is a thrombocytopenia. INR was deranged. And acute kidney injury was present. Transaminitis is present. And bilirubin is also elevated. Hepatobiliary dysfunction is present. And electrolytes were okay. And potassium is on the higher side. CRP is elevated. And procalcitonin is also elevated. And coming to ferritin, it is around 14,000. So at 4 hours of admission, we started we monitored this intra-abdominal pressure. It was around 16. In the background of MOTS, we consider the child is having abdominal compartment syndrome, and we made a controlled drainage of ascitic fluid was done by placing a PD catheter, and then we decreased this because the child is having high driving pressures and all. We reduce this tidal volume and all. We maintain this urine output of around. I mean, the child had urine output of around 40 ml, which corresponds to 0.2 ml per kg per hour in the last 4 hours. And the cumulative positive balance till now was 2,700 ml. And ABG was showing even worsening of the gases, like pH is 7.10, and then bicarb is around 9, and lactate is 7.9. Previously, the lactate was around 5, and bicarb was around 12 to 30. So there was worsening of the metabolic acidosis in the last 4 hours itself. So currently, these issues we have with the patient. So the child is having severe dengue, child is having shock with abdominal compartment syndrome. He's in fluid overload state. He's having metabolic acidosis with hyperlactatemia. He's having decreased urine output and acute kidney injury. Coagulopathy is present. Hepatocellular dysfunction is present. Sepsis is present, and hyperferritinemia is present. With all the issues in the background, we, after 6 hours of admission, we started CRRT in this child. So we started with the Prismaflex. We placed an HD line of 12 French and 12 centimeters, and we used the M60 filter. We started with CVV HDF mode, and no anticoagulation was considered as the child is the risk of bleeding is high. We didn't use any anticoagulant initially. We primed the circuit with the saline. We started with the blood flow of 200 ml per minute, dialysate flow of around 600 ml per minute, and then free blood pump of around 200 ml and replacement fluid of around 600 ml. We gave it in the post filter. So initially we didn't target any ultrafiltrate in the patient, and gradually as the hemodynamics started improving, we gradually removed the amount of fluid. So why CRRT, and what does the evidence says in particular cases of dengue? So if you see that severe dengue, so we all know that whenever the mosquito bites, after 3 to 4 days, the viremia starts. Once after the viremia starts, 1 day after this viremia, this fever starts. Fever will last for 4 to 5 days. And once the fever settles, the platelets will start falling down. And that's when the plasma leakage will start. And this phase will last for 2 to 3 days. And after that, recovery pathway starts and complete recovery occurs. If the child follows this pathway, every one of us will be happy. But nearly like 10% of the children, there will be deflection. So they follow the other pathway. So we commonly see like 5 different spectrums of dengue. So the first spectrum is like increased pleural effusion and delayed redistribution. So most of the time with a good amount of supportive care and all, these kind of children will improve over the time. And other spectrum, what we commonly say is like those children who is having respiratory distress, ascites, and increased abdominal pressure. So such kind of children, they also will get managed with adequate fluid management and all. And few children may require this abdominal decompression by placing a controlled drainage of peritoneal catheter and all. Over the time, they will be keep on improving. So other spectrum we commonly see is like increasing pleural effusion and ascites, increased intra-abdominal pressure, and shock with bleed. This spectrum of dengue requires intubation, mechanical ventilation, proper titration of fluid, and proper titration of inotropes, and they require this blood products and all. And over the time, most of the cases will improve. The troublesome 2 spectrum, what we see in our clinical practice is this spectrum. Those children who are having reduced urine output, progression to acute kidney injury very fastly, lactic acidosis, refractory shock, along with myocarditis. This is the spectrum which is very difficult to manage, and this is the spectrum that requires CRRT in the dengue. And we see other kind of spectrum like hyperferritinemia MOTS with progressive liver failure with bleeding. This paradigm usually may become normal or may not become normal. Some will progress to, some may ultimately like death will happen if there's like a disease will be keep on progressing and all. So with all these things, we'll see the burden of dengue viral illness related renal involvement. So the prevalence is around 0.9% in children hospitalized with dengue viral illness. The mechanism is either by direct injury or by the indirect immune mediated injury or by the hypotension induced renal perfusion. So, and the mortality of those children with dengue hemorrhagic fever and dengue shock syndrome with the AKI is more than 60%. It's a 60% is very high. So what does the evidence say? So there are no proper evidence or no proper studies till now saying that when to start CRRT and what are the indications when to start CRRT and what all things to be manipulated, how to adjust the setting. There are no proper guidelines till now. There is no high quality evidence or there is no best practice statements also till now. It all predominantly based on expertise availability, machinery availability, unit familiarity with the pediatric CRRT as well as the dialysis, and financial support that plays a major role while making a decision for CRRT in severe dengue. So as there are no evidence, we have to inculcate the same evidence from the CRRT in the critically ill children. If we go through the indications of CRRT in the critically ill children, as per KDIGO, any children who is having life-threatening changes in the fluid, electrolyte, and acid-based disturbances, they are the potential candidates for CRRT in the critically ill children. So, and one more conference was held in 2020 that controversies in AKI, where it is mentioned that any child with metabolic and fluid demands that exceeds the kidney capacity, that is a shock-like situation where the kidney is not functioning properly and metabolic and fluid demands are more. Such a situation also we have to consider the CRRT. So we have to use these two things as an indication for CRRT in the critically ill children, even into the severe dengue also. And when do we start CRRT and when do we start accelerated CRRT? So the conventional indication saying that any AKI with KDIGO staging 2 or 3, KDIGO stage 2, which is progressing, it's forms an indication for CRRT. And any child with a fluid overload of greater than 20% is a definite indication. But if any child with a fluid overload between 10 to 20% also, you have to think about CRRT, because many studies has depicted that child with a more fluid overload of greater than 10% is associated with mortality. And any child with a severe acidosis, uremia, acute liver cell failure, that is hyperferritinemic mods, we have to consider CRRT in these children. And what is accelerated CRRT? What the difference between the normal CRRT and accelerated CRRT? So we discussed this trajectory earlier. So whenever we try to identify this clinical deflection point earlier, so that we can, under denotation saying that metabolic and fluid demands exceed the kidney capacity to meet them. So that happens in the life-threatening dengue. We are trying to identify it earlier. So, and with these indications, we can identify it earlier. So those children who are having refractory shock, and the shock is refractory to crystalloids, and the shock is refractory to colloids, and the child is having low urine output, this forms an indication. So we have to identify this kind of children and we have to start the early CRRT. And those children who are having metabolic acidosis, high lactate, poor peripheral perfusion, and low urine output, this also form an indication we have to start with an early CRRT. And those children with above two things and progressive plasma leakage and reduced urine output greater than 6 hours. And those children with the shock, low ejection fraction, where there is a limiting of we can't give too much of IV fluids, and the child is on tight inotropic support, and child is having low urinary output, we have to consider CRRT. And significant liver involvement, those children with significant liver involvement and which is progressing day by day, we have to consider this accelerated CRRT. Accelerated CRRT is nothing but it's an early CRRT. We have to consider it like in an early phase, not in the late phase. So which modality is better, PD versus IHT versus CRRT in dengue? So dengue is like a dynamic condition. So the fluid dynamics will be keep on changing every hourly. So CRRT is the better thing. So we will have a proper control over the patient, and we have a control over the volume status as well as the fluid removal in these children. And it allows the administration of medications and even the blood products, whatever things we remove, extra fluid, whatever we give, we can consider removing at the same point of time. So there will be better control of serum creatine, electrolytes, acid-base status when compared to other modalities like PD as well as in IHT. So the case gets continued. So 18 hours of PICU admission, child was on mechanical ventilation. We continued on PRVC mode. ABG was showing bit of improvement. The lactates came down to 4.0. Previously, it was around 8. And saturations are improved. Heart rate came down to 140. Peripheries were warm and CFT was normal. So the blood pressures are also okay. And he was an adrenaline support of 0.15 microgram per kg per minute. So child received PRBC, FFP, platelets, and generalized edema was present. So urine output was still nil since since last 2 hours the urine output was nil. Till now the cumulative balance of around 3,600 was there, and eventually we started removing the fluid from this child as the hemodynamics got better. So on day 3 of admission, this same child developed fever spikes in the last 12 hours, and CRRT was continued, and 1500 ml of fluid was removed in the last 24 hours. So the urine output was bit better, 0.3 ml per kg per hour, and adrenaline support of 0.1 mics per kg per minute. Heart rates were better, and blood pressure was also fine. And ventilation wise, child is better, and ABG was also started showing improvement. The pH is better, lactates were better, bicarb is around 20, and the saturations were also better. So these were the labs. So if we consider the labs, if you see at admission, we have around 16.2. The child had bleeding manifestations, and gradually this hemoglobin started coming down. Platelets were still low. INR was gradually worsening. Urea creatinine was better after starting CRRT. SGOT, SGPT, and bilirubin, if you see that SGOT, SGPT started coming down and bilirubin started rising, which is a bad sign. And electrolytes, the electrolytes were properly monitored, and it was normal. And CRP, procal, if you see that CRP was getting elevated and procal was also elevated. If you see the ferritin values, initially it was 14,000 and now it is around 80,000. And peripheral smear was showing no cystocyte and fibrinogen was normal. So the present issues we have with this child is like the child is having persistent fever, acute liver cell failure started. Transaminase is coming down and bilirubin is going up, hyperferritinemia is going up. So the possibilities we consider at this point of state is like secondary sepsis, hyperferritinemia with MODS, and secondary HLH. So how to deal with this hyperferritinemia and dengue? So most of the time we'll check the ferritin. So in the early phase, it will be high. If there is a high viral load in the dengue, so any child who is having higher viral load, this ferritin levels will be elevated. Or those children with uncorrected shock and DIC also, this ferritin will be elevated. It is a marker of severe disease, and it indicates that extreme thrombocytopenia will happen in this child. And it is often associated with acute liver cell failure. In such a condition, no need of treating this ferritin and no need to be behind that ferritin value. Only thing is like you have to monitor it closely, and over the time it will come down. In the late phase of the disease, say around 8th to 9th day of the illness, most of the time we expect that there will be improvement in the disease, but there won't be any improvement and ferritin is keep on going. In that phase, you have to think about secondary sepsis, secondary HLH, acute liver cell failure, or hyperferritinemic MODS. Those are the spectrum of the patient who requires the CRRT, IVIG, pulse dose steroids, as well as the plasmapheresis. And how to differentiate between this secondary HLH and hyperferritemic MODS is secondary HLH, fever with organomegaly with the 2 cell lineages are affected. There will be hyperferritinemia, hypertriglyceridemia, hypofibrinogenemia, and hemophagocytosis will be present. And most of the time we have to treat the cause, and some may require this dexamethasone and all. And hyperferritinemic MODS, it will be associated with hyperferritinemia along with fever and hepatocellular dysfunction, as we discussed earlier. There will be ongoing DIC will be there. Those children will get benefit from plasma exchange, IVIG, and methylprednisolone. So in this case, we upgraded antibiotics to meropenem as well as colistin in view of elevated septic markers after sending the blood cultures. And in this case, we consider the possibility of hyperferritinemic MODS with ALI, ALF with the DIC was considered. We started IVIG with IVIG 2 gram per kg, and we started plasmapheresis along with CRRT. So this last indication, what we discussed in the previous thing, hyperferritinemic MODS with the progressive liver failure with bleed. This follows an indication of therapeutic plasma exchange along with CRRT. So what does the evidence says for plasmapheresis? This is the recent article which was published in PCCM. So they compared, they divided this dengue-associated liver cell failure with shock syndrome into 2 groups. One group, they gave only CRRT. In other group, they gave CRRT along with plasmapheresis. What they observed is like the group which had only CRRT, there is 85% mortality. And the group which has both the CRRT as well as therapeutic plasma exchange, there is only 37% mortality. There is a significant mortality benefit with therapeutic plasma exchange along with CRRT. These are the other studies which were published in Thailand, Vietnam. So most of these studies are from the Southeast Asian countries because dengue is not seen in other developed nations and all. So on day 8 of this illness, day 8 of a hospital admission, in view of persistent hyperferritinemia and worsening liver parameters, plasmapheresis we did for this cell in 3 cycles. Fever started improving and CRRT was continued. Urine output improved to 1 ml per kg per hour, and we stopped CRRT. Hemodynamics were better, and we continued on mechanical ventilation with minimal settings. And then ABG was also started showing improvement. Hemoglobin was fine, platelets started improving, bilirubin started improving, now it is around 5. Ferritin started coming down, and creatinine was around 0.9 milligram per deciliter. On day 10 of illness, we extubated the child, and antibiotics were downgraded after the negative cultures, and child was discharged on 14th day after admission. So with all this evidence, the take-home message is like we have to consider CRRT as an earlier rescue than the late adjuvant, and CRRT can be safely done in children with life-threatening dengue. Immunomodulation and CRRT will be very promising in very sick or life-threatening dengue. Therapeutic plasma exchanges and CRRT can be considered in children with progressive acute liver cell failure with severe dengue. The outcome is very good with therapeutic plasma exchange with CRRT. Still, it warrants more studies in future. Okay, thank you. Any doubts regarding the particular thing?
So since morning, we have gone through pediatric pulmonology, critical care in pediatric pulmonology. We have gone through pediatric nephrology, then specific critical care intervention in pediatric nephrology. Now we have started moving toward mods. Any questions till now? By anyone to any faculty till now? In case you have questions, you can keep them noted down. We will have lunch time to discuss with our faculty. Now we are moving towards section of neonatology. I would like to invite to start the session Dr. Sindhu. Dr. Sindhu Maru is our consultant neonatologist at KIMS Cuddles, Gachibowli. And ma'am, please.
So I'm going to talk on neonatal sepsis. So why do we give so much of importance for the neonatal sepsis? That is the most bugging issue for all the neonatologists who practice in level 2 or level 3 care, who practice neonatology per se. So why is it so? When we think about a global burden on the neonatal sepsis, point. So first, what is neonatal sepsis? Any bug, could be a bacteria, virus, or a fungus, whichever irritating the baby, it's a sepsis in a single point of, if you say the single line. So what if we define it as, it's a systemic condition that arises from the bacteria, viral, or a fungal origin associated with hemodynamic changes and clinical findings, and which causes severe morbidity and mortality. So epidemiology, it's too much of global burden. It's the third leading cause of neonatal death. And as per WHO 2021, around 3 million cases of neonatal sepsis all over the world, of which 430,000 were neonatal deaths. In this, incidence comes around 1 in 1,000 to 5,000 live births. In Western countries, the most common organisms which they see is like group B streptococcus and E. coli as a dominant in early onset sepsis, whereas in late onset sepsis, cons is the most dominant organism in the Western countries, in contrast to us. So as a later, when the more of case mortality rate occurs in early onset sepsis than in the late onset sepsis. When we come to the India, the most common study, that is Denny study done in 2016, which show incidence is around 14.3, of which the culture positive sepsis is 6.2%, and of which 2/3 are early onset sepsis. The most common sepsis of early onset or late onset sepsis is early onset sepsis. And the organisms, in contrast to the Western countries, we see are Acinetobacter, Klebsiella, and E. coli. And the pathogens in the early onset sepsis is same as in the late onset sepsis. Whereas in the Western countries where early onset sepsis and late onset sepsis, the organisms are different. But in our country, almost both early and late onset sepsis, the organisms are same. Why Acinetobacter? See, almost if you get a culture of so many neonatal ICUs, most common organism is Acinetobacter. Why? Acinetobacter, how is it transmitted? It is transmitted same as any other organisms, with a contamination of our hands or with an object. Like getting our phone per se can also cause contamination of Acinetobacter. So this is the most common expansion or rapidly multiplying organism. So it is the most rapidly progression. So that could be the most common cause, because that carries around 22% in all over the infections. So the case fatality rates in India, the New York gram-negative organisms was higher when compared with that of the gram-positive organisms. With Pseudomonas has the highest case fatality rate. With the predominant gram-positive pathogen which we see is same as coagulase-negative Staphylococcus. The group B Streptococcus which are isolated in very, very few neonates compared to that of the Western countries. Next, nomenclature. We use so many terms when we diagnose the sepsis. One is probable sepsis. What is probable sepsis? The probability of having that baby having a sepsis is what probability? Based on what features? The clinical signs and laboratory findings suggestive of infection, but blood culture is sterile. Then we call it as a probable sepsis. And we call it the clinical sepsis. Only the clinical features are suggestive of sepsis, but both septic screen and blood cultures are sterile. Means we don't have any investigation saying it as positive. That is called culture positive sepsis. Next, definitive sepsis. Yes, that is culture positive sepsis. Suspected sepsis. This is the common word we use. As soon as any baby comes to us in an ER or an OP, if the baby is dull or whatever, we call it a suspected sepsis. We'll write it in the heading. So suspected sepsis based upon the risk factors. Like if it's an early onset sepsis, based on the risk factors, we categorize and suspect it. But it is neither the proved by the screenings or thing. So suspected sepsis based on the risk factors and clinical features, but the clinical course and the screening tests are not suggestive, but we just label them as a suspected sepsis. What are the signs and symptoms? We all know the non-specific signs, like whatever could be the sign, we can label it as sepsis. And systemic signs, like starting from the central nervous system, any dull activity or a convulsions, increasing tonic posture, stiffness of all the limbs, irritability, hypotension, cardiac part, hypotension, poor perfusion, gastrointestinal tract necrotizing enterocolitis, which is like feed intolerance or abdominal distension, vomiting. We will label it as a sepsis. So when we go precisely based on the prevalence and based on the association of the severity of illness, the prevalence in 0 to 6 days, the most prevalent sign or symptom could be the respiratory tachypnea. Tachypnea is the so the most prevalent వస్తుంది కానీ దీని మీద పాయింటర్ అవ్వట్లేదండి వెనక్కి తెలుసు okay. So the most prevalent is 18%. 18% that is tachypnea, the most prevalent feature, which is associated with severity of illness. But if you see, the most prevalent is tachypnea, but the prevalence of severity of illness is very, very less. If you see that not feeding well or the baby is a dull activity, the features which they present is only 9.8% of prevalence rate, but the severity is 17.8%. So the most prevalent features which they present to us is the tachypnea or respiratory part, but the prevalence of severity of illness is most comes with that of the decreased feeding well, decreased accepting the feeds, or lethargic is the most severity of illness is directly proportional. When we come with the 7 to 59 days, the most prevalent features which we see is this is 23.6%, that is fever, which usually they come with, but the severity is not the fever. The fever is most prevalent, but the severity is not directly proportional. It is very, very less, 2.9%. When we compare with the other features like reduced skin turgor, that is dehydration, or could be a hemodynamic instability, where severity of illness is 15.7%. And the other study, like the young infant clinical study group, they have an independent clinical predictor showing the severity of illness. The independent critical predictors like prolonged capillary refilling time or cyanosis or history of convulsions show the highest incidence of and severity of the illness. Next comes to the early onset. So what are the common case scenarios which we see in early onset sepsis in our daily practices? Number one, asymptomatic term or late preterm neonate with one or more risk factor for sepsis. Number two, asymptomatic preterm, that is less than 35 weeker neonate with no risk factors. So neonate with feces suggestive of clinical sepsis brought from house. Next, neonate with non-specific suggestive of clinical, non-specific signs and symptoms of sepsis. These are the 4 clinical scenarios which we commonly face. So how do we deal with it? By the end of the sessions, you would be able to have some clarity like whom to start antibiotic, whom to do septic screen, whom not to do septic screen. That's the only aim of this talk. That's it. There are different, to calculate into the risk factors, there are different kinds of practices which are done in different countries. In US, they use a septic calculator. Based on the septic calculator, they calculate whom to give antibiotics, whom not to give antibiotics. In NICE guidelines or in UK, they use different red flag signs, non-red flag signs. If one red flag sign is present, then they go with starting of antibiotics. If 2 or more red flags, non-red flag signs are present, then they go with the starts doing of septic screen. So different. In our country, we have n number of studies or n number of practices we have. We have IAP, NNF, AIMS, and each one have their unit-based one. But I prefer it is an unit-based would be a most preferable one. So this is a septic calculator. If you press in Google, if you see a septic calculator, you will have this kind of screenshot. In that, if you enter each of it, you will have well-appearing equivocal or clinical illness, and they show the risk pattern. And then you can start on, based on this calculator, you can start on antibiotics. So in our country, most common used is, these are the risk factors. That is rupture of membranes, that is PROM for more than 24 hours, spontaneous preterm labor, chorioamnitis. Previously, we used to call chorioamnitis, but recent we have changed from the chorioamnitis. There is no word called chorioamnitis, which has been changed to intraamniotic inflammation or infection. And or in few of the like IAP and all, they use like in III, whereas in AIMS and all, they use foul smelling liquor. Both comes to the same. Prolonged labor, that is stage 1 and stage 2 more than 24 hours. Single unclean or more than 3 sterile per vaginal examinations. Perinatal asphyxia. These are the 6 parameters or 6 risk factors which most commonly used in our country based on our own studies. So in detail with about intraamniotic infection and inflammation, there are 3 categories in this. Not all intraamniotic infection or inflammations are severe. They are divided into 3 categories: maternal fever, suspected III, or confirmed III. Maternal fever, that is oral temperature is more than 39 degrees, or if oral temperature is 38 to 39, repeat after 30 minutes. And if the repeat value is also at least 38 degrees or 100.4 Fahrenheit, we will label it as a fever. Next category is suspected III. Okay. In this, we have 3 things. That is fever without a clear source. So there is a fever for the mother without a clear source, like baseline fetal tachycardia is more than 160. Maternal total TLC count more than 15,000, and definite purulent fluid from the cervical os. And third is confirmed III, means confirmed chorioamnitis. There is confirmed the infection in the mother. That shows that positive amniotic fluid Gram-Stein or culture is a pathological evidence of inflammation in the both in the placenta. So let us see the 3 categories. Whatever case scenarios I have just told you, let us preterm 32 plus 3 weeker male baby 1.5 kg. Primary mother, second degree consanguineous parentage, LSES, Abgar for 7 and 8, at 7 and 8 means 1 and 5%. So the question comes, what to do with this baby? Okay, let us answer in the last. Next, second baby, late preterm 36 weeker, delivered by primary mother with normal vaginal delivery, birth weight of 2.12 kg with PPROM of 26 hours, no antenatal risk factors, baby cried with a good Abgars. And the third baby, term baby with delivered by LSES in your oligohydramnios with PROM of 24 hours with good weight, maternal fever of 20 hours before delivery, baby cried, and Abgars were normal, but baby is having tachypnea, symptomatic. Okay, so with these 3 clinical scenarios, we are going to answer. With this clinical scenario, we will be able to answer the last. Septic screen. So very precisely, I have put only 2 things. You have a good clarity like when to do septic screen. 2 or more perinatal risk factors at birth, or there are certain signs like there is fever or decreased activity when the baby is got from the community or present in the NICU per se. We will go with the septic. So when to start antibiotics? The starting of antibiotics is clearly based on unit which we practice. Okay, but as per the risk factors and as per the protocols which we follow in India, all clinically triple, that is amniotic infection and inflammation, or 3 or more risk factors out of 6 which I have mentioned, we will start up antibiotics. So septic screen. What is septic screen? Septic screen, the red part which I have put, it's only mainly of rule out sepsis than in the rule in sepsis. Okay. So what are the components in the septic screen? Total leukocyte count of less than 5,000, that is leukopenia. Absolute neutrophil count of less than 1,800 per cubic mm. Immature to mature neutrophil, that is more than 0.2%. That is more than 20% in case of preterms and more than 27% in term babies. Micro ESR more than 15 mm HT. That is how do we normal is 3 plus age in days, C-reactive protein. Let me discuss a bit more about C-reactive protein because which we commonly use in our routine practice. C-reactive protein. So it's an acute phase reactant, rises by 4 hours and peaks by 36 to 48 hours. And the half-life of CRP is 19 hours. There is 15% reduction in 24 hours of starting of antibiotics. Okay, serial CRPs have higher predictive value than negative predictive value. That is negative predictive value per se. What does it mean? That chance of ruling out of sepsis is more than ruling in. Like if negative predictive value is 100%, we are 100% sure that there is no sepsis. The sepsis is there, so we are more sure about no sepsis. That is called negative predictive value. So when 2 CRP values, serial CRP values of less than 10, the negative predictive value is 99%. So presence of 2 abnormal parameters in the septic screen is associated with sensitivity of 93 to 100%, specificity of 83%, and with a positive and negative predictive value of 27 and 100%. As I have told you, it's more of rule out sepsis than the rule in sepsis. If 2 or more parameters are abnormal, it should be considered as a positive screen and you have to start on antibiotics. And okay, 2 or more screens are positive, let us start on. Initially, I told you whom to start antibiotics. So 2 or more on whom to do septic screen. 2 or more parameters are positive, let us do septic screen. And if the positive screen, it should be started on antibiotics. If the screen is negative, but still you have a thought of like babies might have sepsis, then repeat the septic screen after 12 hours. Still after 12 hours, the screen is negative. You should have some other differential diagnosis in your mind other than the sepsis, because we have almost ruled out the sepsis. So other investigations like X-ray, urine CUV or urine culture is done to see where is the focus of the infection. X-ray will be done in case to rule out the pneumonia, or in case of necrotizing enterocolitis, or if there is an abnormal distension to rule out necrotizing enterocolitis, and neurosonogram to see if the baby is having a meningitis, to see the hydrocephalus. And urine tests we are almost preferred to see for the urine infection late onset sepsis mainly than in the early onset sepsis. So when do we say there is a nutrient more than WBC count of more than 10? More than 10 count per cubic mm in 10 ml of centrifuge sample. Okay, and more than 10 to the power of 5 organisms in urine obtained by a catheterization. Always it should be a catheterization, right? So catheterize any organism urine obtained from that of the suprapubic aspiration, then we can take it as a UTI. So approach. This is a simplified form of all the approaches whichever we have in India. But it is always, as I keep on telling you, it's unit-based approach. Whatever to do septic screen or to start antibiotics, it's always depends upon your unit, whichever you are practicing it out. So to see asymptomatic neonate, if the baby is an asymptomatic neonate, risk factors present or absent. If the risk factors are present, think about what risk factors are present. That is more than 3 risk factors, or if there is a triple I is there, no doubt. Start and send blood culture. Very, very important. Send blood culture whenever you are starting antibiotics or whenever you are upgrading antibiotics. So you have started antibiotics today, send a blood culture. After 48 hours, still you are having suspension, like baby is not improving and you want to upgrade the antibiotics, send repeat blood culture again. Make sure that you are sending blood culture when you are starting or upgrading of antibiotics. And if then less than 3 risk factors, monitor clinically. No need to do septic screen work for all the babies who are asymptomatic with risk factors. That's what I want to tell you. Septic screen not necessary to be done for all the babies, even though there are less than 3 risk factors. Okay, if there is only a preterm like less than 33 weeks and all, and your unit protocol says that we need to do, then only do. Not necessary to do septic screen for all the babies who have 2 risk factors. Nothing. Okay, if there are no risk, if the risk factors are absent, asymptomatic baby, nothing. If there is extreme preterm like 28 week and 29 week, you just monitor the baby clinically. Symptomatic. Next question. Symptomatic baby. This is all about early onset sepsis I'm talking about. Symptomatic baby. Whether again same thing. Risk factors present or no. There are no risk factors. symptomatic risk factors are present, get an X-ray and see like where is the source of infection. If X-ray is suggestive of pneumonia, no other reasons for the symptoms, like the baby is having a tachypnea, you got an X-ray, there is no pneumonia in it. But you see the if you see the polycythemia, or if you have an hypoglycemia of baby, if you see the polycythemia part, then you have some other reason to explanation for that kind of tachypnea. But if there is no other reason for that kind of symptoms, start antibiotics after sending the blood culture. If there are no risk factors but symptoms are present, check the baby. If the baby is sick clinically, start antibiotics. If the baby is not sick looking, monitor clinically, or if symptoms persist, send for the septic. Approach to the late onset sepsis, that is low probability of neonatal sepsis, high probability. So based upon the symptoms, based upon the clinical assessment, whether it's a low probability or high probability. What is low probability? Like one episode of vomiting, or one episode of feeding intolerance, or one episode of apnea. That's also low probability, right? So low probability, do septic screen. And then if septic screen is positive, start antibiotics. If the septic screen is negative, monitor clinical. If it's high probability, like baby sick looking, dull, bought from the community, with decreased activity, not accepting feeds, start antibiotics right away, irrespective of the septic. Okay. Then all LOIs with high probability, definitely we need to do CSF analysis, lumbar puncture. Next comes to the biopsy. So clinically, we have got some idea what to do, when to do septic. Next, the other part of the recent part which we are seeing is biomarkers. That is C-reactive protein, procalcitonin, interleukin 6 and 8, cell surface antigen, CD64, serum amyloid A, and all. So in this, all the six, there are some other also. In this 6, most commonly we are using first 2 and very rarely next 4. So let me explain in detail about first 2. CRP I have already spoke. Next comes the procalcitonin. So procalcitonin is a pro-hormone produced by the thyroid seed cell, the precursor of the calcitonin. Many pro-inflammatory cytokines, they will stimulate the like interleukin 6, plays a pathogens of bacteria. So as soon as the bacteria enters into our body, then obviously we know that interleukins will start secreting them. These cytokines seem to trigger the procalcitonin from the target, of which bacterial lipopolysaccharide has been coated because of the PCT release in cell. So it starts rising from the early rising of all the biomarkers whichever I have showed. One of the early rising, okay, procalcitonin, because interleukin also will rise early. So this is early rising, that is 3 to 4 after the endotoxin challenge, and peak about 6 hours and remains increase about 24 hours. This is why some of the important of red lines is remains increase over 24 hours, because a bit of we have some time to check it on to get it through. The sensitivity of the PCT is around 83 to 100%, whereas specificity is around 70 to 100%. The main drawback of PCT is PCT increases normally because of the peripartum inflammatory changes or non-infectious diseases like RDS, perinatal asphyxia, hemodynamic failure, post-resuscitation, and all. PCT can be used. So we don't have much confidence in the EOs. But with this, they have been studied. This study was done in long ago, around 2001 to 2002, where they have quantified the numbers of the PCT. Okay, this is for this. The first one is showing the normal baby, and this is the septic baby. With the normal baby, the squares are showing the values of normal babies. They have taken the values of almost from birth to 48 hours of life, all the healthy babies, and then they have put a graph. The center graph is showing the median range. The above and the below is the ranges. So if you see the upper line, this line, which is showing almost around 50 maximum. Okay, the median is around 2 to 5. If you see a septic baby and if you see the procalcitonin values, the higher the range, see the minimal range only, the starting is more than 10. So with this, at least we have some confidence that higher the PCT levels, can be chances of getting PCT positive, and we can take it into. These are all early on which they have done. Okay. Next, without this study, I will shouldn't close with pneumonia studies done by our own sir. PCT guided decision making, this study was done whether based on PCT, whether to stop antibiotics or not. In CRISP, I'm telling you, based upon the procalcitonin, can we stop antibiotics or not? Like if procalcitonin is negative, can we stop antibiotic is the question. Okay, this was showing decision making of suspected EOAs and safely reduce the duration of antibiotics. Out of 1710 neonates, they have divided into 2 categories. One is PCT guided and one PCT guided antibiotic therapy, other standard unit protocol standard antibiotic therapy, of which PCT guided decision making was superior to standard care in reducing the antibiotic therapy. Like, so they have taken if the PCT is less, after giving a 48 hours or 5 days of antibiotics of that protocol, if they take a PCT as a test and the PCT is coming the decreasing trend, then they stop the antibiotic. Whereas the other standard care, like they used to give for 5 to 7 days. So that this shows that antibiotic stewardship, it's better in taking of the antibiotic stewardship. Next, continue with the biomarkers, cytokines, interleukin 6 and 8. As I told you, it's a very short half-life, but so very short half-life, so negative values. So false negative rates are high. The positive of this interleukin 6 and 8 is accurate, useful for the early diagnosis of sepsis, and can be used along with the late peaking, because it's early raised and stopped when we test, maybe it will not be positive. So it can be combined with the late peaking markers as association with it. The limitation is relatively long turnover, and it levels increase and decrease by the time of clinical presentation, because as soon as the endotoxin, as soon as the bacteria increases, endotoxins or interleukin cytokines will start releasing, right? So that peak will come and down by the time we get a clinical features per se. Next, CD64, rise by 1 to 6 hours after the onset of infection. The positive is small volume, rapid turnover with good high sensitivity and specificity, limited values as a sole marker of infection. Serum amyloid, as I'm telling you all this, we are not using still in the research part. I don't think any of the units per se are using this kind of biomarker, that is serum amyloid A and all. Rises sharply within 24 hours of infection. Positive is rapidly automated kit. But limitations are variability of sensitivity. And the serum amyloid A depends on about hepatic function and everything. In short of the biomarkers may assist in the early detection of sepsis, non-specific indicator of infection and inflammations, incapable of providing information about etiology of infection, much more evidence required for taking of the biomarker as a single indicator for identifying EOS. Next, this is one of the important study which we all not practice much, Indian study only. So based upon the clinical tool, can we diagnose the early onset sepsis? Early onset sepsis, early is the main thing. In compared with the procalcitonin. So we are talking about procalcitonin so much, no? In this clinical tools, we call it as STOPS tool. STOPS. S for sensorium. Sensorium is activity. So your baby is in NICU. See the activity of the baby. 3 hours, they started the baby. 6 hours and 12 hours, they examined the baby. I think they can hear my. Sensorium activity at 6 hours and 12 hours. Okay, 6 hours and 12 hours. See the activity of the baby. The baby is becoming lethargic or baby is becoming hypotonic. See the activity. Next, temperature, hypothermia or hyperthermia. Next, output of the O for output of the warmer. You have seen at the time of your rounds, you have seen the output is around 10% or 25%. By the time after 6 hours, if the output is increasing, it means that baby's requirement is increasing. That again, one of the tool. O for not urine output, please, output of warmer's output. And P for pulse rate or heart rate. And S for saturations. So with these tools, when compared with that of the procalcitonin, abnormal STOPS parameter was superior in detecting and early detecting of early onset sepsis when compared with that of the procalcitonin in early onset sepsis, whereas as good as PCT in late onset sepsis. So this can optimize the use of antibiotics. Next, blood culture. We have two kinds of blood cultures. The one is conventional culture, which we used long back. That is conventional culture, where the positivity is only 40.5% and used to take around 3 to 4 days to get the culture report and to act on it. Whereas this BD Bactec technique, there are different other methods also to see the blood culture, which commonly we all are using is BD Bactec technique. In this, it will recognize the bacteria by 90% of recognition of bacteria. And if gram negative, there will be an early growth in around 24 to 36 hours only, you can see the growth. And optimized enriched, there's an optimized enriched culture medium with antimicrobial neutralizing property in that culture media. So if you given 1 dose of antibiotic, if mother would have received antibiotic also, it will optimize it and it will show the growth if the actual growth is there in it. Next, continuous read, it will be continuous reading detection system by using a fluorescent technology. I will explain you later. Next, it detects bacteria at level of 1 into 10 colony fold count with a minimum volume of 1 ml of blood. Oh, we know blood culture, we should take at least minimum of 1 ml of blood. With a minimal well, it can detect the bacteria. So this is what I am talking about fluorescent. This is a bottle. And the base contains a sensor. Okay, we put a blood. If the blood is having the bacteria, that bacteria will react with the broth, whichever the medium which we give, and release carbon dioxide. This carbon dioxide will react. So this is the, if you think this is the base, it contains dye and a sensor. Okay, that vial sensor. Okay, it will react with the dye and then in the vial sensor and then detects shows a LED light, like a fluorescent material in the sensor, and fluorescence will be seen, that light will be seen. Okay, and with that kind of photo detector reads the fluorescence, and this is the raw data from the detector is analyzed by a robot, which they will be having microbiology team, and this will show the positive analysis. Positive analysis can be announced, like this robot is kept in that box where they can have an it can be announced, have an announced positivity will be shown by an announced by an audible or by an alert technique or by an positive while indicator. These are the three things it can show us the positivity. Next, what are the important points in taking the blood culture? Though blood culture very commonly we use, the most sample to be taken by the freshly placed central line or freshly punctured venous punctured. Okay, and so when do we think about contamination of the blood culture? Number one, if the culture takes for more than 3 days to grow, so most of the culture, as I have told you, gram negative will take around 24 to 36 hours. Most of the cultures in the BD tech, BD technique, it should be less than 3 days. If it is more than 3 days, if it is showing the cultures with the mild symptoms and all, we should think about the contamination of the sample. Next, multi-organisms have grown in the, especially skin flora has shown, then we should think about contamination. But we should be very conscious in the second point, because multi-organism growing in the blood culture have high mortality rate also. So thinking about contamination will be in a dilemma. Next, neonates improves within 4 hours of deterioration. Baby deteriorated, could be some other cause, but sepsis came positive. But if the baby is septic, it will not improve in a short period, right? So we should think about that time, we should think about contamination. And the last point is usually the blood cultures which should be taken in 2 culture bottles. But what we take is in 1 culture bottles, but it should be taken in 2 culture bottles. If only 1 culture bottle is showing the growth, then think about contamination. The other techniques of blood culture is 2 moments. Polymerase chain reactions by molecular assay. One is polymerase chain reaction. The other one is whole cell mass spectroscopy, spectrometry. Polymerase chain reaction is a gold standard by using in 16S ribosome and DNA extract, and used for DNA extracted directly from the blood or CSF. Detects bacteria within short period, within less than 24 hours. Sensitivity is 40 to 100%. Does not provide information about antibiotic susceptibility. Though it will tell about the organisms, based upon sensitivity and susceptibility, it will not send which organism, which antibiotic susceptible. The other one is WCMCMS, that is the whole cell mass spectrophotometry. Based on the ionization of bacteria, generates unique protein by using in spectral fingerprints. It will results were issued within by 3 days. Next, lastly, by lumbar puncture. So what are the indications? All babies evaluating for late onset sepsis, we should do lumbar puncture. Blood culture positive, yes. Worsening of clinical conditions when on antibiotic, think about the lumbar puncture. Few point on lumbar puncture, that is gram-positive bacteria started antibiotics, whether to do blood culture. So these are the query which we get in our clinical practice. So gram-positive bacteria clear by 36 hours of approximately 36 hours by appropriate therapy. Whereas gram-negative will take around 5 days. So we can consider lumbar puncture if the baby is given 1 dose of antibiotic or 2nd dose of antibiotic and thinking of meningitis, we can. Next, in unit with meningitis not showing any clinical recovery after institution of antibiotic, LP should be repeated after 48 hours. If the LP is traumatic, most common thing, the LP is traumatic, then CSF sent for the gram stain and culture. Okay, at least this will show us some information. We should not discard it. At least send for the stain and the culture. This will show some information. If the WBC count must be performed within 30 minutes of drawing the sample, so we should make sure that pathologist is available when we are drawing for the LP, right? So because the WBC will get misperformed if it is within after 30 minutes. So it must be noted that CSF, WBC and glucose rapidly fall with the time, giving spurious results. So last, baby A, preterm 32 plus 3 weeker, male 1.5 kg, primary mother, second degree concern is LSS. Should we start antibiotic? What should we do with this baby? Do we seriously need to monitor also? Okay, monitoring is okay. Do we need to start antibiotics or not? Thank you. Baby B, late preterm, 36 weeker, male baby delivered to a primary mother by normal vaginal delivery with birth weight of 2.12 kg, PPROM of 26 hours, no antenatal risk factors, but one antenatal risk factor obviously is there, that is PPROM. Baby cried after 1 cycle of bag and mask with the abgas of swans. What should we do? So here comes the query. What should we do with this baby? So as I told you, it's all unit based, but with only two risk factors like delayed pregnancy transition, that is perinatal access is there and PPR1 is there. So with these two or risk factors, not all the babies required for septic skin. That's what I want to tell you. Septic skin not necessary. Then, as I told you, like less than 3 risk factors go for the septic skin. Like 2 or more risk factors go for the septic skin. More than 3 risk factors start antibiotics. 2 or more risk factors also you can wait and see clinically, not necessary to do septic skin. Baby C term female baby delivered to GPQ eligible mother, LSCS, oligohydrogenase, PR1 for 24 hours, maternal fever is there, baby crying. Abgar scores 8 and 9 and 1 5. Baby had taken care. What to do with this baby? Thank you. Why is it skin again? So points to remember, make sure that you do blood culture before starting of antibiotics. For evaluation of sepsis, have an unit policy. Have an unit policy and not single biomarker or septic skin may not be very sensitive, but have a good negative predictive value. So rule out sepsis than in the ruling sepsis. Serial CRP or serial PCT have a higher importance than in a single CRP or single PCT. No ideal test for sepsis. Thank you.
Thank you, Dr. Sindhu. Need not to be sorry. I think it was long but interesting. And finally, you made sure that everyone did the right answer. So without further delay, I would like to invite Dr. Aparna, who is Clinical Director of Neonatology Department and Neonatal Intensive Care Services at KIMS Cuddles. The topic given to Dr. Aparna is one of the most crucial, time-taking, life-saving, that is PPHN, management of PPHN, usage of ECMO, and let's learn from Dr. Aparna. Madam.
Slide changer. So good afternoon, everyone. I'm aware I'm standing between you all and lunch, and I'll try to keep this as interactive as possible. Thank you, Sindhu. A slight digression is probably I may not be speaking too much about ECMO in this talk. You know, there is a large role of supportive care and other modalities of treatment. We have pharmacological measures, we have inhaled nitric oxide, we have a lot of other things to optimize in terms of supportive care. So I would probably be stressing a lot more on these aspects than on ECMO. So let's all begin with a case scenario. So this is a baby born early term at 38 weeks of gestational age, large for gestational age. Birth weight was 3,798 grams, female. This is a real scenario only. Managed at our unit, KIMS Cuddles. So this baby was delivered by normal vaginal delivery. You know, on this is date and time can be ignored. The baby cried after stimulation. Abgars were 6 and 8. So what is your interpretation? Does this baby have perinatal asphyxia? So they have mentioned that the baby needed some stimulation at birth. The Abgar score at 1 minute is less than 7. Okay, but 5 minutes, it seems to be fine. So as per the NNPD's definition, the Indian definition, this would qualify for moderate grade of asphyxia, where 4 to 6 is taken as moderate asphyxia. So there's nothing like mild asphyxia. Anything more than or equal to 7 is taken as normal. But at least we do know that this baby was not severely or significantly depressed at birth. There was no significant maternal antenatal history. The mother had PROM, prolonged rupture of membranes, with meconium stain, LICA. So this baby starts having respiratory distress at 10 minutes of life. The Downey score is 6/10. The team from KIMS was called, and the baby was started immediately on delivery room CPAP. So do you all agree with this? Or how many of you think the baby should have been intubated straight away? Anyone? Great. So is there a role of CPAP in MAS, or is CPAP contraindicated in MAS? So there is definitely a role. There is definitely some worth in trying CPAP in babies with meconium aspiration syndrome. A Downey score of, does the pointer work? Okay. Okay. So that a Downey score of 6/10 is not really a contraindication to CPAP. We may be able to still rescue some of these babies with CPAP. And there is evidence, including a large randomized control trial from Hyderabad, that showed that CPAP usage in meconium aspiration syndrome can be associated with significant reduction in the need for invasive mechanical ventilation, need for surfactant, etc. So trying CPAP was a valid step, but of course this needs to be accompanied by close monitoring for worsening or signs of PPHN, signs of hemodynamic instability, signs of respiratory failure, which may all call for mechanical ventilation. So this baby did develop CPAP failure. Once the baby was shifted to NICU, the baby had worsening distress, increasing FiO2 requirement, and had to be intubated. The baby was connected to SIMV mode, and these are the settings. So this was the first X-ray. So what do you think the X-ray of the baby shows? So do we see? Yes. So is the baby really hyperinflated? So how many posterior intercostal space are there? 1, 2, 3, 4, 5, 6, 7, 8. The diaphragm is not very clear. But on eyeballing, at least this baby's lung doesn't really look hyperinflated. 8 intercostal spaces is just around okay on SIMV. But what is more predominant is that opacities are significant. Both sides, it's not really homogeneous. More of the typical fluffy and irregular opacities that you see in meconium aspiration syndrome. This is quite classical of meconium aspiration syndrome. Some people might call it white MAS. Some people might say it's predominant kind of atelectasis-like picture. So definitely this pattern of opacity is different from what you see in RDS. That would be more fine, more granular. This is more coarse and opaque. So this is consistent with meconium aspiration syndrome. Predominant atelectasis subtype. And some people do consider giving a dose of surfactant. So where do you consider giving surfactant in meconium aspiration syndrome? Anyone? Okay, so if the baby is needing invasive ventilation with an FiO2 requirement above 50%, again, not much of evidence to say that it reduces mortality, but at least it has been shown to reduce the incidence of hypoxemic respiratory failure culminating in ECMO. So it may not translate into reduction in death, but at least we may be able to salvage oxygenation, if not permanently, at least transiently. So we did try respiratory 2 doses of surfactant in this baby, actually. The first blood gas showed mixed acidosis with pH of 7.1. CO2 is also elevated, and you also see some metabolic acidosis. The baby started showing features of PPHN in the form of labile SATs, pre-ductal 88 to 93, post-ductal 74 to 85%. Oxygenation index was 20. A post-ductal line, arterial line was placed. I think the baby had a peripheral arterial line. You all know how to calculate OI. Anyone wants to say the formula? What is there in the numerator? So remember, what you give is in the numerator. What do we provide for oxygenation? We provide 2 parameters in the ventilator. They are MAP and FiO2. So MAP into FiO2 in the numerator, and what we get from the baby, or what we assess from the baby, in the denominator, that is PaO2. And that is preferably post-ductal PaO2. So this baby's OI was 20. So we began nitric oxide. Inhaled nitric oxide initially was started at 20 ppm. Again, this is a little unusually severely hypoxemic baby. Usually we would limit to a dose of 20 ppm because higher doses are associated with toxicity, but this baby had to be escalated and was given a relatively higher dose of nitric briefly. The baby also developed right-sided pneumothorax on day 3. Intercostal drain had to be placed, and then the baby was on nitric for 6 days, after which the baby started showing signs of recovery in hypoxemia. PaO2 is improving, and the baby could be tapered off and weaned out of nitric oxide. This is table showing serial blood gases. You can see that the baby almost touched indications for ECMO at a couple of points, but thankfully, thanks to a large PDA which was shunting right to left, the baby could escape from significant RV dysfunction. And with close monitoring, the baby came out with inhaled nitric oxide. This is, of course, not something that we are recommending that you should do, but this is just a case scenario where, this strategy did work. So as expected, the echo showed features of severe pulmonary arterial hypertension. There was bidirectional shunting. ARIA-RV was enlarged. There was tricuspid regurgitation. Baby had features of severe PPHN and associated RV dysfunction. The baby also had hemodynamic instability requiring inotrope support. Also had sepsis. And this is the antibiotic course. Let me come back to PPHN. So we know that successful adaptation to extrauterine life requires a lot of physiological steps, and these may not always go as per what is expected, and that is what culminates in PPHN. We just saw one example of a baby who had both asphyxia and meconium aspiration syndrome who ended up with PPHN. So this picture is probably a little blurred, but this is just to show that in fetal circulation, we all know that the placenta carries oxygenated blood. So I'll have to go here. So the placenta is, the umbilical vein is actually carrying oxygenated blood from the placenta to the fetus. And you know that the umbilical vein is connected through the ductus venosus to the IVC, which in turn takes this into the right atrium. And in the right atrium, you have mixing of the venous return from the upper half of the body, which comes in via the SVC, as well as oxygenated blood from the IVC. Selectively, the oxygenated blood from the IVC seems to be routed through the PFO into the left side of the heart. And ultimately, this reaches the systemic blood flow from the left ventricle, goes to the aorta. The right ventricle, of course, does go into the pulmonary artery, but most of the blood from the pulmonary artery would be shunted right to left across the duct. This is because of the high pulmonary vascular resistance. 90% of the blood from the pulmonary artery ultimately ends up reaching the aorta through the PDA. So after the baby is born, so despite this relatively low oxygen tension in the fetal aorta, which has a mix of the blood coming, oxygenated blood coming from the left ventricle, and majority of the deoxygenated blood coming from the right ventricle, how does the fetus survive? Despite having such saturations of around 45%, PaO2 would be around 20-25 millimeters of mercury. This is possible because of fetal hemoglobin, which has more affinity to carry oxygen. So even this limited oxygen is carried to the tissues because of the availability of fetal hemoglobin. It is also because the baby can compensate with relatively high cardiac output and low myocardial stress. Because of the shunting of blood through the PDA that reduces the right ventricular strain and preferential brain sparing effect. So maximum oxygen delivery is ensured that it reaches the brain as well as the heart. But once the baby is born, when the baby transitions in the first few minutes, there are a lot of changes. This include that the placenta stops being the organ of the gas exchange. This is because we clamp and then ultimately cut and remove the placenta. The lung becomes the organ of exchange. The first few breaths transition the PaO2 from a hypoxemic environment to a normoxemic environment. So you all know that it takes around 10 minutes for the normal baby to reach saturations of 85 to 95%. This increase in the PaO2 results provides the much needed reduction in pulmonary vascular resistance and increases pulmonary blood flow. Along with that, the production of vasoconstrictors like endothelin, leukotrienes, and thromboxane is replaced by the production of pulmonary vasodilators, predominantly like prostacyclin and nitric oxide. All these processes result in relaxation of the pulmonary smooth vessels and the normally expected reduction in the pulmonary vascular resistance. So this is what we just discussed. But when this doesn't go right, we start seeing this entity called persistent pulmonary hypertension in the newborn. So the incidence is around 2 per 1,000 live births, and this is a condition where we start seeing right to left shunt across the major shunts. So the PFO may shunt right to left, the PDA may also shunt right to left, resulting in hypoxemia, resulting in differential saturations. If the PDA is also patent, we are going to see preferentially higher saturations in the upper limb before the right to left shunt occurs across the PDA, and lower saturations in the lower limb. We will start seeing clinical evidence of labile saturations like we saw in this baby, and differential cyanosis. So pre-ductal saturations more than the post-ductal saturations. What are the situations where we usually expect PPHN? So we expect PPHN in 3 different settings. One is a scenario like we just saw, when the baby has essentially anatomically normal pulmonary vessels, but these vessels fail to react, or they have abnormal vasoreactivity because of some stress. That could be in the form of MAS, RDS, sepsis. In preterms, RDS is the commonest reason for PPHN. In term babies, it is either asphyxia or meconium aspiration syndrome, or sometimes sepsis and pneumonia. The second scenario is when there is chronic hypoxia leading to excessive thickening of the pulmonary vasculature or muscularization, which leads to increased smooth muscle thickening that results from either chronic antepartum hypoxia or use of maternal vasoconstrictors. If mother had been exposed to SSRIs, NSAIDs accidentally, and over a period of time, this can lead to increased smooth muscularization leading to PPHN. And the third scenario is when there is abnormal low vascular development in the pulmonary vessels, which may accompany pulmonary hypoplasia itself when the lung as well as the vasculature may be poorly developed. And where do we see this? We see this in pulmonary hypoplasia accompanying diaphragmatic hernia or chronic oligohydramnios. So these are all some settings where we see PPHN. And what do we see because of PPHN? You start seeing that there is increasing pressure overload over the right side of the heart, leading to right ventricular increased systolic pressures that translate into right atrial pressures going up. There could be tricuspid regurgitation. Ultimately, the strain causes the RV to fail. There is bending of the septum towards the left side of the heart. This reduces the left ventricular compliance. Ultimately, all these changes can result in decreased cardiac output in general. So initially what starts as RV dysfunction ultimately will lead to biventricular dysfunction and cardiac dysfunction overall. The baby can present you with shock. The baby can present with hypoxia, significant acidosis, and differential cyanosis. So this is just a mnemonic for us to remember the various causes. Even TTNB, as described by Western textbooks as malignant TTNB, has been also found to be implicated in causing PPHN. But of course, generally TTNB is something that we do not expect to go that severe, and something which is progressively worsening in postnatal life generally kind of rule out the diagnosis of transient tachypnea. Of course, all other conditions, anything that causes parenchymal pathology like meconium aspiration, asphyxia-related wet lung, RDS, sepsis, and congenital anomalies like diaphragmatic hernia can be accompanied by secondary PPHN. Now, idiopathic PPHN may sometimes follow maternal NSAIDs and SSRI intake. We had a similar case where the mother had been on NSAIDs and that was given outside. The baby walked in last minute, presented with, was an extremely blue, severely cyanotic baby at birth. First echo even done at 2 hours of age showed no PDA. So that kind of clinches the diagnosis of this particular entity. When we went back and asked the family, they did tell that she had chronic joint pain and she was on NSAIDs, and she wasn't, told that NSAIDs should not be given. So if you find that kind of picture, always think of secondary and PPHN secondary to maternal NSAID intake, and this is generally associated with a good outcome. So what this causes is in utero closure of PDA, and this puts the right ventricle under significant strain, and this can result in PPHN-like manifestations right from the time the baby is born. So what we essentially see is cyanosis, hypoxia, inability to maintain saturations, particularly with lability and difference in pre and post-ectal saturation. And when you see hypoxemia, which is out of proportion to the respiratory distress, always suspect two things. One is PPHN, the other is cyanotic congenital heart disease. Very good. So I'm sure Dr. Sudeep will be talking to you about the echocardiographic findings in detail. So these are all the prenatal, aspects in history that we just discussed. At birth, one should actively ask for history of need for resuscitation, history of meconium-stained amniotic fluid, any history of antepartum hemorrhage that can result in asphyxia, birth trauma, the Apgar scores, and need for resuscitation. Assessment of signs of respiratory distress or severity of respiratory distress as measured by Downey's or Silverman score. Particularly look whether there is audible grunting, whether there are severe retractions and nasal flaring, which may be indicative of an underlying parenchymal disease causing secondary PPHN. Absence of signs of severe respiratory distress can be seen in idiopathic PPHN or cyanotic congenital heart disease. Now, with this picture of a hypoxemic baby, if you see the classical picture of pre-ductal SATs more than post-ductal SATs, we all know that the diagnosis is quite straightforward. It is a case of PPHN with right to left shunt across the PDA. And this can also be seen in some other problems. These are relatively rare. These have also been mentioned here. Now, what if you see that the baby does seem to have PPHN, but pre and post-ductal SATs are actually equal? Can this happen? All limb saturations low? When would it happen? Cyanotic heart disease, of course, is one. But let's say we are actually dealing with a newborn with PPHN, but you are not seeing pre-post-ductal saturation difference. What if PDA has closed? Okay, the same baby has sepsis pneumonia on day 7. Can the baby still develop PPHN? Yes, isn't it? So you will still have cytokines, pulmonary vasoconstrictors. The baby can still have PPHN, but if PDA has closed, the elevated pulmonary pressure is going to result in right to left shunt across only the PFO. So then all limb saturations are going to be reduced. You may not see the classical pre more than post-ductal saturation kind of presentation. This could also happen when the baby has severe parenchymal lung disease, and this can lead to intrapulmonary right to left shunt. So in this condition also, you will not see pre-postductal saturation difference. A rare entity where you see pre-ductal saturation, which is less than postductal saturation, this can only be explained if the baby has transposition of great arteries with pulmonary hypertension or with coarctation of aorta. But this is, of course, an exceptional scenario. So typically when you do a PaO2, especially a postductal PaO2, the PaO2s are going to be low, and generally in PPHN, the response to oxygen would be excellent. The baby will have a rapid response or increase when you give the baby adequate oxygenation. We all now are using more and more bedside echocardiographic techniques for diagnosing pulmonary hypertension. And this is a classical picture where you see in the apical four-chamber view, you will be able to see dilated right atrium and right ventricle, along with the presence of a tricuspid regurgitation jet. We will also see bending of the ventricular septum towards the left heart. Now, the X-ray helps us in diagnosing the underlying etiology that triggered pulmonary parenchymal persistent pulmonary hypertension, whether this was RDS, whether this was meconium aspiration syndrome. Sometimes you may have a pre-existing air leak already when you do the first X-ray. So you have all already told me how you're going to calculate OI. And we generally take an oxygenation index more than 20 as an indication for starting inhaled nitric oxide therapy. Of course, if the baby has escalating OI and reaching up to more than 40, particularly on high frequency oscillation with adequate recruitment along with inhaled nitric oxide, that is taken as an indication for extracorporeal membrane oxygenation. So when it comes to the management, delivery room management starts from optimizing oxygenation, temperature, hemodynamic status, right from the word go. Remembering the role for being developmentally supportive, remembering the role for preventing excessive stimulation and optimal analgesia for the baby. So I think this is coming up as a figure. So this is a kind of infographic that summarizes the principles of managing PPHN from Dr. Satyan Lakshmin Rasuma. He is a proponent in PPHN and very good with infographics. So you'll find a lot of his reviews covering this aspect of the holistic management of PPHN, which is what I think I would like to stress in this talk. So PPHN is not just about nitric oxide and ECMO. It is in fact more about supportive care. So these are all some of the principles. Optimize oxygen saturation levels. Now 90 to 97% is no longer recommended routinely. We are still happy to maintain a target range of 90 to 95%, provided the baby is not hypoxemic or hyperoxemic. We are quite happy with that. Remember to treat the underlying parenchymal condition. It could be RDS, and a dose of surfactant would be very, very optimal. Likewise, if it's meconium aspiration syndrome with predominant atelectasis, like in this baby, there could be a role of surfactant for optimizing the functional residual capacity. When it comes to ventilatory strategies, try to always be using strategy that will mitigate the ventilator induced lung damage by using the right PIP. Preferably try to not cross PIP of 24-25 in a term baby, a map of 14 in a term baby. If it's a preterm baby, you will want to target even slightly lesser pressures, and you may have to choose the rate depending upon the underlying disease mechanics. You may have to start with 50 or 55 or 60 in a baby with RDS, and much lesser rate in a term baby with meconium aspiration syndrome, ultimately targeting these saturations and also targeting PaCO2 levels within the target range of 45 to as much as 50, 55, or maybe 60 if it is beyond 72 hours of ventilation. Definitely, you do not want to target hypocarbia in these babies. Likewise, consider early high frequency oscillation if the baby is requiring MAP of more than 14 and PIP more than 28. When it comes to postductal saturation, remember that there is going to be a gradient until PPHN gets resolved. So in the task of chasing postductal saturations, one need not expose the baby's brain and the eye or the preductal saturations to hyperoxemic range. So as long as the preductal saturations are within the range, accept slightly lower postductal saturation in the interest of avoiding ventilator-induced lung injury and the interest of avoiding hyperoxemia and oxygen-related free radical injury to the brain and the lung. Also very, very important to target an optimal mean arterial pressure, which must be in the normotensive range. Again, we need not target blood pressures which are more than 95th centile. As long as they are between 5th and 95th centile, we are happy. So maybe I'll just cover the primary indication for inhaled nitric oxide, and I'll leave it there. So you are all aware of the 20-20-20 rule, isn't it? So OI more than 20. What are the other two 20s? INO at a dose of 20 ppm, and the third 20 is a improvement in PaO2 more than 20, or reduction in PaO2 FiO2 ratio by 20. And what is the other rule we have? There is another 60-60-60 rule. So you start tapering nitric once the FiO2 requirement has come down to less than 60%. So start nitric, the immediate effect that you should see is a decrease in the need for FiO2. Once you touch an FiO2 of below 60%, then it is optimal to actually start weaning down the nitric oxide. So FiO2 below 60, duration of more than 60 minutes, and PaO2 should have touched across more than 60. Probably I'll stop with this last figure, which based on the echo will help you to fairly reach a diagnosis. Even if we are not experts in pediatric cardiology, we have Dr. Sudeep and others who will always come to our rescue. But what can we do in the bedside? So you can look at the apical four-chamber view, and you can look at the direction of blood flow across the PFO and across PDA. Now, if you have a hypoxemic baby, let me start with the normal scenario. So what do you normally expect to see? So you have a baby, say, who has severe lung problem like RDS. You would normally expect a left to right shunt across both the PFO and the PDA. So here the problem is not the pulmonary vascular resistance, but there is some problem in the pulmonary parenchyma. So this baby has severe lung disease, and what we need to do is to optimize the mean airway pressure, optimize ventilation, see whether you're giving adequate PEEP, adequate peak pressure, or in other words, adequate MAP. And if needed, you may use a dose of surfactant for recruiting the lung. On the other hand, if you're having right to left shunt across the PFO and left to right shunt across the PDA, here the problem seems to be somewhere in the right heart, where there seems to be an obstruction to the right ventricular outflow tract. And in this situation, you may suspect a duct-dependent pulmonary circulation. Example, tricuspid atresia, it could be pulmonary atresia, critical PS. All these are neonatal pulmonary obstructive pathologies that can present in this fashion, where you will see right to left across AST and left to right across PDA. So here, awaiting confirmation, you are quite right in starting prostaglandin infusion. Even if you are not able to immediately get a cardiologist performed echo, you will still be able to salvage the baby by starting prostaglandin infusion. Of course, be aware of the complications or adverse effects of PG even. Now let's move on to the typical PPHN scenario, where you know that there is elevated pulmonary vascular resistance, hence elevated right ventricular systolic pressures. And here you are going to see increase in the right atrial pressures as well. So there is going to be right to left across both the PFO as well as the PDA. So this is typical scenario of persistent pulmonary hypertension, where apart from optimizing the ventilatory parameters by recruiting the lung, we are also going to use pulmonary vasodilators like inhaled nitric oxide, or perhaps sildenafil in a low resource setting where nitric oxide may not be available. Now, last scenario, if you have a baby who has a left to right shunt across PFO and right to left shunt across a PDA, this is a very, very dangerous situation. One of the situations where starting nitric oxide may actually be counterproductive, because this baby is likely to have a problem in the left ventricular function, and something is causing the left ventricular output to become compromised, which is causing left atrial volume overload and left to right shunt here. But because of the poor systemic output, there is right to left shunt from the PDA. So this is something like a RV dependent systemic circulation. Here, starting nitric oxide can lead to sudden precipitous fall in PVR, and this may increase pulmonary blood flow at the cost of systemic blood flow. So in this scenario, you may see the baby crashing down after you start nitric oxide. Okay, here it might be important to optimize LV function with milrinone before we start nitric oxide. So regarding ECMO, I think there is no real need for me to talk. So there is a definite role for ECMO, not that it's not there. There is data from, from the West that there are more than 5,000 ECMO runs in units with PPHN with 77% survival, which is fairly encouraging. We have had a very limited experience with neonatal ECMO. We have been able to do in a baby with meconium aspiration syndrome. Typically, VA ECMO is preferred in newborns, you all know that ECMO is a temporary strategy where you allow the lungs to improve or allow the lungs to get recruited and give some time for the pathology, underlying pathology to resolve. And the average duration of ECMO has been around 7 to 10 days. So with that, I think I'll thank Dr. Nitin for the opportunity. And this is our experience with nitric oxide in PPHN. Our survival, I think, has been close to 70 to 80%. Mostly with meconium aspiration syndrome, we have had 100% survival. Preterm and asphyxia, it has been plus minus. Thank you, Dr. Nitin, and you can let me know if there are any questions.
Thank you, ma'am, for this lucid presentation. Going ahead, I would like to invite Dr. Bhavani Deepti, who is a consultant neonatologist and pediatrician at KIMS Cuddles Gachibowli, to talk about golden hour management in preterm babies. Madam.
Good afternoon, everybody. I know I'm at one step between you and lunch. Even though the topic is golden hour management, I'll not be taking an hour. I will be as brief as possible. Pointer. Yes, to go ahead, what is golden hour? Why is it called golden hour? What is the importance and what do we do in the golden hour? What are the components of golden hour management? So actually, this concept of golden hour was adapted from the adult trauma in emergency medicine from Dr. Cowley. Reynolds et al. Was the first person to implement this golden hour concept, especially in the newborns. So it's a crucial time where neonate face lots of challenges, and optimal management during the first 1 hour of life can help us in reflecting better long and short-term outcomes of the newborn. We have certain special considerations for the preterm newborns, especially babies who are less than 32 weeks and also less than 1.5 kgs. So they have poor thermal control because of the larger surface area to body ratio, larger surface area to volume, and also larger surface area to the head ratio. They have inherent surfactant deficiency due to the immature lung development, immature adaptive systems to the stress, such as variable levels of catecholamines. They are susceptible to IVH and PVL. Apart from that, they have poor respiratory drive and also poor energy stores, and they are usually often born after a complication. And apart from that, adds to the highly stressed family that we need to deal with, not just the management of the newborn. So in addressing the golden hour, in optimal management of the golden hour, we can prevent short-term outcomes like hypothermia, hypoglycemia, hyperoxia, hypoxia, hyper and hypocarbia. And in preventing the long-term outcomes such as intraventricular hemorrhage, ROP, BPD, NEC, ventilator-associated pneumonia, and also neurodevelopmental impairment, which help us in intact survival rather than just the survival. So what are the components of golden hour management? It starts from the most crucial part of it, antenatal counseling and briefing. Apart from that, taking antenatal history from your obstetric team. Prevention of hypothermia, delayed cord clamping in vigorous babies, and resuscitation according to the NRP protocol, support to the cardiovascular and respiratory system, Prevention of nosocomial sepsis should be on the forefront, and aggressive parental nutrition should be started along with antibiotics and caffeine in the first hour of life. So it primarily points down to 3 areas where it is first prior to delivery, in the delivery room, as well as continuation of care in the NICU. So prior to delivery, what are the points that you ask in the antenatal history that pertain to this preterm newborn? Anybody wants to volunteer? Yes, yes. History of steroid cover in the mother, and if possible, when was the last dose given? And what else? In a preterm newborn, you're anticipating, for example, a 28-week delivery in your NICU. So first question you ask is history of steroid. Yes, what else do you ask? Yes, magnesium sulfate. The 2 primary interventions that will help us in the outcomes. Along with that, number of births. Is it a single or multiple? Is the baby steroid covered? Is the baby magnesium loaded with magnesium sulfate? And what are the other comorbid risk factors in the mother? Any Doppler abnormalities if it's an IUGR baby, and discuss the umbilical cord management plan also in case you have a vigorous baby. And the antenatal counseling also to establish a rapport with the family, make them aware of the risks associated with prematurity, the morbidities that the premature baby can have, and also have a note on the anticipated duration of NICU stay to make them prepare. And next is the team. Most important part of the golden hour management is the team briefing. Preparation of the team, including a neonatologist and neonatal fellow and a nurse or nurse practitioner, at least 3 people minimum, and allocation of the roles and responsibilities of each team member to have a clear idea of how and when each person comes into action. And another important part is the equipment check in the delivery room, as well as ongoing preparation of equipment and organization in the NICU simultaneously. So in the newborn care corner in the delivery room, what are the equipments that we need to check? So we have a simple mnemonic, TABCD, temperature. So starting from the delivery room temperature to be in correction from 25 to 28 to plastic bags or wraps, along with the humidified respiratory gases, to airway breathing comprising of getting a humidified respiratory gas, blended humidified respiratory gas, to organization for the equipment such as endotracheal tubes of sizes 2.5 and above, laryngoscope blades 000 and 00, ET plasters, along with due importance to the barrier fixation, skin barriers. Then next will be for the circulation, the pulse oximeter with the pulse oximeter probe, along with the ECG leads, and drugs such as adrenaline, normal saline, and surfactant and umbilical lines, along with the equipment. So the resuscitation will follow according to the standard NRP. And in the delivery room, as soon as the baby's head is out, you start the Apgar timer to check to correlate with the time. And in case the baby is breathing and crying, there is a provision for delayed cord clamping. If not, you will be handed over the baby where you follow the initial steps of resuscitation. So WHO recommends cord clamping to be delayed for more than 1 minute, and NRP says clamping should be delayed for at least 30 to 60 seconds. So what does delayed cord clamping do in preterm baby in contrast to a term baby? Because in preterm baby, there is one of the most common causes, one of the most common morbidities that we encounter is anemia of prematurity. So how does it help us? It gives us a higher circulating blood volume for the first 2 days. It gives us a better control of blood pressure and reduced need for inotropic support. It increases the blood flow in superior vena cava. It increases the left ventricular output, and it also has a higher cerebral oxygenation index, which also lowers the frequency of intracranial hemorrhage. When you look at the follow-up studies, there is a reduction in the risk of death or major disability by 17% at 2 years of age, and also there is a reduction in the relative mortality by 30% with delayed preterms who receive delayed cord clamping. So there is this concept of intact cord resuscitation that is coming up, more so practiced in the term newborns. There are studies where RIPC warmers have been designed, where the warmer will be kept just near to the baby, where placental circulation is going on while you resuscitate the baby. You do not detach the baby, you do not do the cord clamping. So what does it give actually? In late preterms and term newborns, how is it helpful in the short-term outcomes majorly? So it has increased oxygen levels at 1 and 5 minutes of life. It has increased Apgar scores at 1 and 5 minutes of life. However, there is no difference in the baby's temperature. Even though you are resuscitating the baby in the delivery room, there is no difference in the baby's temperature after resuscitation or higher bilirubin values at discharge. So there is no recommendation for cord milking. In fact, it is not indicated for cord milking. In case you are not able to practice delayed cord clamping in a preterm baby, you cannot do cord milking because sudden rapid boluses of blood can cause severe IVH of grades 3 and 4, especially in 23 to 27 weeks of gestation. So coming to the crux of delivery room management, even though it's considered the last, but it has to be given the first priority, thermoregulation. So how do you achieve thermoregulation? It starts from communication with the AC technician in the OR that delivery room temperature has to be down to 25 to 28. If you have a good communication and your logician can understand, she also will let you increase the OT temperature from 20 to at least 25. Then second thing is you start your warmer in manual mode, 100% heater output at least 30 minutes prior. You would start your transport incubator at the same time, and also the incubator that is supposed to receive the baby in NICU also will be started at the same time with 100% humidity. That starts, and slowly you can come down to 80% once the baby comes. Later, in the resuscitation area, in the resuscitor, you use pre-warmed blankets, you use the plastic, pre-warmed blanket, and warmer is already on, and a thermal mattress, most importantly, embrace or the thermal mattress to decrease the hypothermia. Then usage of a plastic bag or polyethylene wrap and a plastic cap, especially in babies who are less than 32 weeks. So do not dry the baby, bring the baby and put the baby in the polyethylene wrap with the cap on, and use warm humidified oxygen along with the blended warm humidified oxygen in the delivery room to see that the evaporative losses are nil. So there is a nice systematic review and network meta-analysis where they compared around 9 interventions, 8 to 9 interventions to reduce hypothermia in delivery room management, which said usage of a plastic bag or wrap with a cap or heated humidified gas was associated with lesser risk of major brain injury and mortality compared to all other interventions. So these are the 6 interventions that we follow: timer with temperature and the humidity, along with the polyethylene wrap or cap and the cap, heated humidified gas, blended heated humidified gas in your delivery room, and the warmer is in the manual mode with 100% heater output, the exothermic mattress or the embrace, and the incubator is already pre-warmed, ready to receive the baby. Why is hypothermia so important? Because 1 degree Celsius drop in the admission temperature can increase the mortality by 28%. So that this hypothermia can nullify the effect of steroids that you have given. Coming to the respiratory management, neonates will be resuscitated as per NRP guidelines. A spontaneously breathing neonate can be taken over by delivery room CPAP with FiO2 starting at 30% and PEEP of around 5 centimeters of water. In case the baby is not spontaneously breathing, you can start positive pressure ventilation, preferably with the blended humidified oxygen rather than PPV or just the TP's resuscitator where you give 100% oxygen. So which one do you use? I know bag and mask is easily available. This TP's resuscitator with no blending is also easily available. The ideal one would be using blended humidified oxygen in the Resus Plus, especially in the delivery room and also in NICUs where you cater for preemie babies. The optimal oxygen FiO2 to start during resuscitation of babies less than 35 weeks would be 30%, 21 to 30%, and more than 35 weeks would be at room air. So there are minute specific target preductal saturations that have been given. So the aim should be achievement of saturation around 80 to 85% at around 5 minutes of life. So do you guys use sustained inflation in your units? So what is sustained inflation? Sustained means the pressure of around 20 to 30 centimeter of water is given for around 5 to 15 seconds, which can be given to 1 or 2 breaths. That was the initial idea when they started the sail trial. But because of the increased mortality in this SLI group, that is out of 16 babies died out of the first group, where the standard resuscitation alone was favored in the forest plot. You can see the trial was stopped early and sustained lung inflation is not recommended now. So more than 25 weeks, a trial of CPAP can be given. In less than, the situation comes where the baby is less than 25 weeks or baby is a micropreemie, where CPAP can not be sufficient and requirement for intubation and surfactant will follow. So if you compare CPAP versus intubation, obviously CPAP will score higher because it reduces the incidence of BPD, the trauma of intubation, trauma related to pressure or volume or gas or endotrauma. The combined outcome of death and BPD and mechanical ventilation will reduce when you compare CPAP versus intubation. So it will start with CPAP, and in case the early rescue surfactant rather than prophylactic or the late rescue surfactant, even on a spontaneously breathing unit, you can give surfactant. It need not be insured, which was practiced earlier. It could be by non-invasive methods like LISA or MIST or through LMA. And the gentle ventilation strategies where you target only 4 to 6 ml per kg and the target saturations 90 to 95, not more than that. So early rescue surfactant that is given first within 2 hours is preferred over delayed rescue or over prophylactic also, because it is shown to decrease the incidence of BPD. It has better survival and the chances of redosing is less. Ensure was the method that was followed previously. Less invasive surfactant administration or MIST is followed now. Do you guys practice LISA in your unit? How many of you practice LISA? So on CPAP, you guys practice LISA, right? So I could see around 3 or 4 people who do LISA. So the idea is there is still a learning curve with the advent of LISA catheters into the country. Previously, there was a situation where it was given through OG catheters or angiocats. With the advent of surfcats in the country, LISA has become even more popular and it's feasible in our setting also. So caffeine for apnea of prematurity, the landmark trial by Barbara Schmitz, where caffeine was started in babies less than 1250 grams, less than 30 weeks, and also more than 30 weeks where they require significant respiratory support. So the outcomes were initially, there were less BPD, there was shorter duration for mechanical ventilation. Even though the 5-year outcome was not very satisfactory, the 11-year outcome showed reduced risk of motor impairment, improved visuomotor, visio-perceptional, visio-spatial abilities. We do practice caffeine along with the antibiotic and the TPN, caffeine within first hour of life. So cardiovascular system, assess the hemodynamics, the capillary refill time, blood pressure to be followed according to the centiles, maintain the normal perfusion, early detection of shock, lactic acidosis or metabolic acidosis can help support in the cardiovascular system. Hypoglycemia is a very frequent occurrence in ELBW newborns. So it should not, administration of glucose will not wait till you establish umbilical lines. The IV access should be established in the delivery room within 1 hour of life as early as possible. So coming to the nutritional care, because the baby is also in a metabolic urgency. So you establish central lines. With the peripheral line itself, you can start the fluids, just the fluids. And once the central lines are established, you can start the total parental nutrition. Okay, you usually start at a GIR of 4 to 6. 6 should be the usual target, 6 mg per kg per minute. And also prime the mother, prime the family in the antenatal counseling that she needs to express milk. The earlier, the better. Earlier, the better, even though it is just, that can be used just for oral mouth care. Earlier would be the better because that will help in her cycle. Then start of total parental nutrition. Coming to the investigation, a point to note here, to prevent anemia of prematurity, the first CBP, the first blood gas can be taken from the cord samples. Gas and the CBP can be taken from the cord sample as well as the blood group also. The culture and glucose can be taken once you establish lines or your peripheral IV, and the chest X-ray for confirmation of lines and the other plastics. So another last important part is the documentation, where you document all the resuscitation details, timing of surfactant replacement, temperature the temperature at admission will be one of the key quality indicators for our resuscitation. Timing of installation and umbilical catheterization. Once you check the X-ray, you see where your ET tube is placed, where your lines are, where your OG tube is placed, and how are the lungs. Last would be the prevention of nosocomial infection, because neonatal sepsis and prematurity are the leading causes of morbidity and mortality in any neonatal care. So not to add on sepsis to prematurity, prevention by following strict protocols, bundle care approach, and having a rational antibiotic stewardship program. So aim should be always about prevention of physical or mechanical injuries, prevention of medication errors, because it's a preterm baby, the response is totally different, prevention of acute lung injury and intraventricular hemorrhage. So gentle handling, placing the baby in midline, following gentle ventilation strategies, avoiding infusion of rapid IV boluses or bicarbonates or any hypertonic solution, and also prevention of hypoglycemia can decrease the brain injury. And lastly, once the baby is stabilized, it's our duty to communicate with the family, bring the parents or bring the father especially, or anybody in the family, to look at the baby, understand what the baby is going through, and have create a social environment where they can communicate their issues and lessen the economic burden as much as possible if there is a possibility. So how do we implement this concept of golden hour? Simulation-based teaching. First is the simulation-based teaching, where you allocate rules, do the equipment check, understand how the whole process goes through to look at a real baby. Then quality improvement initiatives, follow a checklist for the equipment in the 3 places, and allocate your team member in the team, and posters and reminders. So in a nutshell, the preparation starts prior the delivery, resuscitate and stabilize the baby in the delivery room, then give the admission orders, follow the antibiotic, caffeine, starting of the IV access and glucose, then send the labs, give antibiotics, then would be confirmation of the plastics that are on the baby, administration of TPN, and getting shifted to NICU. It's just 1 hour in your daily duty, but actually that 1 hour is quite important for that single baby alone, which can influence the whole life of the baby. Remember, we are giving life to a 60 or 70-year-old babies. 70, we are creating a future for a 60 years or a 70 years future for a human being. So just 1 hour itself can influence so much. So that is why it's so important. Thank you.
Thank you, Dr. Bhavani. In a nutshell, what I understand, 60 minutes of labor will give us 60 years of a healthy life. And to take this discussion further, I would like to invite Dr. Babu, who is Clinical Director, Head of Neonatology, and Director of KIMS Cuddles, Secunderabad, to talk on neuroprotection in neonates.
Thank you so much. Everybody was saying I'm the last person standing between you and lunch. The matter of the fact and the truth is I am the last person. Okay. So what is not normal attention span of a human being? They say it's 15 to 25 minutes. I think we have 15, not 20. 25 is the upper limit. That's why the classes, the periods are made so in such a way. 40-minute schedules are there in the schools, wherein the teacher has to take 5 minutes break, or he must deviate from the topic and then restart. Now we were given 20 minutes, time slot to finish our talks, but then we are delayed by some time. I think, anyways, I'll try to. The topic given to me is the practices to improve the outcomes, especially the neurological outcomes. There are a number of interventions that we can do, but I'll just try to be very brief. Good number of my my topic has been covered by Dr. Aparna and Dr. Deepti. Yeah. Not working. Yeah. So yeah. So if you look through this, this is graph representing neonatal mortality rate over a period of time. Initially, when we were doing our MD times and MBBS times, and even before that, neonatal mortality rate was in the, in the terms of, in tunes of 50s, 60s, 70s. All those areas marked in red are all the areas where neonatal mortality rate was 50s, 60s, 70s, 80s. Now, over a period of time, what has happened, the government has taken a good initiative. Government has taken a very good initiative and has been putting a lot of efforts. Even more and more pediatricians are able to take care of more and more very low birth weight babies, and more neonatologists are taking care of extremely low birth weight babies, which is why we are seeing over a period of time there has been sustained improvement in neonatal mortality rate. It is actually falling down. There are areas wherein we have achieved single digit mortality, but then there is the other end of the story. Initially, we are having low survival, high mortality, but now there is although good survival, but there are morbidities. We are actually adding large number of babies who are either neuromorbid, whether it is visual, motor, language delay, or some kind of addition to the society. This actually causes a lot of burden to the society in terms of finances, a lot of emotional burden to the family as such. So we need to do our interventions in such a way that it has to be an intact survival. The survival has to be intact. I just start with a case scenario. Since morning, I've been seeing various number of speakers are giving, delivering their talks with the help of case scenarios. What actually happens in case scenarios, we actually share our experiences. At the same time, we also tend to show what the guidelines are, and it's easy to make, easy to understand. Let's start with one of the case scenario. There was this baby born by emergency LSCS, indication of which was fetal distress. Baby had a weak cry, and baby was observed by pediatrician for around half an hour and then shifted to mother side. He thought baby must be good. At around 7 hours of life, mother woke up from the anesthesia, and she saw that baby was having poor feeding. Pediatrician was called by the mother, and the pediatrician saw the baby at around 8 hours of life, and he thought that baby is having some kind of seizures, subtle seizures. So this baby was shifted to a bigger hospital, and then baby was treated with anticonvulsants. Supportive care was given, and baby was treated for a duration of around 1 week, and then discharged home. Everything looks simple, going easy. And then this baby came back at around 8 months of life, hardly able to sit, not attaining milestones, no neck control, no eye-to-eye contact. So could anything be done? Whose is it the fault? Is it the fault of obstetrician or pediatrician who was attending the delivery? Or is it the fault of a pediatrician who has seen the baby all through 1 week of duration, or nobody else's? The outcome has not been great. Everybody has done their work. So this is a real scenario that we actually face. So objective is to understand neuroprotection strategies. I'll tell you by the answer to this in a different example. There was this similar kind of example wherein baby was born by emergency LSCS, indication of which was abnormal Dopplers again. Baby did not cry, very poor Apgar scores of 3 and 4, received bag and mask, bag and tube ventilation, and then got stabilized. Refer. This is a photograph of the baby who's well ventilated, saturating well, blood pressures are within normal limit. Within 1 hour, this baby was referred, and this baby received, whole body cooling because this baby was suffering from, severe birth asphyxia. This is the picture of the same baby at around 7 months of age, almost sitting with good support. There is very good eye-to-eye contact, neck holding is perfect. So baby has almost achieved all the milestones. So what is the difference between the first example, first scenario, and the second? The first or management, beyond that, whole body, therapeutic cooling. Cooling was offered to this baby within, we have to offer it within the stipulated time of 6 hours. So if you delay it, the benefit cannot be given. Now, cooling is the standard of care for babies who have suffered from moderate or severe birth asphyxia. We have to offer cooling. Just supportive care, just anticonvulsant medication doesn't help in terms of long-term neurological outcome. So which are those, the points which we have to take care as far as neuroprotection is concerned? Prevention of hypoxemia, hypoglycemia, management of perinatal asphyxia. Preterm units it itself is a different topic. Management of infections and nutrition, we don't have to emphasize on this again. Now, this part has been again covered regarding neonatal, the point regarding hypoxemia. This baby was born by emergency LSCS, indication of meconium stained liquor, and baby did cry, although well at birth. These kind of scenarios we tend to face in our real life, situations. This baby had, although had very good cry, was started on head box oxygen, which many of the centers still do this practice of starting on head box oxygen. Started on head box oxygen 6 liters per minute, and then it was seen that baby was maintaining saturation within normal limits of 92 to 95. So normal tendency, what we see, we put the baby on oxygen, saturating well, we tend to become complacent. We feel, yeah, baby is doing good, saturating well. Although there was meconium aspiration, meconium stained liquor seen before, but then baby is now doing well. We tend to be complacent. At around 6 hours of age, what was seen was this baby was having worsening of distress, and baby was not maintaining saturations well within the normal limits. So the normal dictum or normal understanding in pediatrics, when we try to target the saturations and when the saturations are maintaining within the normal limits, we tend to become little, complacent. We try to taper down the settings and all. In neonatology, it is little different. There is something called as microatelectasis. What actually happens over a period of time, the ends of lungs, the alveoli tend to collapse. Slowly, this collapse keeps on piling up, and then maybe after a few hours, we tend to see there will be atelectasis, which will require more pressures. So we have to continue these kinds of pressures. It is not just oxygen, good amount of pressures that we need to also give during specific time. So there is a lot of skepticism with respect to usage of delivery room CPAP. Dr. Aparna was saying importance of usage of CPAP in meconium aspiration. When we say meconium aspiration, we tend to have a thought in the mind that it is something which simulates bronchial asthma, which simulates something where there is expiratory obstruction. But when we offer CPAP to these kinds of babies, it helps in stabilizing the upper airway. It helps in distending the lower airway. It helps in uniform distribution of surfactant. It also helps in stabilizing the chest wall. So thereby, it helps in prevention of the sequelae of the meconium aspiration, which is PPHN or furthermore, or air leak syndromes. So had we used meconium aspiration in that situation, had we used CPAP, we wouldn't have let the baby to go into further sequelae. Now this baby was treated with whole lot of inotropes, nitric oxide, and high frequency ventilation. It took a very long time for this baby to be revived back to normals. Now, principle of management of meconium aspiration with PPHN has already been covered, which include ventilation, reduction of pulmonary vascular resistance by usage of nitric oxide, supportive care, and also maintaining good systemic vascular integrity. Now coming to hypoglycemia. Hypoglycemia is extremely important. The management of hypoglycemia in newborn babies is extremely important. You must have read in the newspapers with regard to ROPs. Now suing a doctor for failing to screen ROP has become a fashion. So every other day you see people getting sued for failing to screen ROP. Now time is going to come wherein the hypoglycemia, if you're actually failing to screen, then we might be in a bad soup. So NHS is an authority in UK which takes care of the health. It has kept aside 235 billion pounds just to settle 60 cases of failed screening of hypoglycemia. Such is an intense situation. So we have to have a uniform protocol to treat or to screen and then to treat babies who are having hypoglycemia. As such, our aim has to be made in such a way that it should be a never occur event in our units. And if you just go through one of the study, this published in JAMA, it was seen that in long term also, it has a very bad outcome in terms of executive visual motor dysfunctions, and the highest rate of these kinds of things, neuromorbidities were in hypoglycemia were seen in babies who were actually were prone for hypoglycemia. So which are those babies whom we have to screen? Babies who are premature, SGAs, because they have lower reserve of sugar. IUGR babies for the same reason. Babies who are having perinatal stress, sepsis, asphyxia, and the babies who have polycythemia because of the increased requirement of sugars. Of these, IUGR babies and the babies who are having stress are the ones whom we have to concentrate on. So if you see through this picture of a IUGR baby, so many axillary folds, more than 2.5 folds indicates IUGR. Similar is the region. So these babies are prone for developing hypoglycemia. So we have to actively screen for it. There is one screening modality as advised by AAP for late preterm babies, wherein they classify before 1 hour and beyond 1 hour, and cutoffs are different. Every unit, based on their experiences and based on the feasibilities, they can have their own protocols to screen for hypoglycemia, because hypoglycemia is associated with irreversible, catastrophic, severe damage to the brain. Now, coming to perinatal asphyxia, we already had touched on this in the first case scenario, but just to flip through, the definition of asphyxia is different as per the different organizations. AAP or ACOG says that there has to be presence of all these 4 criteria, which includes metabolic acidosis of pH of less than 7, Apgars of less than 3, encephalopathy with MOTS. WHO says failure to initiate or sustain normal breathing. So sometimes in real life scenarios, what we see is that we may not have ABGs in all the centers to see for, look for metabolic acidosis. There might be some times wherein the Apgars have not been recorded, either because the pediatrician has not been able to attend. And so sometimes we tend to not to have all the 4 criteria. So in those situations, we have to have some pointers which will act as surrogate markers to suggest it as to babies suffering from birth asphyxia. So which include hyperalertness, irritability, jitteriness, bradycardia with heart rate less than 100, and kidney injuries. So there are various pooling criteria. The standard, there are so many of them, but 2 things we need to remember. One is it is offered to bigger babies who are 36 weeks and above. And the offering of pooling has to be done within the first 6 hours. Because when the birth asphyxia occurs, when the encephalopathy, the process is happening, there is first injury, which is called as primary injury, and the second injury is secondary. The cooling helps only, when you offer the procedure before the onset of secondary injury. First primary injury has already occurred during the time of delivery, but we have to make sure by offering cooling, we are postponing the secondary injury, or we are letting secondary injury to not happen. Now, coming to neuroprotections in preterm units. We all know that corticosteroids are beneficial in improving the respiratory outcomes. We know they can be called as invention of the centuries because of the fact that the usage of surfactant, CPAP, mortality, NEC, sepsis, all of them do come down. But then surrogatively, they also are known to help in decreasing IVH, PVL, thereby decreasing cerebral palsy, thereby improving the neurological outcomes. So this is the same thing. And coming to magnesium sulfate. Magnesium sulfate now has become a norm. Magnesium sulfate, we all during our MBBS times, we used to read about magnesium sulfate, wherein magnesium sulfate was used for situations of preeclampsia and eclampsia. But now in all those mothers, all delivering mothers in whom there is impending preterm delivery within 35 weeks of gestation, even if she is not having preeclampsia and eclampsia, we have to actively give magnesium sulfate. So there's a whole lot of evidence from this, whether it is ACT Max 4, Pre-MAG or BEAM, and there are a large number of societies which could be American academies, Canadian academies, Australian academies, everybody is suggesting to use magnesium sulfate because it has been shown that usage of magnesium sulfate has been beneficial in decreasing cerebral palsy, helpful in improving motor skill dysfunctions and mortality as well. So dose remains the same. We have to give loading dose of 4 grams followed by 1 gram per hour for 24 hours. The most important point in this is we have the evidence and we know how to do it. The point comes, I mean, the feasibility issue comes wherein we actually, it becomes a little difficult to convince the obstetric colleagues to start doing this. There are some centers which are using it, but there are some centers still not using it. So it takes little, initiative from our side to show the evidences and help the, transition of the practice. But then one very important thing is, just because of the fact that we are giving magnesium sulfate, we should not delay the process of delivery. If the delivery is happening, let it happen. And this part has also been covered about the importance of delayed cord clamping. If you see, logically think, the blood which is present in the placenta belongs to the baby. The blood which is present in the placenta should go back to the baby. That is a common understanding. So what actually happens if you cut the clamp early, the good amount of blood, which is around 30 ml to 50 ml, stays back in the placenta and gets wasted. It doesn't go to the mother. So if you leave the blood, if you let it flow to the baby, we can make sure, I mean, the evidence also says that the cardiac stability is very good. There is decreased incidence of IVH, NEC is normalized, and a long-term iron stores are very good in the baby. So the amount of, this kind of intervention doesn't require any great, equipment or any great, it's very cheap, easily feasible, and can be done with just change of our mindset. But the kind of outcome that it has is very, large. The only one side effect that people say is that the chances of phototherapy in those babies wherein the delaying has been done is more, but that is still acceptable for large amount of benefits that we are accepting, having. The one little lesser kind of, less intensive side effect can be acceptable. So just carry a message, just to wind up. So in meconium aspiration syndrome, wherein PPHN has been anticipated, it is very important for us to recruit early and refer early. Hypoglycemia should never be an event. In absence of ABGs, in absence of Apgars, surrogate markers like jitteriness and bradycardia can indicate encephalopathy, and they are the ones wherein we have to start or initiate cooling therapies. But most important thing is early initiation of cooling therapeutic hypothermia is very important because time is brain. If you cross 6 hours, we have actually damaged baby's future outcome in terms of neurological outcomes. So with this, I wind up. Thank you so much for your patient hearing. Any questions we can discuss in the lunchtime.
We are not breaking for lunch. Don't worry. I am not the last person. He is the last person. I am giving my topic after lunch, but we need to finish in time. We know that you all have been very patient since morning, tired, but it's an interesting topic which is coming, and we will take one half of the cardiac portion before lunch, then we split for lunch, then we finish arrhythmias after lunch. Okay, and that will bring us back to the timing so that we finish our session by 5. Okay, just bear with us for another 15 minutes. It will be another interesting talk. Yes.
Sorry for breaking it. I will be sharing of online education initiative that we have launched on behalf of KIMS Cuddles. It's online neonatology education. I think some of you probably are aware of it. We have every Friday with us in the 4 minutes ICU. We have finished some topics on ventilation, respiratory support. We have also covered some topics on hemodynamics. The CME has taken some talks. Our neonatal team consultants have taken some talks. We have now started out with gastroenterology, nutrition, cases. I'll share the playlist of all these YouTube talks, which you can access anytime at your leisure. And those of you who want to join live can join the Zoom link, which we will keep posting on our various social media handles. So whenever you have time, you can log in and view this video. Just wanted to tell you all that.
Sorry, extremely sorry because I have to rush somewhere. So it's just a myocarditis. There are two things only there. Okay, this is just whether the concept of clinical evidence of whether you have to give IVIG or steroids or not. Next, you. So just two case scenarios. 10-year-old history of viral prodrome, features of cardiac failure, chest pain, LV dysfunction, high troponin, severe LV dysfunction, a mild MR, ASO titers are done, but they not did any of the other things. And now this is the severe LV dysfunction. So now the concept when they referred to us started on the routine care, secondary causes ruled out as a cardiologist, probable clinical myocarditis. So now the question comes whether to give IVIG or steroids, either one of them or not to give. In this case, what happened? They're not given, and ultimately this is the result after 4 weeks to 6 weeks. They come with the severe DCM. The first case scenario. Second, 13-year-old with history of viral prodrome, okay, with LVID disease score is less than 3. Okay, high LVF of 40, high troponin, ECG changes. Again, this is a severe LV dysfunction. Here it's a positive for adenovirus. We send viral marker this time, PCR we send, receive IVIG steroid, hospital admission for 8 days, discharge on carvedilol and diuretics, and this is after 1 week. It's a good LV function. So now it comes up to the concept whether in the myocarditis where you did the DCM and 9% of that with the myocardial biopsy turned out to be the myocarditis. So with that, whenever any myocarditis you are suspecting, there are the 3 criteria: biopsy, MRI, and the clinical diagnosis, which half of them we are not able to do MRI and the biopsy. So then you have to go with the clinical diagnosis of that LV dysfunction, troponin, chest pain, any symptoms, and ECG. And better now there is a viral PCR and all coming with the marker. So better to do that so that we'll make sure that there is a viral component is start there. And whenever it's there, with the all evidence, it's showing that you have to give steroids as well as the IVIG both for the improvement. Clinical practice, it's a difficult to convince the parents for that sometimes for the IVIG rate, but it's all because the impact of not giving is much more higher. It's better to overtreat than that. And with that, the good thing with or bad thing with the COVID experience, we come to know all myocarditis, IVIG steroid works very well. So this is the just the criteria for the MRI, which we're not able to do. In the viral, there are 3 phases: viral, autoimmune, dilated. So this is the phase we have to act because here where the viral marker and the viral replication is the maximum. So here where we are bound to give the immunomodulator because immune mechanism like mimicry, autoimmune, receptor, all are involved in that. So here is the effect of steroids, but literature shows enough alone steroid will not work in the myocarditis. As per the all literature shows that they have no difference in the mortality over the long term. But when it comes to IVIG, which is the main immunomodulator, and when you combine both suppressor as well as the modulator, the effect are good. So now this is one of the very recent paper that shows once you give on the both, the present not suppose corticosteroid alone on the superior to IVIG, but when you give combine, it has got the good. These are all so this is the one of the last paper with the recent, they considered all other that shows in a single center retrospect in Seattle. In that they treated all with the IVIG as well as for 48 hours high pulse rate, and over the week they will taper. With that, they found out 70 to 80% improved with the function. Within 1 week, 60% improved. Although they did all biopsy, MRI and few, or in 20%, they did only go with the clinical criteria and they found out it to be useful. So this is the curve in that same, they shows within 10 days, 5 days, the LVEF improved and become normalization. So with that, I search all other papers. This is one of the paper recently that shows excellent recovery with both. But when you see alone with this is the Cochrane data that shows even with the 10 years old, it's not improved alone with the corticosteroids or IVIG alone. But when you combine suppressor as well as immunomodulator, it becomes very good. So what the topic given when still I am unable to follow this before 1 year, we are just seeing and checking the secondary cause and whether to give. Now we are reinsulating and pressing the parents to purchase IVIG and give steroids pulse therapy so that the results are better. And with the extrapolation of the COVID data as well as the Kawasaki disease, which also had got the same mechanism molecular mimicry, we found out they are much useful as compared to other. So this another paper that there are so many papers from all over the world in the recent. You see all are 2020 to 23 in the COVID phase, and without COVID MISC also they found out all to be useful. So in general, this is a recent sign. So if any, no, first you have to rule out secondary cause. If then you have to see all those clinical troponin dysfunction. But there is one thing, when the LVID is more than +3 Z-score, that means it's already burned out or there is a previous dilated cardiomyopathy present over that myocarditis. So your LVID should be always less than 3 Z-scores. So this is one of the thing, and then you have to deal with the ECG biopsy, and then if not, do with the clinical criteria, and better to overtreat than undertreat. This is one 18-month-old diagnosis DCM and following it as DCM, failure to thrive, but nobody checked the ECGC. So this is the ECG. You can see there are deep Q waves. So it followed at DCM. So our onus is on the pediatrician to first or the cardiologist. Whenever DCM is there, like CP, it's not, it's a blanket term, but you rule out other causes of neuro damage. In the same way, DCM, you have to rule out other causes. There are deep Q waves. And then we found out there is a severe LMCA stenosis, which was missed during early surgery. And then we found out, and now we did the surgery, and the child is doing very good. So it's a congenital. So in the first corner, wherever myocarditis, rule out the rheumatic rule out, you rule out any secondary cause of coronary abnormalities. And then this surgical correction one now 5 years is doing it. This also, sorry to say, but it missed by so many people. You can see there is an unequal persistence followed up at DCM. But there's calcification in the aorta, and it found out to be the nobody checked the lower limb pulses properly. It was just the Takayasu arthritis. So onus on us when DCM first rule out secondary causes and then try to put into the clinical criteria of the myocarditis. If not that, MRI possible, do biopsy do possible. If not, then clinical criteria, what is there? And the viral panel, it's good now, it's easily available. The last second patient which improved turned out to be the adenovirus positive. So when we have that evidence and with the high troponin, and then we can tell easily you can give the immunoglobulin steroid. So whenever any dysfunction, these are the treatable causes. Apart from that, if the myocarditis also, do and better to overtreat than undertreat. In practice, what we are doing, IVIG is still not given in all. Viral panel, we are not doing routinely, but it should be done routinely. Biopsy, MRI, not often done because of the so many practical factors, and we miss the golden period. So now what the evidence showed, doubtful steroid use alone, doubtful IVIG use steroid alone, but when you use both immunomodulation as well as the immunosuppression, both will help. And this can be extrapolated by the KD and the MIS in the recent time. So take home message, any myocarditis, check the infectivity, make diagnosis as well as the inclusion criteria, rule out secondary cause. I showed you 2 examples, IVIG and corticosteroid therapy. When in doubt, better to give, better to overtreat than undertreat, because once it gets the dilated, burnt out phase, the only option is transplant and the outcome is very bad. So assessment on the follow-up is compulsory to see the check. And once they get, better to do the MRI even on the follow-up. With that, thanks a lot. And sorry for coming.
So now no one is standing between you and lunch. Finally, we are breaking this cycle of me and lunch. In a nutshell, what I want to say is, with this incredible lineup of subspecialties of neonatology, nephrology, half of cardiology and pulmonology being covered, basic assessment by doing a good physical examination of neonate or infant or bigger child, whomsoever is coming to you. Make sure you rely on your physical examination, checking pulses of all 4 limbs, doing BP in all 4 limbs saves a lot of life. And Takayasu arthritis as a concluding case, which can be picked up but was missed because nobody has taken 4 limb pulsations.
Forefathers are very much better clinician than us. We are little bit, we are not as good as them, but now the new generation, even it's not good because we are not doing routinely.
So let
we have to reinsulate the fact that you have to touch the patient, see saturation, monitor X-ray ECG, your 50% of the things will be in your differential diagnosis.
Physical examination is a key, is very important. With this, we'll break for lunch, and we hope to see you all soon with no sleepiness in arrhythmia session, which I will take. Thank you.
Thank you.
కావాలి మేడం రేపు ఇస్తాలే మేడం మండే ఇస్తాను
It's an add.
వీడియో అందరికి
वीडियो मैं कर
Hello, 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 hello.
Good afternoon, everyone. Welcome back after lunch. So here we are going to talk now about cardiac emergencies, where we are going to talk mainly about the arrhythmias, heart blocks, cardiac arrest, and syncope. That means I'll go from the spectrum which is higher end and will end with a simple trivial problem of syncope when it comes to your ED. Without taking much time, we all know what is QRS, what is P, what is interval. But when we talk about ECG evaluation, QRS duration defines whether we have to think about arrhythmias or not. So a narrow QRS tachycardia and a wide QRS tachycardia, these are the two forms of tachyarrhythmias. Whenever there is bradycardia and duration is different, we call it bradyarrhythmias. We should always remember that in pediatrics, the heart rate varies with age. Thus, the duration of normal QRS duration also changes with age. In a nutshell, each small ECG box is 0.04 second and normal QRS duration is two small boxes. If the QRS duration is less than 2 small boxes, then you start thinking about tachyarrhythmias if heart rate is beyond the normal range for the child. If you are looking or taking care of a kid with tachycardia, with pulse, you notice QRS duration, try to see whether it is a wide complex, whether it is a narrow complex. Whenever you come across a narrow complex tachycardia, check whether it is regular with P wave present. If it is present with P wave, the differentials will be sinus tachycardia, atrial premature beat, can be SVT, can be flutter, focal atrial tachycardia, re-entrant AVNRT, atypical AVNRT, and the line will increase. Do not confuse yourself with etiology. In emergency, make sure you do not miss the identification of an abnormal ECG. If QRS duration is 1 small square, it is a narrow complex QRS. Age is second in consideration, duration is first in consideration. Similarly, if narrow complex is irregularly present, you should start thinking about atrial fibrillation, atrial flutter, multifocal atrial tachycardias. When the QRS complex is wide and it is regular, this can be SVT with aberration, this can be ventricular tachycardia. 95% of children with wide complex QRS are actually SVT with aberration. Ventricular tachycardia is not a very common arrhythmia seen in ER as walk-in. Yes, it is one of the commonest arrhythmia in cardiac surgery, post-cardiac surgery, or in cases who are in ICU and are very sick or on multi-organ dysfunction. Then we talk about irregular wide complexes, atrial fibrillation or atrial flutter with atrial fibrillation with aberrancy, polymorphic VT, Torsades. All these comes whenever we have an irregular wide QRS complex. Let's see how various waveform with clinical parameters are shown on a ECG waveform. ECG rhythm strip comprises of small square, and all 5 small square makes a bigger square. So the distance 0.04 into 5 is 0.2 second. 5.2 second will make a proper number. So when we take a rhythm strip, isoelectric line and first positive deflection is P wave. Q wave is the first small negative deflection. Second positive deflection is QRS. Last, after the second negative deflection is S. Then there is a ST interval and a positive deflection is T wave. Between T wave and P wave in hypokalemia, another positive deflection comes that is called as U wave. We are not going to discuss those today. Here we are going to focus on ED, manifestation of simple pulse-based rhythm, and how can we manage them. Sinus tachycardia, most common causes are decreased effective circulating volume, hemorrhage, yes. Hypovolemia because of loose motions, yes. Impaired cardiac function can happen because of this, can also cause cardiac sinus tachycardia before going into SVT. Hypoxia, pulmonary embolism, hyperthyroidism, DKA, fever, infection, withdrawal, pain, anxiety, anything which has a reason will lead to sinus tachycardia. any arrhythmia which has no significant history, but your QRS is narrow, this is one of the most significant pediatric cardiac arrhythmia. 20% of this has trigger from infection, and also our commonly used sympathomimetic oral cold remedy can also cause SVTs. So giving right, left, center oral medication to decrease cough and cold, you should also remember that this may also lead to abnormal arrhythmias in some of the children. So stay cautious when you recommend a medication. In one liner, I would like to say, when you recommend a medicine, ensure that the component which are in that medicine, you know the complications because of that component. Usage, you have known. Complication and adverse effect, if you are aware of, it will make your practice safer. Heart rate in supraventricular tachycardia range between 150 and 300. There are specific cutoffs in infant and above infancy. We are going to go ahead with that. Usually the clinical feature of SVT present depends on age of patient, rate and duration of tachycardia, whether there is associated congenital heart disease. Most common findings in adolescent is palpitation, shortness of breath, chest pain, dizziness, syncope, irritability. Irritability as such is one of the most common presentation in neonate also. One day neonate excessive crying, you go for ECG, no, you do not have any reason, you go for ECG, you get a SVT. Start treating immediately. So our understanding of presentation of arrhythmia varies with age, and then comes, if we identify with a thought process, we intervene immediately. Heart failure is very uncommon in a patient more than 1 year of age, and it is usually associated with congenital heart diseases. If SVT is not being diagnosed for more than 24 hours, uncompensated SVT leading to cardiac failure is also known. Narrow complex tachycardia generally have a P wave which is not seen, and it can also be inverted just after QRS complex, or it may precede QRS complex. Ventricular complexes in SVT are usually normal in contour. If at all there is an aberrant pathway, then we see a delta wave, which is WPW syndrome, which is a characteristic feature of WPW syndrome. There will be 1:1 AV conduction, and atrial rate can be between 180 to 240. SVT means supraventricular. AV node, the start of rhythm is above ventricle. Now it can be AV node, it can be above at SA node, S near atria, and all we have to see is the morphology, how ventricle are getting stimulated, and what is the effective contraction. If there is a SVT, the heart is pumping blood at a faster rate. When this rate is so fast that adequate filling is not happening, then soon heart will give way and will not get circulation for itself. Coronary circulation happens during diastole of heart. If SVT is happening and it is not getting reversed, then even cardiac myopathy, myocarditis, and infant flaring up of problems can also happen. SVT with white QRS versus VT, that is SVT with aberrations. We see that SVT with aberration generally remains stable, or they have some difficulty. When we see a ventricular tachycardia child, like I mentioned, they are very sick. Common site of presentation is multi-organ or a sick patient in ICU, where when they land into arrhythmia, if we do not identify ventricular tachycardia in ICU settings, then soon we will launch a code blue and we have to resuscitate. QRS complex in SVT with abrasion is primarily less than 160 seconds. There are very broad complexes in more than 160 seconds. There are no capture beats, no fusion beats, no AV dissociation. Capture beat are those beats where there is a broad complex tachycardia, there is a broad complex QRS. After the ventricular contraction has happened, a normal rhythm from P wave with a normal QRS is also seen on the same strip. Fusion beat is when there are two impulses, one from the ventricle and one coming from above the ventricle. They both come and they make ventricle depolarize, and that rhythm and that waveform which is seen on ECG is called as fusion beat. Sinus tachycardia versus supraventricular tachycardia. Usually in sinus tachycardia, rate is below 180 in more than 1 year of age and below 220 in infants. P wave is normally seen, easily seen before QRS complex. RR interval is usually variable because it is dependent on how child is breathing, what is the crying pattern and other things. When we think about SVT, in infants rate more than 220 with no history behind this very presentation on arrhythmia, and most of the time P wave will not be seen, or it will be difficult for you to see the P wave. You should start thinking with this heart rate that this can be SVT. RR interval will be fixed. RR interval variability means that heart is responding to whatever is happening to the body. When RR interval is variable, that is how heart will respond. If RR interval is fixed, that means the rhythm generation is generated with a problem inside the heart, and we have to find out the focus of this arrhythmia. If you see, this is one presentation which those who have been taking care in ICU must have come across. Abnormal waveform with a normal QRS complex. These are premature ventricular contractions. They occur earlier than the next expected normal QRS. The RR interval preceding to this, before this waveform, a RR interval before this is subsequently was half of the distance between these two waveforms. So a compensatory pause after PVC will be nearly 2 times of preceding RR interval. And the morphology will be a broad complex QRS between narrow complexes. Most common dysregulatemia is the cause behind it. Can also happen in myocarditis and associated electrolyte disturbances. The QRS morphology is generally bizarre. Preceding P wave is absent and compensatory pause will always follow, which is usually 2 times of preceding RR interval. Atrial flutter, atrial fibrillation, ventricular tachycardia. Another type, 4 type of pulse rhythm, which all of us should be aware of. So atrial flutter, we have organized electrical activity. When we compare it with atrial fibrillation, the atrial rate and the conduction pattern is erratic and disorganized. Atrial and ventricular conduction happens. At atrial flutter, if you see, in a simplest way, if you have one QRS complex in one block at regular interval, start thinking about atrial flutter. This is sawtooth pattern. When you see a long lead 2 and you see that at specific interval, one large box is having one QRS complex. Think about sawtooth pattern, think about atrial flutter. This is also a type of supraventricular tachycardia, not SVT, which will be managed with adenosine, but a tachycardia which is generated above the level of ventricle. So here you see that 3 P waves do not generate any waveform in QRS. No ventricular depolarization is happening. But after 3 P, this P is able to be transmitted and the conduction is now possible. So this waveform of QRS will give this specific sawtooth appearance in atrial flutter. The atrial rate ranges between 250 to 300 beats. AV node conducts every second or third atrial impulse. We can see that here we have 1, 2, third impulse, 1, 2, third impulse. So second or third depends on the periodicity. Before we comment and on a one look, how we say it can be atrial flutter is, if you see one large square occupied with one big QRS at a specific interval, you should start thinking about atrial flutter. When we talk about atrial fibrillation, we have to search for P wave. This is T wave, we know. This is QRS complex, we know. We are not able to find P wave anywhere. And if you see, the distance, RR distance is very irregular. Somewhere it is close by, somewhere it is not. So out of habit, you should start keeping a 6-inch scale with you. make sure that you mark on the ECG paper on one side and shift it to other. If you see discrepancy in intervals, that means you're dealing with arrhythmia. So these are certain trade secrets which are easier for you as a student to identify arrhythmias and then start evaluating. Okay. These atrial fibrillation are the most common sustained dysrhythmias. Variable ventricular response rate is a complication. Because of this variable ventricular response rate, cardiac dysfunction will happen very soon and there will be ventricular compromise in no time if not identified. Atrial fibrillation are not very common in pediatric age group, but if it is coming, it will come and will jeopardize the conduction, jeopardize the cardiac functions. When we talk about ventricular tachycardia, for comparison, this is QRS, where we can see that only one small square is occupied. This is broad complex QRS, where the duration is more. This tells us that we have a uniformity, which is called as monomorphic, that is, waveform has simple one formation. It is not coming at a regular interval as a positive deflection, and uniformly it is happening. So monomorphic broad complex tachycardia is ventricular tachycardia. There is absence of P wave. Fusion beat and capture beats are not seen in this image. Capture beat will be normal QRS. Similarly, like this waveform you can say, but this you should never miss. This is critical waveform. This will lead to ventricular fibrillation. Organized will ultimately go disorganized. So completely disorganized, immediate cause cessation of cardiac output, no associated pulse, no P wave, no QRS, no T wave, incompatible with life. Can anyone tell me what is the treatment for ventricular fibrillation? Defibrillation. Any other wave, any other reason where we do defibrillation? Ventricular fibrillation ho gaya. Second, pulseless VT. Pulseless VT and ventricular fibrillation. Cause we have to give defibrillation. VT with pulse, cardioversion. SVT decompensated SVT. ठीक है? तो defibrillation का usage आपको आना चाहिए. When you have a defibrillator in your ICU or in your hospital, you should be aware how to use it. Okay. When we come across a child with arrhythmia, we assess them on these clinical parameters, which are, can this clinical condition result from cardiac arrhythmia? Is there hemodynamic instability? Is arrhythmia episodic or it is present for a long time? Can it be reentrant arrhythmia or it is an automatic focus? Where is the focus? If we can identify, is there is an underlying structural heart disease? Most of these questions can be answered by history. Child is complaining of excessively crying. We come across, we have evaluated thoroughly. We have seen for all possible things. Make sure you also see for arrhythmias. Any one of you, whenever you walk stairs, like here when you came up with by walking, maybe some of you, you feel your heartbeat, heart rate, start heart beating faster. That is some different kind of feeling than usual day, right? Children, whenever they pee, whenever they pass urine, they have a different feeling that time also. They cry in that also. If they start feeling their heart, that constant different feeling is palpitation, child will cry only. They will not say they are feeling differently. They will keep on crying. You check for anything, you give colic aid, you check for ear, you check for diaper rash, you check for hair on the things, you check for zipper. If nothing is positive, then check for ECG. Okay? You will, if you bring this change after today, you are going to see at least 3 to 4 SVTs in your career by doing this change only. Okay? Going ahead, our management should be dependent with an approach where we are going to talk whether there is P wave identified or not. What is the relationship between P wave and QRS, and how do we determine the QRS configuration? Mostly hemodynamic instability warrants usage of synchronized cardioversion, like you all have mentioned. Dose remains 0.05 to 2 joule per kg. Ideally, because any kind of shock is a painful procedure in synchronized cardioversion, if child is there, then you should consider giving some sedation as well. It is always helpful for such children. As per PALS algorithm, stable QRS tachycardia, dosage of adenosine is the first dose. Is the first drug necessitated for SVT management. 0.1 mg per kg is the first dose, maximum up to 6 mg. 0.2 mg per kg is the next second dose, maximum up to 12 mg you can give. Now, if there is sudden termination of the rhythm disturbance after adenosine, this probably is AV nodal reentral tachycardia or AV reciprocal tachycardia. If there is no cessation after giving adenosine, then this can be plain sinus tachycardia. You have missed it and you have to treat the cause. Flutter will start appearing in front of you. The waveform will improve, and flutter, if flutter is there, cardioversion and followed by medication like amiodarone, digoxin and beta blockade. If it is ectopic atrial tachycardia, then again amiodarone, beta blocker and digoxin. Here we start taking help of our cardiology colleagues. Importance in emergency is not to give a diagnosis. Importance in emergency is to identify the most life-threatening situation, and anticipation brings in planning. If you can identify, you will anticipate a complication and you will plan accordingly so that you can do justice with that patient. Maybe here we all have different kind of hospital setup. We cannot treat every patient, but we can plan for every patient, whomsoever comes in contact with us. That is most important step in emergency management. White complex tachycardia, if it is stable, we have 1:1 PQRS relation. We try adenosine. If there is AV dissociation, we start treating for calming down the ventricle. We can give lignocaine 1 mg per kg as an antiarrhythmic, amiodarone 45 mg per kg, maximum up to 150. 5 mg per kg is usual dose to start with. In adolescent, we can start from 45 mg as well. If there is no response, then DC shock. Unstable, no questions, DC shock. CPR, you have to give a shock. You have to reanalyze the rhythm, and after you give a shock, you restart CPR. You don't jump for reanalysis immediately. Okay, remember this. This is a crowded slide, but one of the most important slide seen by most of you every time. I would like to go through this slide. So when we identify and treat an underlying cause, BLS will come into action, where we have to assess and support ABC as needed. Do not forget to start oxygen. Attach a cardiac monitor to identify a rhythm. Manage a blood pressure, check for oximetry, and if you can get a 12-lead ECG, it is very practical. Do not delay the therapy if you do not have a ECG. If your QRS duration is less than 0.9 second, you have to plan for ST or SVT. If it is more than 0.09 second, then probably you are dealing with ventricular tachycardia. We have already discussed about compatibility differences in SVT, VT and ST. Now we are just going to talk how and what we can do for SVT management. Vagal maneuver for younger child, you can put a cloth dipped in cold water over the eyes. If you have ever tried putting ice on the eyes, that can also cause an insult and injury to the child. So keep the cold water or a normal water dipped cloth over the eyes of the child without covering the nose. Second thing is, if it's a bigger kid, you can ask them to blow through a narrow aperture, that is a straw. You should, by this time vagal maneuvers are acting. The other thing is on both the carotid. Ideally, once you have ruled out carotid bruit, then only you should give vagal maneuver or carotid massage. Otherwise, carotid massage on both sides should not be given. And if you avoid that, is also fine. You go in and do a carotid massage on either side if you're confident and have done the procedure before. Considering vagal maneuver is an important step. Right, by the time you are preparing adenosine, When you give adenosine, then it is a rapidly, it is a drug which will be rapidly metabolized. So it should be given in a bigger vein closer to heart with a flush technique. So dosage remains is very important. First dose 0.1 mg per kg, second dose 0.2 mg per kg. First 6 mg maximum, second 12 mg maximum. If you do not get improvement, then it is right time to inform a pediatric cardiologist on backup or a specialized unit which can handle this. You should attempt cardioversion in a situation when SVT is causing unstable cardiac compromise state, and you do not wait for any other thing but cardioversion in SVT whenever you come across instability in hemodynamics. When we talk about probable ventricular tachycardia, then amiodarone 5 mg per kg over 20 to 60 minutes or procainamide 15 mg per kg over 30 to 60 minutes. Make sure you do not administer both the drugs. They antiarrhythmics also role in causing arrhythmias. So ensure you choose your drug after discussion with your cardiac team, or you can always connect to our specialist. We have been taking care of such cases here in our units. So emergency treatment when we come across bradyarrhythmias, and when we talk about dengue, many dengue adolescent also have bradycardia going below 50. That doesn't warrant treatment. That is relative bradycardia. You have to monitor cardio, you have to monitor hemodynamics, and that's it. You don't treat them. If bradycardia is happening, hemodynamic compromise is happening, for that you keep atropine at bedside. You keep adrenaline at bedside. You should make sure that cardiologist in your area, in your hospital, should be aware of pacing. You should be ready after anticipation. That is most important. Okay. Last slide. We are not going to go beyond time. Is heart block. First degree heart block. If you see there is progressive increment, it will be more than 0.2 second, and there will be no cardiac compromise state other than increase in PR interval duration. Mainly it is caused by drugs. First degree heart block will not have all the atrial pulsation will be transmitted to ventricle, only the conduction will be prolonged. When we go to second degree Wenckebach or Mobitz type 1, there will be progressive prolongation of PR interval and there will be a missed beat. Then again, PR interval will be narrow, will be small. Before the missed beat, PR interval will be longest. So PR interval, no QRS, no R here. So when there is progressive increase in PR interval and a drop beat, it is called a second degree heart block or Wenckebach, Mobitz type 1. When there is Mobitz type 2 is a defect in His-Purkinje system in ventricle, when all of a sudden everything is going fine with no difference in P or with no difference in atrial conduction, no difference in AV node conduction, because His-Purkinje system in ventricle is affected, QRS is not generated. So in between, QRS is not generated, but rest everything is fine. This is type 2 heart block, Mobitz type 2. When there is no association between atria and ventricle, that is called as third degree heart block. Third degree heart block needs pacing. Third degree heart block, if not identified, will cause very rapid deterioration in patient's clinical setup. Cardiac arrest is ultimate result if we do not manage the patients very well and we are failing to identify. These four rhythms will lead are commonly seen with cardiac arrest, where there is no pulse, asystole, pulseless electrical activity, ventricular fibrillation, pulseless VT. So we have discussed that in pulseless VT and in ventricular fibrillation, we will defibrillate. In asystole and in pulseless electrical activity, we will continue CPR. Support, ABC, attach ECG, manage with defibrillation if needed. If it is shockable, start with 2 joule per kg, first attempt, followed by 4 joule per kg. Don't get carried away with biphasic, monophasic. Whatever you have, use these energies to give the shock. If it is a non-shockable rhythm, that is cardiac arrest or pulseless electrical activity, go ahead with CPR and epinephrine. Don't stop yourself. This is the last part of my presentation. 3 slides. Syncope, very commonly seen, transient loss of consciousness. Postural tone is lost. Patient had a poor cerebral perfusion. They fall, they get up and they're fine. Neurology mediated reflex, orthostatic and cardiac syncope. Most commonly in pediatric, adolescent, in schools after a tiring day, or if they are not properly hydrated, they land up into this kind of presentation. Cardiac syncope is something which we should not miss. Hypoxemia due to cyanotic heart diseases or decreased cardiac output secondary to myocardial dysfunction, arrhythmia or obstructive lesion can cause cardiac syncope. This is primarily seen in patients with arrhythmias and also in patients who have congenital heart diseases with structural lesions such as obstructive lesions, cyanotic heart diseases, or abnormalities of coronary arteries. Most important thing is, if you have a case which you are difficult to identify and you are dealing with common symptoms of irritability, excessive crying, lightheadedness, dizziness, chest pain, ensure you get a 12-lead ECG and a good evaluation of ECG. Inquire about frequency of such episodes. If at all there is any sequelae or possible drug ingestion, most of the time, there is adult who is taking some beta blocker or some CCBs and child pops that pill as a power pill. There are known cases like this. Physical examination, make sure you check for orthostatic vital signs. And if at all there is cardiac syncope, the sudden onset can be ruled out with a good stethoscope and usage of 12-lead ECG. Treat every ECG abnormality. Polymorphic VTs we haven't discussed, but if you're dealing with VT, your immediate evaluation and treatment will save a life. Thank you. Going ahead, I would like to invite Dr. Yoga Nagendra sir to talk about, to open the Pandora box of abdomen with interesting cases, sir.
At the outset, actually, good afternoon to all of you. After vigorous sessions by all these medical people, we'll try to talk a little bit about surgical aspects. Surgical aspects are a little bit more interesting and more colorful. But unfortunately, this is a little bit of whatever I'm trying to talk is a little bit not a very good scenario. So recently I moved from actually Apollo actually after 20 years. Actually now I moved to KIMS Cuddles actually with our team. We cover everything. Next slide, please. So today I thought actually I will talk about few causes for abdominal distension and when you should be alarmed and when you should be scared and when you should react properly and appropriately on time. So abdominal distensions actually we see quite often day in, day out. Actually as pediatricians, most of the mothers will tell about actually abdominal distension starting from newborn period to literally last day also. So I'll go through only few of the slides. Actually, as you can see in this one, you're seeing that anyway, some of you can comment also if you want. Actually, in this X-ray, in the first X-ray, what are you seeing in this X-ray? It's X-ray of the abdomen. It's a supine or erect film. Erect film, because actually we are seeing some of the air fluid levels. Okay, so how many fluid levels are there in that one and how many fluid levels are there in this one? Just for comparison, I equip both. It will be many, usually many. Yeah. About this, actually, we'll talk in detail. Actually, there can be many possibilities. And about this, actually, I will tell. So there are overall very few air fluid levels and very few gas shadows also. So what does that mean? There is paucity of the gas shadows. Means what? It can be a malrotation of the gut. So in a case of malrotation of the gut, actually there can be associated mid-gulf volvulus. So it can happen anytime, today, now, or tomorrow. So the moment a malrotation of the gut is diagnosed, so we have to evaluate and treat as early as possible. So at least on your paper documentation and all, you should write clearly it needs a laparotomy as early as possible. often parents will ask, actually, can I wait for 1 more month, 2 more months? So don't fall in that trap. So that's a big trap. If or else actually later they'll tell, actually you should have told me earlier, I would have got it operated, or just because of you, actually my child went into midgut volvulus and he lost whole of his midgut. So that's why you be very careful. So this is a case of actually malrotation of the gut. Okay, so we cannot clearly make out actually whether it is really midgut volvulus or not, but a vague abdominal distension in the central part of the abdomen, and that gives us a clue. So coming to this one, anyone randomly, just anything. Supine erect, abdomen X-ray, supine or erect. How many air-fluid are there? Quite a few. And how many are significant in children? 7 plus. Okay, so this is the only contrary. So 7 plus lights, actually 7 plus air-fluid levels, actually we have to suspect something. So in this patient, actually, means if I'm called for this case, actually I will tell my clinical diagnosis is maybe appendicitis with perforation, with adhesions, and having associated actually proximal small bowel multiple air-fluid levels is my first possibility. Means everything goes by DD. No, nothing is clear cut. Second thing is, here so much of fecal matter is there, some amount of fecal matter. Definitely it is looking like a grossly dilated maybe colon, because the shape itself actually is looking more like a colon than a stomach. So I will tell, actually it's a case of overall maybe a constipation related patient also. So just by giving enemas for this patient, actually we may be able to relieve the whatever full clinical scenario of this patient. So the other possibilities, it can be an adhesive obstruction. Actually, if the previous history of operation or some scar is there, then we can think it can be a possible adhesive obstruction. The first thing, actually, even in a case of actually once we were taught as MBBS graduates is appendicitis don't give enemas. That is a wrong concept, outdated concept. Even appendicitis, actually, if you are suspecting maybe a constipation, yes, you should give an enema. So sometimes actually enemas relieves most of the pediatric pain abdomens, constipations, and abdominal distensions. Everything will be relieved by enemas. So again, actually, he was telling, it's a Pandora box. We don't know what it is. So this is another similar clinical scenario. Like how I told, actually, it can be a multiple air-fluid levels, actually everything. So it looks as if pathology is here and all the air-fluid levels are going that side. So it can still be appendicitis, actually. So earlier, when what we were taught is actually a clinical scenario like this, we were taught do a laparotomy. So nowadays the trend is even if it is a complex appendicitis or perforated appendix or even abscess, mass, everything, the treatment actually nowadays is laparoscopy. We are going to treat that child with beautiful scars and maximum benefit, almost same benefit or more than that, because actually we'll be able to see a bigger area. In a case of laparotomy actually or appendix incision, so our vision is very small. And in that pus cycle, definitely the vision is still more small. So nowadays the treatment is means answer for all these most of the conditions is laparoscopy. Sorry, the only condition where we think actually laparoscopy, this is not a good child for laparoscopy, is that distension is too much and the air-fluid levels are too much. Too many air-fluid levels are there, grossly distant loops are there. Then maybe my first port itself can go in, may damage any of the intestines. That's why in those cases, actually, maybe yes. And second thing, I won't be getting much of pressure. So the more, if I try to instill some gas and all to get pneumoperitoneum, so maybe I'll be increasing the abdominal pressure more. So that's why in that case, I will not use a laparoscopy. So if that patient actually, if it had been opened actually for just for simple appendix, so this is what would have been the finding. Actually, one perforated appendix would have been there, and unnecessarily we are leaving the baby with a big bad scar. So, or else actually we'll be leaving the child with at least 3 beautiful small scars, which will be hardly negligible in his future life. So nowadays, actually, laparoscopy has become answer for most of the abdominal conditions. So whenever a child is seen by all of us, actually, often we think, actually, especially surgeons, we really don't know because we'll have so many differential diagnoses. I really don't know what it is. That's why, actually, when I was introduced, I was introduced as we are going to open the Pandora box. So when we are going to open this when a Pandora box is seen, I'll be thinking, actually, what is this? Actually, should I open? Should I not open? Should I do open? Should I do laparoscopy? Am I justified? At the end of the day, actually, all our doctors, actually, we are good doctors. We don't want to have a negative laparotomy. A wrong diagnosis by us really makes us feel very uncomfortable. So to avoid this, actually, always, most of the time, we'll be in this situation. We'll be just thinking like a thinking man. So then suddenly some ideas will come, and then actually we'll start doing something, and we'll progress in that case. So in a similar way, actually, one day I was called by a pediatrician. It is about actually a 15 years back story. So one day I was called by a pediatrician, and he said, actually, this is a case of abdominal distension. And so what is the thing? And anything I'm asking, he said, actually, okay, post-enterocolitis child and vague abdominal distension. Abdomen is quite hard. You come soon as early as possible. So all that he is telling is actually just come soon. That's what he is trying to tell. No vomitings, no diarrhea also. This is what I was called for. So I was asking, while traveling itself, I used to travel a lot. So something like 80 kilometers a day. I'm just trying to tell actually how you should travel in your practice. So all of us will run. So I asked him, is there bilious aspirate? He said no. And he said, actually, I'm not able to pass the NG tube properly. Actually, nothing is coming from there from the NG tube. And then I asked, is the child passing stools? No, he said no. Earlier it was, but even now I am not able to pass the flatus tube also. I asked to pass anything. He's not able to pass anything from below. And as usual, actually, we asked the pediatrician, what do you think? Actually, he is telling, just come. I don't know what it is. So even I am not able to get what he is trying to tell. So I'm trying to show you two clinical scenarios. Actually, we have 4 cases, but actually I'll show you only 2. So this is one of the newborn. And as you can see, what are you able to see this in this one? I'm trying to hold the hand, and I'm trying to hold the foot, and I'm trying to show you in the same thing. And in fact, they were checking actually pulse oximetry from here and from here also. Here you can clearly make out actually it is quite dusky. The lower limb is quite dusky. The upper limb is reasonably okay, but not okay. So as you can see, actually, it's a ventilated baby. 90 degrees, 90% is the saturation in the upper limb, and lower limb is having only very hardly any good saturation. Subabdominal distended, ventilator care, not maintaining well. So I had something in my mind. What do I have in my mind? So obviously, any surgeon actually first what he'll do is actually first he'll put the hand, which you people don't like because he's not touching, cleaning his hands. It's still cold. All these problems. But we are very comfortable touching the abdomen as often as possible. So abdomen is quite tight. It's very hard. So what is my diagnosis? So I told actually, let us go for laparotomy. That is the only option left. And this parent actually, they said actually, sorry, we are not interested in laparotomy. Let it go. It's okay. So that is his wish. So this is the other scenario. Actually, the earlier case I was talking about, this is the case. So if you can see, his anus is pouting. So anus is pouting, but fecal matter is also not there. Just a posterior wall is abutting onto the orifice, anal orifice. And in this picture, actually, I don't know whether you're able to appreciate. This part is okay. This part is definitely congested. Full lower part is congested. And he put a feeding tube, but it is not entering nothing is coming from there. So in fact, actually, in this picture, you are not able to appreciate, but even the venous flow is more towards this side. Okay. So what is your clinical diagnosis? I'm telling you, all of you will face similar situation at least once in your lifetime. That day is your doomsday. And that's it. That day I felt so sad. I was very sad. So anything? Again, touching the abdomen, yes, it's very hard, like a rock. Rock means rock. And as you can see, it's ventilated by the time I could go there. And there is a feeding tube, but actually it is not draining anything. So X-rays are done. X-rays are done. Actually, if you can see, the feeding tube has come here and it has coiled, it has gone back here. So one pediatrician asked, actually, is it a case of a tracheostomy, variant of tracheostomy fistula? So, excuse, no, no, TF always, you remember, it is at the level of just below the manubrium sternum. So it will be invariably, it will be there only, nowhere else. It won't come below that. So very rare. Means unless it is traumatic or something. So you can see that actually the feeding tube has gone till here, it is going back. And coming to the abdomen, if you see, all the abdomen, actually all the gases are dilated. There are no significant airflow levels also. It's not a clear-cut intestinal obstruction. It's quite tight. And if you can see, actually even the pelvis, actually below that, actually there is no gas at all. Means the gas is not entering into the rectum. And that's why actually they are not able to enter the rectum at all. And here also, actually, if you can see, actually, a feeding tube in the Foley's or whatever, it has gone only till here. It did not go much beyond. So no, you know the diagnosis. Okay. And you can see the diaphragm also, it's quite tented, high tented diaphragm. So whenever similar situations are there, the treatment is, there is no treatment. Okay, so anticipate this, and whenever you are putting a hand on the abdomen, when the abdomen pressure is very high, so always make it a point that you will put as many tubes as possible from everywhere, and then decompress the abdomen as early as possible. So they lost the golden minutes or hours. So they should have passed this before only. They should have passed this before only, so that actually at least they can measure what is the intra-abdominal pressure. So the gold standard for measuring the intra-abdominal pressure is, someone told. So by measuring the pressure from the urinary bladder. So pass a catheter and then actually connect it to the CVP monitor, and then actually you'll be able to measure the intra-abdominal pressures. So various pressures are there actually, and according to grade 1, 2, 3, 4 and all. So we can't exactly correlate all these things to our newborns or pediatric age group, but these are almost more or less the same. So especially something like actually the moment it is going into grade 1 itself, try to do some decompressive something. Decompress from anywhere. Either can be from the stomach, or it can be from the urinary bladder, it can be from the rectum. So 3 holes are available. So 3 holes, use those 3 holes and decompress that. So the answer for all these things is prevention is the cure in this diagnosis. So, and you should have that early suspicion. Yes, actually, this is a possible case of intra-abdominal hypertension, and he will go into abdominal compartment syndrome. Okay, so early intervention, I won't accept this step also. I will let us fix on to the first and second ones only. So coming to abdominal compartment syndrome, actually we discussed that bladder pressures are the key and the gold standard measurements. There are some other ways of measuring real intra-abdominal pressures, but they are not safe and they are not comfortable for every patient, not feasible also. So bladder catheter we keep, actually that it can be connected to one will be connected to the IV set, any IV standard set, and then actually the other one will be connected, and we will be measuring intermittently. We don't measure continuous monitoring. Usually it's not done, and we do intermittent pressures actually by using a CVP monitoring. That thing will be available, which will give centimeters of water also, and this is the normal intra-abdominal pressure. And if at all, if it is going more than 12 itself, then you should be scared. So, and if it is actually 3 times, actually, if you are having a high intra-abdominal pressure, actually we'll be in trouble. So don't allow this to happen to any of your patients. If it comes as like that patient, actually that is okay. But unfortunately, this will happen with your most common cause is gastroenteritis, simple basic gastroenteritis. So be very careful. Whenever a gastroenteritis patient comes to your OP, just put a hand on the abdomen. So I jotted down actually few of the various causes for intra-abdominal hypertension that we see commonly. So as a medical personnel, actually you will be seeing more commonly in the gastroenteritis cases. So even post-op, actually there will be a little bit of ileus. So any post procedures or abdominal surgeries also, because of the ileus, actually you'll be having this. And if you know, actually nowadays burns management fluid, it's totally changed. What formula that we were using, actually they're not applicable to any of these burns criteria. So massive fluid resuscitation also can lead to extravasation of fluid into the outside the lumen. So that commonly that we see as pediatric surgeons is actually when we are called in a case of NEC, necrotizing enterocolitis. Often, actually, if at all, if any perforation is there, definitely automatically your pressure will increase. So whenever NEC perforations are there, during your PG time, actually, you must have seen a pediatric surgeon coming in overnight. He'll just put a drain and then he'll get out because anesthesia is not available, night duty doctor, that this and all are not available. That is the best concept. So put a drain, come out, so that actually the hemodynamics will stabilize over some hours, and then you can do a decompressive laparotomy or something. So the bottom line here I'm trying to tell you is don't rush to do a laparotomy for surgeons. You don't force us also to do laparotomy immediately. So any perforation, yes, pressures are going to just go abnormally high. In simple gaseous distension, be careful. And once I was doing one hydrostatic reduction, actually, a pneumatic air reduction. Suddenly I saw actually there's differential colors in both the upper and lower limbs. So immediately I released. That is why actually, or else actually in that hurry, actually, if I don't forget it, I'll be in trouble. Once I was doing a laparoscopy, pressures were high. I did not notice. Suddenly lower limb actually saturations were falling down. Immediately we released. I was able to save a child from abdominal compartment syndrome. So prevention is the important thing. So here actually in KIMS Kondapur, actually Dr. Manisha was doing one exempless reduction, my colleague and pediatric surgeon. And after reduction, there was tight intra-abdominal hypertension was there. Immediately she put drains and all, actually it got relieved. So or else worst case, what we can do is even you can do actually after we go, just remove all my sutures, nothing wrong. That way you will be doing that decompressive laparotomy, nothing wrong. Surgeon will not say anything, don't worry. So abdominal compartment syndrome is a bad condition. So the criteria are actually whenever actually intra-abdominal hypertension is there, along with that, actually there is actually multi-organ dysfunction which is setting in. So all these conditions actually means it is an abdominal compartment syndrome. There is a clear-cut definition for that. You can go through later. So as we said, actually upward displacement drive from everything, overall the kidneys get congested and they'll be losing the having decreased vascularity, leading to multi-organ dysfunction syndrome. So this collapsing of the IVC that is happening there. So immediately we should not be relieving it immediately. Slowly we have to release. So again, I'm trying to tell actually early suspicion, early diagnosis is important, and slow decompression is the bottom line. This point you try to understand actually, even if in your condition, in your practice, if junior pediatric surgeon comes and if he says, I'll do an immediate laparotomy, you tell, sir, please, you're neither pediatric surgeon. He had very bad experience with 4 cases, it seems, all literally 3 died, one survived. Okay, means you could tell that. Usually it will be not 3 died, actually all died only once the diagnosis is made. So slow decompression is very important. And this is what actually we are talking about. Paracentesis means nothing but actually putting a drain. So by putting a drain, actually you will be doing a slow decompression. Slowly, actually pathophysiology and venous return, everything will get settled and IVC will come to the normal place. So then we should do a next day. Actually next day means after a few hours, we should be doing a laparotomy to settle what is the main issue. And sometimes what we do is we don't do the abdominal closure on the spot itself. We just cut it. And if it is not going inside, actually we create a ventral hernia. So that creation of ventral hernia also is to reduce possibility, chances of intra-abdominal hypertension and abdominal compartment syndrome. So bottom line is prevention, prevention, prevention. So I opened this abdomen in NICU. Actually, in front of me, they were looking like bowels, intestines. Immediately within some time, actually, they became like flabby, some tubes, almost decompressed balloons. It became like that. And in front of me, only that pink color became that dusky color. I know that he is dying. So I told him, he said, okay, try. So I gave it a trial, but the answer is going to be this one only. So better do it. Whatever you want to do it as early as possible. Don't waste time. Don't waste in calling surgeon also. Do whatever you want. Surgeon will support. So overall bottom line is it's a lethal condition. So suspicion is more important rather than surgical intervention. So I always tell actually alert mother. Actually, you can make it alert pediatrician also. Early detection, early solution, and that specialized is required. Actually, all of us should have that specialized and put one hand on the abdomen. Actually, it will save a lot. So this is one slide I want all of you to take a picture also. So I wish actually all of you, before the child enters your cabin itself, if you have a checklist of these things, like something like, does the child has a tongue tie? You need not ask. That secretary, actually height weight chart only, they'll be checking, having this checklist. Tongue tie is there, umbilicus, any problem is the groin, this testis, phimosis, hypospadias, any swellings are there. This documentation. That surgical checklist should go to before they enter your cabin. So then actually our pickup rates will be very high. More than anything, actually it's not actually a personal wish that I should get more cases. It's more than that, actually the parent will be very happy. So if I go to this pediatrician's clinic, yes, he will check all these things. He'll do an overall measurement, overall care and all will be given by the pediatrician. This is a very interesting slide I tried to make. And if you have any questions, actually we can talk, but all of you try to see that you should pray God that you should never see one intra-abdominal compartment syndrome in your lifetime. Then you are a very lucky pediatrician. Lucky. Second thing, you are vigilant and you are very good pediatrician. No, this is the message I wanted to give, that's all. Means you don't see this.
I would summarize this as a practice changing slide, sir. And it is really a practice changing for, at least for me, I will change my practice. I'm definitely going to add to this department itself. So going ahead, without further ado, I would like to invite Dr. Pratik for giving his perspective. He's an ID specialist, helping in all the difficult cases when we get stuck. We call our savior. So Dr. Pratik, Dr. Patil will be taking and telling us about the GI infection and perspective of a infectious disease specialist.
Thank you, sir. Good evening, everybody. So I'll just take you through some GI infections, how to approach them, and what are the things we can do. So this is ID perspective of this. I don't have any conflict of interest to this, Okay. So I'll first of all discuss about diarrhea. Then I'll go to the enteric fever, some parasite infections, Clostridium difficile, because we use a lot of antibiotics, especially in the ICUs. Then some other systemic infections which can have the GI manifestations, and hepatitis. So diarrhea in resource limited settings, we can say that infant experiences on a median of 6 episodes per year, and a child experiences nearly 3 episodes in a year. So it's a quite common problem. Most of the kids have it. And what we know is there is a considerable geographic variation in the incidence and the mortality of the diarrheal diseases. So now coming to the common causes, when we see any case of diarrhea, what we need to start is what kind of diarrhea it is. First of all, we need to know whether it's a diarrhea or dysentery. So it's a watery diarrhea, means they may have only mucus in the stool along with watery fluid. Fever may be present, or it may be a little low-grade fever. The common causes are rotavirus, enterotoxic E. coli, Vibrio, Cryptosporidium, norovirus, and adenovirus. Now, in adults, Cryptosporidium is usually seen in the immunocompromised hosts, but in pediatrics, you can see it in even immunocompetent kids. So coming to the invasive or bloody diarrhea or dysentery, where you see a gross blood in the stool, which is often associated with fever, which may be high grade, or you may have repeated frequent febrile episodes. It is associated with vomitings and abdominal pain. The Shigella, non-typhoidal Salmonella, Campylobacter, enteroinvasive and enterohemorrhagic E. coli, Entamoeba, and adenovirus sometimes. So the other causes, like other systemic infections like influenza, measles, even dengue can cause it. Acute HIV or HIV with immunosuppressed child can have it. Malaria and sepsis can do the diarrhea at times. And then you have extraintestinal bacterial infections like pneumonia, you can have diarrhea, especially sometimes Legionella can do that. UTIs can cause meningitis, listeria is one meningitis which can have diarrhea associated with it. Then other intra-abdominal processes can cause diarrhea and milk intolerance. Now, this is one multi-center study which was published in 2013 in Lancet, where the different causes of diarrhea were studied in different countries. In India, there was a Kolkata as a center there. And you can see in infantile age group, rotavirus, Cryptosporidium were the commonest causes, followed by adenovirus. So the take-home point here is most of them are viruses or not bacteria. So this is one point I would want you to notice, that bacteria are not so common causes of diarrhea in infantile age group. Coming to the 12 to 23 age group, there you see some Shigella coming here, probably some Vibrio, and otherwise all are this SC enterotoxic E. coli, but again, not so much big numbers. So similarly, up to 5 years of age group, here the bacteria is little more. But again, this is the data from the Kolkata as such. And then if you see the incidence of the deaths due to the diarrhea, this is 2019 data from India, the Campylobacter and adenovirus. So the common causes of bacterial causing the death is Campylobacter. The other bacteria, they usually do not cause the death as such if you see the absolute numbers. So now coming to the diagnostic evaluation for the diarrhea. We do all the routine tests, but I think stool routine and stool culture is very important. And if you are suspecting cholera, then hanging drop preparation, speaking to your lab, microbiologist is very important, because you should inform them what you are suspecting. They can specifically look for it. Now coming to a specific thing here about Entamoeba histolytica. We have seen it several times. A stool is being reported like, okay, Entamoeba histolytica cyst seen, but you know, you cannot, the pathologist cannot differentiate they cannot differentiate between the Entamoeba histolytica with non-pathogenic Entamoeba like Dispar or Bangladeshi or Moshkovetsky. So these species, they cannot differentiate. What specifically you need to ask them is whether they are seeing any erythrophagocytes there on the stool microscopy. If that is seen, then you can seriously consider possible. And if your diagnosis is, infective diarrhea with possible dysentery, then you can seriously think that is an amoebic diarrhea, or else it can still be a normal viral diarrhea. Now, coming to what is the role of antibiotics in diarrhea. So in watery diarrhea, most common causes are viral, like we discussed. But if you are suspecting a cholera-like infection, obviously, yes, you have to give the antibiotics, which includes tetracyclines. A single dose of doxycycline or macrolides can be used. Ciprofloxacin, we don't know how much it's really useful. Most of the times they are resistant. So macrolides can be a good choice in pediatrics. You can still use doxycycline, though they're not supposed to be used for longer duration in pediatrics, but for cholera, it's a single dose, so you can still use it. Now, invasive or bloody diarrhea. Here, the empirical choice is usually directed against Shigella. And then if you are suspecting amoebiasis, if you have confirmed that there is amoebic cysts with erythrophagocytes, then you have a role for metronidazole. But again, It's not coming here. I think. Anyway, so the common antibiotics which to use in case of dysentery, you can use beta-lactam drugs, third generation cephalosporins. But again, the Campylobacter, which can be another common cause of diarrhea, and the enterotoxic E. coli, they all have very good sensitivity to the azithromycin also. So azithromycin, though in general practice is used for respiratory infections where should not be used, because most of the upper respiratory tract infections are viral, and starting azithromycin in first 3 to 4 days makes no sense. But it's a very good drug for the diarrheal diseases also. That's the point what I'm trying to make it here, that probably we should avoid using cephalosporins early in the diarrheal diseases, because unnecessarily we are selecting out resistant bacteria. So try to use macrolides in these drugs. Now, what is the role of anti-secretory drugs in the management of diarrhea? Rasacadotril can be used. European guidelines say it can be considered. It's not available in US, no data or any recommendations from that, but it is safe. Benefits are uncertain. And again, there are inconsistent findings among the different studies. What is the role of probiotics and prebiotics? Again, no consistent evidence on use of these. Whatever studies which have shown benefit is what is the levels or the dose that you use. So you need to use specific dosage for them to show the benefit. So like in Saccharomyces, 250 to 750 mg of this has to be used. Similarly, Lactobacillus, you have to use at least 1 to 4 into 10⁸ colony forming units. So the dose is important when you are using the probiotics. Coming to enteric fever, this is a recent article this year in April, it had come in NEJM. Incidence of enteric fever in India and then different parameters, the burden. So the commonest symptoms of enteric fever in India, the diarrhea was around 50 to 70%. Constipation is another symptom which we don't commonly inquire, but again, pre-antibiotic era, the diarrhea was equally common as constipation. Now post-antibiotics era, the diarrhea is more common. Abdominal tenderness and distension and rectal bleeding can happen, and perforation usually at 3 weeks or later can happen. The lab parameters, you see anemia. In adults, you do see leukopenia or leukocytosis, but in pediatric age group, leukocytosis is commoner. Eosinopenia is another subtle marker towards enteric fever, and you can see the abnormal liver function tests also. Now, coming to the other diagnostic tests, blood culture, it's positive only in 50 to 70% of the cases, depending on what is the volume taken and prior antibiotic usage. So, but it is still the gold standard. Stool culture is positive in 30 to 40% of the cases. Bone marrow, you can do in patients who have been antibiotic exposed and you are still suspecting up to 5 days of antibiotic usage, still bone marrow can pick up the salmonella. What is the role of serological tests? Vidal, always make sure that you are doing Vidal. If you really want, it has to be paired, 2 tests done. And if you see a rise in the titers, then only it is significant, or else single test may not be really useful. And rapid antibody based test can be used, but again, it is not very, very sensitive test, only around 70 to 80% depending on the test that you are using. Another thing that you need to know is it may not be positive very early in the disease. Second thing, it does not detect the paratyphy. So it only detects the typhy. So that is another backdrop for that. Now coming to the antibiotic usage for enteric. We have seen that patients take time. Usually enteric fever is one which doesn't respond very early. The paratyphy takes longer than the Salmonella typhi to respond. The fever is longer. So whatever was studied in those in that study, whatever isolates were there, most of them were resistant to ciprofloxacin. So that is why, for practical purposes, quinolones should not be used whenever you are suspecting enteric fever. Though in guidelines it is mentioned, but not practical in India. So there were a few strains that have been reported which are resistant to ceftriaxone. Especially there is MDR Salmonella that has been reported from Pakistan. We have seen some cases of ceftriaxone resistant Salmonella due to the plasmid mediator resistance, but not so common. Azithromycin has been used commonly and the resistance is also getting noted now. So important thing for using azithromycin for salmonella is the dosage. And when you are suspecting bacteremia, do not use it as a monotherapy. Use it as a combination with some parenteral drug, and then probably as a step down or subsequently you can switch to azithromycin. So to reduce the resistance to the azithromycin, why it is a very good drug. Now, if you see the treatment guidelines for salmonella typhi or enteric fever, the treatment with this is another important thing. The treatment duration is very important. With third beta-lactam drugs, you need to give at least 10 to 14 days. However, with azithromycin, even if you are using orally, it is only 7 days. The reason is it is having a very good intracellular concentration, and that's why it has a post-antibiotic effect. So even though you are using for a lesser time, the efficacy is longer, and that's why the duration of treatment is shorter with azithromycin. Another good drug which is underutilized is cotrimoxazole. It's also shown that it has a very good sensitivity. So if you have a culture proven sensitivity, that is an alternative drug to your other drugs. Coming to the C. diff infections, which can be seen in the ICU patients who are in a long stay, you have to categorize in mild, moderate, severe, or fulminant, depending on the clinical features. Now, important, again, these are few practice points that you need to understand is the C. diff toxin, it undergoes degradation at room temperature. So it has to be processed within 2 hours. So this is a specific instruction you have to give it to the nurses, collect it. If there is a delay, store it in the fridge. And that's why I'm saying it's preferable to do the C. diff test in-house. So the most of the times, if you are doing a toxin assay, it may come negative unless if it is in a borderline range or it's a low positive. So this is how it is. So transportation of the sample is very important. Timing and temperature is very, very crucial in positivity. So this is general approach for the C. diff. If you have a fever and diarrhea with more than 3 episodes, you should suspect in patients who have risk factors for C. diff. You do a GDH and toxin A and B assay. If GDH is negative, toxin is negative, CDI is negative. However, if you have both positive, it's confirmed CDI. If you have GDH positive and toxin negative, it's possible that it's a non-toxigenic strain of C. diff. If your clinical suspicion is strong, you should go to the PCR, nucleic acid amplification test, to confirm the C. diff. If it's negative, you rule it out. If it's positive, that's confirmed. Same thing other way around. If GDH negative and toxin positive, you confirm with NAT. If you can do it NAT, that is better because you don't need these specifications for transportation and the temperature for the assessment of NAT. And it only detects the toxins. So you don't need to worry about GDH at all. So treatment is usually removing the risk factor. That is very important. So cut down your antibiotics. Antimotility agents to be avoided, oral vancomycin or metronidazole at least for 10 days, depending on the response to the treatment. Parasitic infections like giardiasis, most of the people clear it, nearly half clear it on its own without anything. Nearly 15%, they don't have symptoms. It's only up to 35 to 45% of the individuals who have symptomatic infection, which can be diarrhea, malaise, cramps, weight loss, and sometimes malabsorption. The diagnosis is usually by the stool assessment by antigen detection tests, nucleic acid tests, or stool examination. Treatment is simple: nitrous oxide, metronidazole, or tinidazole, sometimes albendazole. Cryptosporidiosis, when it is causing symptoms, you may choose to treat it. Again, you have to specifically ask your microbiologist to do the modified AB stain. Unless you tell them they won't do it, you will never diagnose it. So specifically ask them for modified AB stain and you can treat it accordingly. It can have systemic side effects also. Now coming to the systemic common infections that we see in our regular practice, other infections, how to distinguish just based on your routine lab. So I have just summarized it for the ease of understanding. So dengue, malaria, enteric, lepto, and scrub, where you can see the deranged LFTs and other things. So dengue and malaria, usually your white cells will be normal. Enteric, I said, it's normal white cell, or you can see leukocytosis in kids, but eosinopenia can be your subtle marker. to suspect, and especially in enteric, you may see the fever going on for 6-7 days or longer. So that may be another thing that you would suspect enteric fever. In leptospirosis, you can have a leukocytosis or the scrub typhus also if the counts are normal to high. Now, enteric fever, usually platelets won't drop too much. You can see, low normal platelets, not very low, unless the child is very sick or if you have a perforation. So rest of all the things can cause the low platelets. Coming to the hemoglobin, in dengue, you see a relative hemoconcentration. So your hemoglobin will be really high in dengue compared to your baseline, or otherwise the child will look dehydrated. In malaria, the hemoglobin is low due to the hemolysis. So that's why your bilirubins will be high in malaria. In enteric, usually hemoglobin is normal, or it can cause anemia due to the ulcers sometimes. Yes. Lepto and scrub also, the hemoglobin will be normal. So here the dengue is what you can identify based on the hemoglobin and hemoconcentration. The LFTs, you see malaria, it's usually the bilirubin that is high and the enzymes may be mild high, not too high. However, in enteric, you can still see mild variation. Leptospirosis, you can see a lot of liver enzymes derangements, and same for the scrub. So lepto and scrub can have multi-organ dysfunction. So same thing about kidney also. Both of them can have acute kidney injury. So other important parameters which can help you in diagnosis is serositis that you see in dengue. So generalized skin rash, effusions, abdominal distension or fullness. Malaria, you can simply do a peripheral smear or rapid malarial tests. Leptospirosis, they will have a lot of myalgias, and you can check CPK. Scrub typhus, if you examine carefully, and if you find a eschar, that's diagnostic. You don't need anything else. And treatment, once it's diagnosed, it's easy. So hepatitis A, just before conclusion, that is one of the common viral infections in pediatric age group. It usually subsides on its own. You just need to support the child. There are no antivirals so far approved for the hepatitis A. Hepatitis E is not so commonly seen in children, but that was another hepatitis which did not have treatment previously. Now we have treatment for hepatitis E in adults. And as the age grows, the hepatitis A tends to become severe in the elder age group. So to conclude, I'll say some take-home messages. Diarrhea is mostly that it needs a supportive treatment, preferably no antibiotics, unless you have a dysentery. Antibiotic, if dysentery or very high frequency of diarrhea, or if there is a high fever. Azithromycin is really a good drug for GI infections. There is definitely no role for quinolones and metronidazole, which is commonly available, O2 and all those, or ofloxacin, really not much role in the current practice. The erythrophagocytosis in stool is what we need to look for any suspicion of invasive amoebiasis. Enteric fever, the blood culture is still gold standard. Try always, whenever there is suspicion, always send blood cultures. Azithromycin, ceftriaxone, and cotrimoxazole are good options. No quinolones again. And C. diff colitis is increasing with increasing use of antibiotics. Toxin A and B positivity is diagnostic. Try to do the tests in-house so that your positivity is better. We can have questions later. If you have time now, we can have any questions, if anything.
We can take questions. You don't often see a ID specialist sitting with you. You can ask us. Now we are in a season of dengue. You see a lot of infections. You can bombard with all sorts of questions if you want to. I used to ask him a number of questions from an ICU point of view. Okay. If there are none, then I'll call upon Dr. Pandu, pediatric gastroenterologist. Dr. Pandu has been trained in AIMS for both MD pediatrics and pediatric gastroenterology, a very good friend of mine. So I'll hand over to you.
So next discussion is a liver transplant in children. So nowadays liver transplant has become standard of care for end-stage liver disease. Okay, it is a complex life-saving procedure. So today's our outline will be introduction, some few historical milestones, common pediatric liver conditions, indications and contraindications, pre-transplant evaluation, brief transplant procedure, and post-transplant management and outcomes. So it is life-saving complex procedure. So standard of care for end-stage liver disease nowadays, due to improvement in the surgical techniques and improvement in the survival rate post immunosuppressions, now it became standard of care for end-stage liver disease. And it is also curative for inborn error of metabolism with or without cirrhosis, and also curative for liver tumors. Interestingly, liver transplant is pioneered in the pediatric setting. So first pediatric liver transplant was performed by Professor Thomas Stargell in 1967, which is successful liver transplant. First was 1963, where child had succumbed to death intraoperatively due to excessive intraabdominal hemorrhage. So in India, the first liver transplant is in 1998. So it is 25 years since first liver transplant, pediatric liver transplant in India. Currently, there are 135 centers which performs liver transplants in India. So this is some historical milestones. The first liver transplant. So 1963, so which was child was succumbed, and the first successful was 1967. So extended survival of 1 year. However, that good survival rate was after 1979, when the calcineurin inhibitors were introduced into the immunosuppression protocol. Okay, so thereafter the pediatric transplant programs were successful, and earlier only were age-matched disease liver donor were used for transplantation. So after 1979, there is a huge scarcity of pediatric grafts. So in 1984, the first time reduced size graft was used in pediatric recipient. So then after the pediatric transplant number also increased all over the worldwide. Okay. Then significant, this is not working. No. Indicator. So after in 1994, after tracrolimus was approved, there was significant increase in the mortality due to decreased immunosuppression and decreased mortality from the infections. So in 2002, there was introduction of Melden-Pelt score, where we are able to identify the high-risk patients and perform early transplant in them, which reduce the waiting list mortality. So since then, there was around 600 pediatric liver transplants all over the year, all over the world. Okay. So this is this paper is 2020. So 25 years of pediatric liver transplant history. Nowadays, 1,500 to 2,000 liver transplants in India, around the 135 centers. Of them, 10% are pediatric transplants. Okay. These are the centers, liver transplant centers in India. Most of them are in Tamil Nadu, followed by Maharashtra, Karnataka, and Telangana, Gujarat. So what are the common pediatric liver conditions which require liver transplants? Let's have a look at the list. So most common are cholestatic disorders. So most common is extrahepatic biliary atresia, followed by embryogenic disorder, Alagille syndrome, progressive family intrahepatic cholestasis, sclerosing cholangitis, Caroli, and intestinal failure associated liver disease. These are metabolic liver disease with cirrhosis, neonatal hemochromatosis, tyrosinemia, glycogenosis type 4, cystic fibrosis, bile acid synthetic defect, Wilson, alpha-1 antitrypsin deficiency. So metabolic liver disease without cirrhosis. This is very important to identify the difference between the two, because graft of these patients can be utilized for the another children, which is liver failure. So we call domino liver transplant. We'll be discussing later. So other condition, chronic hepatitis like autoimmune hepatitis and cryptogenic. So other category which requires emergent liver transplant is acute liver failure due to known or unknown causes. These are the few causes of acute liver failure. Again, in the liver transplant is curative in case of liver tumors. So So we won't proceed for liver transplant, all of this condition. Okay, we look for the indications within the condition again. We'll rationalize the therapy. We look for the improvement and we'll proceed for the transplant on case to case basis. So let us discuss one case which was presented to us 5 months back. So 8-year back presented to KIMS with complaints of fever for 5 days, 1 week back, followed by jaundice for 1 week, associated with high colored urine, abdominal distension for 1 day, and excessive drowsy since morning. On examination, child was irritable. There was tachycardia, tachypnea with maintaining saturation. So pallor and icterus was present. Pedal edema was also present. The child had hypoglycemia, emergency admission. So on systemic examination, there is hepatomegaly with ascites. CNS wise, other than that drowsy, other parameters were normal. So working diagnosis of acute febrile illness with acute liver failure with encephalopathy was considered. Other differentials can be febrile illness with meningitis. Okay. So with these differentials, we worked out further. So on day 1, child had anemia with borderline with elevated CRP and poor calcitonin, with bilirubin of 16 and moderate elevation of liver enzymes, ALT and AST, and INR of uncorrected INR more than 7, corrected INR after vitamin K 6.5. And ammonia was 110 microgram per deciliter. Okay, this is the blood gas of the child as metabolic acidosis with hyperlactatemia, lactic acidosis. So here diagnosis is confirmed with, so what is diagnosis? Again, acute liver failure with encephalopathy, grade 1, you can say. So what is the next step? You have to look for the etiology. So etiological workup was viral, all viral markers was negative. Hepatitis A, B, C, E, as well as PCR for EBV, CME was negative. Other malaria, leptospira, dengue, scrub types were negative. Autoimmune workup, ANA, ASMA, and TLKM were negative, and IgG was borderline elevated. Wilson workup was negative. TMS and GCMS awaited at the time for metabolic liver disease, and ferritin was borderline elevated, nanogram per deciliter. So what is the final diagnosis? So indeterminate acute liver failure, or it can be seronegative autoimmune liver disease or metabolic liver disease. Okay. So what next? Child was started and supportive therapy from the day 1 of admission. So we continued support therapy while monitoring and awaiting the other results. Okay. So meanwhile, child was worsened over the next 5 days in form of elevation of the bilirubin and persistence of the prolonged coagulopathy INR of 5.8, and with increase in ammonia and increase in the encephalopathy grade 2. So the child, though, even after 5 days of supportive therapy, the child is not improving here. Okay, and etiological work was indeterminate. So what is the next step? So how do you predict either recovery or death in this child? Is there any markers for the prediction of mortality? So there are markers of prediction of mortality in this acute liver failure. So we use King's College criteria for the prediction of the mortality or recovery. Okay, so this King's College criteria for ALF, for paracetamol induced ALF as well as non-paracetamol induced ALF. Okay, so in our child, that non-paracetamol induced ALF, so our child fulfills the second criteria, at least 3 of the following. Okay, so this child is going to die more than 90% of the times. Okay, the recovery without liver transplant is less than 5%. So according to this interpretation of this score, so we counsel parents for the transplant. Okay. The parents were agreed and we proceeded later. So in cases of any acute liver failure, so after rationalization of the therapy and after evaluation of the etiology, you have to give time to the child for the recovery, at least 4 to 5 days. And meanwhile, evaluate further, look for the markers of the mortality. Okay. If markers suggest of mortality, then go for the liver transplant. Okay. So counsel for them. So early referral to the higher center. If available in your center, then involve the pediatric surgery team, multidisciplinary team, involve the transplant surgeon team as well, or as early as possible. So there's importance, you have to look for the rationalize and supportive therapy, look for the etiology and look for the markers. Okay. So as I told you, the indications in the liver transplant, you have to look for the type of the liver disease, eligibility and timing. Type of the liver disease, if it is metabolic liver disease, we may transplant because it is curative, okay, even without cirrhosis. So then look for the, if it is chronic liver disease, look for the eligibility. It is class A child puke. So we are not going to transplant readily. We wait for, the child may survive without transplant for at least 10 to 15 years. So, and also look for the timing. So how worsen this child condition. So in case of acute liver failure, use King's College criteria and King's Wilson index in case of fulminant acute liver failure due to Wilson. And if confirmation of liver disease by genetics is there, we can use, because curative, so we can early counsel and can treat child. Okay. In case of chronic liver disease, use child puke score. Okay. If class B or C, counsel parents and evaluate for the transplant. So this child puke score. So these are 4 parameters. The scores were given 0 to 1. If score is 5 to 6, it is class B, class A. Class B is 7 to 9. Class is 10 to 15. Okay. So if child is class B, is class A is survival without liver transplant 10 to 15 years. So we are not going to transplant immediately, but if class B or C will work up for and counsel for the transplant. So when you look at, so we have seen the few conditions. Let's look at the profile of the transplant children. Okay. So this is the Pittsburgh liver transplant diagram for last 30 years. So red line. So most of the, in first 20 years, the cholestasis is more than half of the cases. Okay. In next 20 years, the cholestasis and metabolic liver disease contribute to the 2/3 of the liver transplant children. Okay. So in most of common indications are cholestasis followed by metabolic liver disease in children, followed by acute liver failure. So in India, so same cholestatic liver disease. After this is the retrospective study from tertiary center in Delhi. So total number of cases of 200. Among them, 133 is cholestatic liver disease. Among the biliary atresia is 72. Almost 35% of biliary atresia. And cholestatic liver and metabolic contribute around 2/3, similar to the global trends. Okay, followed by acute liver failures and others. So what are the contraindications? Absolute contraindications are few. So generalized extrahepatic malignancy, uncontrolled systemic infection, severe multisystemic mitochondrial disease, Niemann-Pick type C, severe portopulmonary hypertension not amenable to treatment, and hepatocellular carcinoma with extrahepatic. So contraindication are few relative. So we can go to, we'll move fast. Okay. So there are few controversial contraindication as well as where mitochondrial, many experts have even transplanted for the mitochondrial disease. However, they developed extrahepatic mitochondrial disease in neurological and cardiac. So most of these are controversial indications. So you won't get priority in the waiting list. So in pre-transplant workup, once you have recognize the need for a transplant, you have to go through the steps. We first evaluate for the pre-transplant, put the child in listing. Then during the wait list, correction the nutrition, portal hypertension, cardiopulmonary encephalopathy, and then make ready child for the transplant. Okay, so according to the each step, each institute can make their own protocol. These are the vast guidelines present all over the world. Every institute has its own personalized protocol according to the conditions and the difficulties they face. Okay, so we have the pre-transplant evaluation at KIMS, and so this is the guidelines which has to be undergo for the recipient. Okay, few can be rationalized to the condition, and few more investigation can be done according to the conditions. Okay, and subspecialty consultations, and as needed, genetic and liver biopsy and colonoscopy, even endoscopy should be done in cases. So in ALF, we have to draw sample at least for the metabolic and genetic workup if we have time for the diagnosis earlier. So in case of donor, you have to look for the exclusion criteria. The donor should be should not suffer with any genetic or metabolic liver disease or NASH or any complex surgery prior to. Okay, and there should be evaluation of the Doppler and vessels of the donor liver as well. So listing should be done after the decision of the transplant. So listing priority will be given on the basis of the MELD and PELD score. PELD score is children below 12 years. MELD is about 12 years. Okay, this MELD score is logarithmic score based on the bilirubin, INR, and creatinine. Okay, higher the score, lesser will be the waiting period. Okay, so this helps in reducing the waiting list mortality. Okay, so similarly, PELD score is there. Here we add, instead of creatinine, albumin and growth failure. Okay, in pediatric children. So again, more the higher the PELD score, shorter with the waiting list, and it helps in reducing the waiting list mortality. So during the waiting period, we have to rationalize and optimize the nutrition and portal hypertension and other therapies. Meanwhile, to make the children stabilize, make children ready for the transplant. So you have to vaccinate the children with hepatitis A, B, varicella. If not vaccinated for MMR earlier as well, vaccinate it and look for the other vaccine, missing of vaccination as well. Okay. So transplant procedure briefly explain. First, we have the donor liver removal, then recipient removal, then recipient anastomosis and intra immunosuppression. So graft donor. So graft types depend on the donor type and recipient. In DDLT, it can be whole liver or reduced graft. In LDLT, living donor recipient is always split liver. Okay, these are the whole liver, reduced size transplantation, split liver. Okay, and axillary partial liver transplantation, where you keep half of the liver in situ and you transplant, remove the half of the liver and transplant the new liver. Okay. And that is domino APOLT for the non-cirrhotic metabolic liver disease. So where one live donor can save two recipients, okay? And cross domino APOLT. So here you can see the first one is the whole liver. In this case, we have to use the age-matched pediatric grafts or age-matched adults. So it is difficult to get age-matched pediatric grafts. So so there was huge scarcity, but reduced graft, when we use reduced grafts, so we can make up for the pediatric transplants as well. So nowadays you use split liver transplants, which one adult diseased donor can save one adult as well as one child. So this is domino APOLT. So where one live donor left lateral lobe will be transplanted to the non-cirrhotic metabolic liver disease child 1, where the diseased liver of the patient 1 will be utilized to the another child. Okay, in India, first domino liver transplant was performed in 2009. So this is the first case in 2009. So this child was in Shaurya. He is suffering from MSUD. So his left lobe is transplanted into the Shiva, who is suffering from Langerhans cell histiosis. Okay, so this is because here that MSUD is only one enzyme deficiency. The rest are, that can be accumulated by the LCH liver in this baby. So cross domino APOLT is there, where there is no requirement of live donor. we mismatch the left lobe of the two parents. It has been in the adult as well as in India. So that's why we should classify the non-cirrhotic metabolic liver disease. And this can be also done in cases of acute liver failure. We have given time for to recover the normal liver of the other patients. So recipient procedure is with anastomosis, hepatic artery, hepatic vein, and portal vein. This is not require much for us, but we have to know the anatomy to anticipate the complications, which helps us in the ICU. Okay. So biliary anastomosis is mostly Roux-en-Y or ductal anastomosis, which can help us later in identifying the early anticipating the infections, ascending cholangitis. So we have to know the little anatomy of the anastomosis as well. So post-transplant care mostly the first 72 hours is hemodynamic and goal-directed management, followed by immunosuppression, and then watch for the complications. So goal-directed. So we have to look for the first 24 hours, give prior to the hemodynamic, maintain normal blood pressures, and maintain SCOT more than 65%. Use noradrenaline or fluid replacement to for the post-operative asaplasia. Consider high flow CVH if there is refractory shock. Also look for the respiratory. Maintain normal oxygenation. Aim for early extubation. Okay. Means look for the surgery complication. Look for the drains. If the color of the drain as well as volume of the drain. So if it is bright red or red, it indicates bleeding. If it is yellow, it can bile leakage. If it is brown, it can indicate perforation as well. Okay. Also look for the intravesical pressure for the abdominal compartment syndromes. So there can be small for size graft syndrome or large for graft syndrome. It can lead to abdominal compartment syndrome, and which can lead to MODS. Okay. And look for the liver synthetic function as well as excretory function, and start immunosuppression from intra period only. And as soon as child admits into ICU, stop sedation and monitor for the wake up from the ICU. Okay. Look for the infection as well. Start prophylaxis as soon as child accepts enteral feeding, PCV prophylaxis and CME prophylaxis. Okay. So this is post-transplant immunosuppression. We use triple drug immunosuppression. Okay. This overall is triple drug, but dosage will be rationalized according to the centers. So corticosteroids, tacrolimus, and MMF. So corticosteroids started from intra-op period. Tacrolimus started on day 2, day 3, and MMF typically start at the end of the first week. Okay. So meanwhile, look for the complications. Okay. Primary non-function of the graft. So, and abdominal compartment syndrome, post-operative asaplasia, post-operative bacterial sepsis. The first 4 can lead to mortality and non-function of the graft or graft failure. So others are vascular complications, biliary and graft rejection. Monitor for these complications and early recognition and early treatment is important in the post-transplant complication. Okay, when it's come to the outcomes, when you look at the tertiary care center from 200 patients, the survival rate is overall good. When you look at the Kaplan-Meier survivals, the 5-year survival is around 87%, whereas 1-year survival is above 90, is 95%. Okay, overall the survival rates has drastically improved after the immunosuppression. So when this is for all, this is you can for the per case wise. ACLF has lower survival compared to the elective and ALF transplants. Okay. So this paper in this last paper has more than 94% survival at 1 year and 87 at 5-year survival. Only one child needed retransplant. Most common cause of mortality in these children is infection, sepsis. Okay. This is the child transplanted for biliary atresia at 1 year of age. Now is 35 years of age. Though is healthy. 3 years back photos. The first child and who underwent liver transplant in India is pursuing MBBS now is final year child. Okay. So ALF early identification of and referral to the transplant center. So transplant is a standard care of ESLD. So referral to the again transplant center. monitor the chronic liver disease regularly. Nutritional management can improve the survival rates. Also titrate and manage the portal hypertension. So multidisciplinary team approach from the beginning of the CLDs helps.
Thank you, Dr. Pandu, for bringing out important points in care of hepatic failure. Now, I would like to change the tempo, and now we are going into pediatric super specialties where we want support from our surgeon colleagues. Now, I would like to invite Dr. Sugnaka, sir, who is plastic surgeon, extensive experience of decades, and a very learned, very learned, very humble doctor, always available to help us, sir. Sir, we'll be talking about burns and what more we can do beyond Parkman formula.
Thank you, Nitin, for your introduction. Am I audible? Good afternoon, everyone. Our topic today is pediatric burns. Yeah, it's so common. Every one of us would have experienced at some time or the other a burn in a kitchen or during Diwali or whenever there is any function. If there is more percentages more, then obviously one will have a lot of fear regarding the survival also. When to admit, when not to admit is another issue. So what are the modes of burn injury one can have? One is scalds. Usually what we see in the regular practice is the mother is carrying a hot bowl of water and the child runs towards the mother and hits the mother, and everything falls on the child. Other injuries what we have seen is a fall in the bathtub which is hot, and sometimes the child without unknowingly hot water shower he is putting on, and then falling into hot oil or sambar in functions is also we have seen a lot of cases. And nowadays after COVID, many people are steaming for cold. Then also steam burns and flame burns, scald burns are happening. Flame burn is another one when the child curiously playing with fire. Sometimes they will ignite papers, do all sorts of things. But puja also sometimes we are not saying properly, then they will catch fire from the flame. And also calamities of fire also another thing. Electrical things in some flats we have low sockets where they put pins, hair pins, they put safety pins into the electrical socket, and sometimes they put live cord into the mouth, getting serious burns inside the mouth and oral cavity. Chemical also, bathroom cleaners and all, sometimes accidentally patient child out of curiosity, it will fall on the percentage. Actually we know that rule of 9, everyone knows about it. But in the child, the head is relatively large as compared to the body. The lower limbs are relatively less in surface area. And when we calculate the percentage of burns, internal burns like respiratory burns, electrical burns are not included. Actually, the flame burns burn from outside in, whereas electrical burns burn from inside out. So if you see the head and neck carries 9%, right upper limb 9% surface area, left upper limb 9, anterior trunk 9 plus 9, posterior trunk 9 plus 9, left lower limb 9 plus 9, right lower limb 9 plus 9, and perineum is 1%. So 9 11s 99 and perineum 1% totals 100. Whereas if you see the child, the head is relatively having more surface area. When the child is in the age of 1 to 4 years, it is about 19%. When the child becomes 5 to 9 years, it comes down to 15%. Whereas if you see the right upper limb, left upper limb, it is 9.5%. Even if you see in the adult, it is about 9% only. But when you compare trunk, it is about 32% in a child and 32% when he grows older up to 9 years. it grows only to 36%. So the main 19% gets added up to the lower limbs. This has two implications. One is in when we calculating this surface area of the burns, we have to keep this in mind. And then the donor area which we take skin from in deep burns is from the thighs, so which has less surface area. So donor area for children is less as compared to adults if you are taking from conventional areas, although we can take from other areas also. Okay. Degrees of burns. If you take first degree, it is erythema only, just like a sunburn or a steam burn, hot steam onto the face. There will not be any blebs if you see first degree. First degree, it will heal in about 3 to 5 days time. Next is superficial partial thickness burn. These two are called second degree burns, superficial partial thickness and deep partial thickness. Depending on the thickness of the skin which is destroyed, up to the papillary dermis, it is superficial partial thickness. And if it goes up to reticular dermis, it is deep partial thickness. These two will heal on their own if you prevent infection and do proper management. The upper one will heal in about 2 weeks and the lower one will heal in 3 weeks. Third degree burn is when the whole thickness of the skin is destroyed up to the fat. So it will never heal unless you put a graft, or it is likely to heal with contraction, producing a contracture if it is across a joint. Fourth degree is seen in electrical burns, which will go up to the muscle and bone. So these are the staff requirements and infrastructure to treat a major burn. One is plastic surgeon should be available 24/7. And pediatric, because plastic surgeon should be available 24/7 because there are some surgical procedures which have to be immediately done in case of circumferential chest burns, which are restricting the expansion of the chest. And the extremity burns, if they are circumferential, they'll be threatening the vascularity of the limb. And of course, pediatric intensivist, our here fluid management is being done by pediatric intensivist only in the pediatric ICU. And we have to have pediatrician and OT facilities, especially for pediatric anesthesia, trained nurses, and special large dressings which are not available in commercially outside. We have to prepare in CSD, especially non-adherent gauze and big pads and bandages. Then isolation rooms must be available. A step down should be there because we can't keep the patient in ICU for longer time. Then we have to identify, burns rooms. We have to identify burn rooms where we don't keep other patients, even if the room is empty. And nowadays, special instruments we are using such as measure and electric dermatome. So what are the admission criteria in pediatric burns? Usually in adults, we admit the patients if the patient is having more than 25% burn surface area. But in children, if it is more than 10 to 15%, we have to admit. This is because the delicate fluid balance patient must be. And the facial and respiratory burns, many times we have to admit because airway difficulty and sudden airway obstruction can happen. Hand burns is also an indication for admission because it will produce a lot of deformities if not treated properly. And perineal burns are important because to prevent gram-negative sepsis, and patient may not be able to pass urine motion. For such things, we have to admit perineal burn. And electrical burns, first 24 hours, patient can have any arrhythmia. For that reason, we have to admit all electrical burns, even the surface area percentage is less. And closed space burns, if there is a history, we have to suspect carbon monoxide poisoning, and we have also to admit such patients even though the percentage is less. If there are circumferential limb burns or chest burns, as I told you, the chest burns may restrict the respiration, the limb burns may produce ischemia. For that reason, we have to admit and necessary do a eschorotomy. So what are the special characteristics of pediatric burns as compared to adults? Lower percentage also needs admission, as I told you, but a higher percentage is also more likely to survive in pediatric patients. Even 70, 75%, 80% also may survive. So need for changing out dressing under GA. Many episodes of taking to OT, giving anesthesia or giving ketamine or any other medicine in ICU and changing the dressing may be required in pediatric burns as compared to adult burns. The donor area which is available, the donor area which is available for us to graft is less. This is also a special characteristic of pediatric burn. Added psychological effects on children and parents, need for specialized pediatric care, and growing child can develop various deformities because of scar contracture, which will need multiple operations. What to do immediately? Of course, first we have to move the victim away from the scene. We have to remove or loosen the clothes and jewelry. Jewelry will be very hot. It will continue to burn because of heat contact burn. So we have to remove all the jewelry. For normal water for 20 minutes, burns are less than 10%. We have to put water in the running water, normal water, not ice, because the subcutaneous tissue retains heat longer than the skin. So if you put under water for 20 minutes, then the burn, instead of become 3rd degree, it may become 2nd degree. But if the percentage is more than 10%, you should not put or immerse in water. It may produce hypothermia. It is preferable not to apply any ointment until we assess the percentage of burn, because sometimes upper limb only 1% is there and ointment is applied for 5%. And unless you clean the ointment, you won't know how much it is. And it's not so much a benefit also to apply ointment immediately after the burn. It's not, doesn't prevent any colonization of bacteria. What to do if they have blisters? Usually blisters are not punctured. Unless they are small, unless they are big, there is no need to puncture any blister. This will create exposure to the outside environment. Patient have more pain. It will ooze more if you puncture the blister. But when if at all you puncture, then don't remove the loose layer. Keep it on the blister only and do the dressing. If the bleb is very big across the joint, then if it is limiting movement like elbow, then we have to puncture. And if you puncture again, you have to put a dressing. If there is acid burn or alkali burn, liquid chemicals, it should be washed with copious amounts of water. And acid to alkali and alkali to acid is not a treatment, because it will produce generate more heat and salt. Ice application also is avoided because it will produce more ischemia because of vasoconstriction. Topical ointment. Usually silver sulfadizine is prescribed, but silver sulfadizine as opposed to ordinary dressings has not shown to be any better than no ointment or with ointment. It should not be applied to facial burns. If it goes into that, it will produce a lot of irritation. So Silver X should not be applied to the face. Instead, we can apply any ophthalmic ointment so that even if the child rubs the eyes with the ointment, nothing is going to happen. Silver sulfadine is contraindicated in pregnancy and lactation and sulfa allergy patients. Prevention of infection is very important in burns. When we are treating burns, hand washing is utmost important. Then aseptic dressings, which are prepared in the hospital in central sterilization department, especially, are the best. And we have to wear gowns and masks before handling the patient. And isolation rooms and clean all the equipment every day, around like pulse oximeters, BP cuffs, everything should be cleaned every day. When do you suspect a respiratory burn? If there is any facial burn or edema of the lips, singeing of the eyebrow hair, we have to suspect respiratory burns, keep the patient under observation. If there is a tachypnea, hoarseness of voice or stridor, also we have to keep the patient under observation admission, because anytime patient can go into respiratory difficulty. Treatment is 100% oxygen, elevation of the patient, steroid nebulization. If necessary, prophylactic intubation. We have to assess the airway. It is better to intubate the patient beforehand only if you are suspecting any, because it will distort the glottic structures Afterwards, it's very difficult to intubate. If you're suspecting a glottic edema, you have to intubate immediately when the patient is conscious. Bronchoscopy and other respiratory toilet procedures may be required in respiratory burns. Tracheostomy usually avoided because with the neck burns, healing will be difficult. All facial burns will carry some or the other neck burn. And if the neck is normal only, tracheostomy will be useful. Respiratory burns, mortality is independently high if you compare with the surface area burns. So what are the surgical procedures? This is an emergency eschorotomy done for a chest burn. There is a deep chest burn which is restricting the respiratory movement of the patient. So if you incise like this, there is no need for anesthesia also, because in a 3rd-degree burn, everything is insensate. Only thing is you should have a bipolar cautery to stop the bleeding. It can be done in ICU also as an emergency basis to release the eschar to improve the movement of the chest. Collagen application. Collagen application is also like a dressing only. It is useful in 2nd-degree burns only, especially in pediatric scalds. It is not going to heal any 3rd-degree burn. We have to do a grafting only if there is any 3rd-degree burn. But some advantages are it provides a moist environment. It binds to metalloproteases and doesn't get absorbed into the body. It comes out of the body after it finishes its job. It will reduce pain and fluid loss, and it will promote uniform healing, and it reduces scarring. It is non-immunogenic, non-pyrogenic, and hypoallergenic. It is origin is bovine. It increases fibroblasts and preserves macrophages. This patient had scalds. So we have done collagen application, but he will need anesthesia over that because we will be leaving the outer layers of skin, outer layers burnt here, and this white sheet is collagen. We can expose this, but mother or some other person should see that he won't scratch and take it away. Once it sticks, it becomes like this. It becomes dry with the exudate. Later, it slowly separates like this. As I told you, this collagen doesn't heal the 3rd-degree burn anytime. This is a 3rd-degree burn. Patient needed a skin grafting here. All separated in 2 to 3 weeks time, like this. And then this remaining area we had to graft. This delicate area of recently epithelialized burn needs to be protected with moisturizer and sunscreen lotions to prevent pigmentation. This is another patient with the trunk scalds. Admission needed more so because of the perineal burns. Also treated with collagen application. If you remove the outer layers of and apply collagen and dry it under anesthesia, it will slowly heal. In steam burns, the water will not go beyond 100 degrees unless it is pressurized in a pressure cooker or so. So usually the scalds are 2nd degree only, they're not deep. Again, it depends on contact time also. If it is more contact time is more, it can be 3rd degrees, but otherwise usually it is 2nd degree. This gluteal burns, scalds actually, he will need admission, but collagen is usually not done because if the patient lies on the collagen, it will go away. If we can nurse the patient in prone position for a long time, 2 weeks, if a mother can take care, then only we can put collagen in these patients. In deep burns, less than 10%, we can excise and put graft even after 48 hours and hasn't the healing. But we should know that the burns are definitely deep. It needs a lot of experience to know whether it is 2nd degree or deep clinically. There is no test for us to differentiate between 2nd degree and 3rd degree other than clinical thing. And if the 2nd degree burn gets infected, then again, it might become 3rd degree. This one, if you see this child, This is called stamp grafting because there is no available donor area. Everywhere it is burned. Even though both lower limbs are burnt, upper limbs are burnt, only the head and face are spared. So majority of the burns healed by conservative treatment and remaining raw areas were grafted. Even though the patient looks like this now, once he comes out of the burns, he will be healthy only forever, not like cancer or heart attack. Oh, video please. On correct? This is a measure. Audio this is. This is called measure. After we take the skin from the thigh, we'll mesh like this to increase the surface area of the graft. So you can cover more area. It has 1:2 or 1:3 or 1:5 also. Fast. This comes out like this, like a mesh. So the surface area is increased. You can cover more area. Another advantage is because of these holes, any exudate inside will come out for a better take. It comes out like this. This is another thing which is electric dermatome. There's a battery operating from inaccessible areas. Also, we can take skin. Like even we can take skin from scalp after shaving the head, or we can take from the gluteal region. From anywhere we can take with this. This skin is taken and put into the mesher, so that will. Wow. Inside out. Widen. This is neglected bonds, white outline. This is a claw hand neglected bonds referred to us from somewhere. After release, next. Playing slowly. This after the release, the fingers were able to join the fingers. Here's another one, sequelae, post-burn contracture of the finger. After release, it will look like this raw area, which will be grafted to make the finger straight. This is electrical burn. In electrical burn, the skin and the bone gets heated up more because of a lot of resistance, and skin and the bone are damaged more than the other structures. Once it is so deep that it will expose the femoral artery and patient can get a blowout. So this much is a raw area. Then this is a TFL flap over the femoral important structures. Rest of it can be grafted, but this area it has exposed femoral artery and vein, which could blow out if you don't put a flap. This is another electrical burn exposing scapula, and simple grafting will not do anything for this. We have taken a latissimus dorsi myocutaneous flap. This will look like this. There's this flap from here, along with the muscle is shifted onto the scapula, and the donor area is grafted. Thank you.
Thank you, sir. Thanks a lot. I think none of us has ever seen a mesh skin in real terms. I have never seen. I'm sure most of us have never seen it. Thank you, sir, for bringing out such an informative session. If you have any questions, we will ask sir to answer that. We'll proceed with the next session, sir. Thank you. Now, I would like to invite Raghavendra sir, our neurosurgeon, to tell us more about traumatic brain injury series. Sir.
Good afternoon, everybody. I thank Dr. Chawla and Dr. Suman for this wonderful meet. And nice to see all the people at even Sunday. So much of people are gathered to see. So I'm just sharing the last small series which we have done in the. I just can get this one. This one. Which one? Yeah. Myself, Dr. Raghavendra. I'm a neurosurgeon here. Whenever I begin my talk, I just always remember the saying of the great man, the most beautiful thing we can experience is mysterious. It's a source of art and science. So this motivates me always for my presentation. Today, I'm just sharing the traumatic pediatric extradural hematoma. It's a small petite experience. So we all know the value of time is brain. So it's begin with that introduction. The head injury is one of the most deadly complications what we have seen. And not only the head injury, it's not just a person gets affected, like other diseases where in head injury, the family gets affected. We have to treat the family, but not only the patient's health, the family financial burdens, the economical burdens, and the family all are disturbed because of the simple sudden, which can just happen in a seconds. So we know that almost 1.5 to 2 million people, and almost of which 1 to 10 lakh people in India die because of head injury. And the motor vehicle accidents are the main cause for this. And in that, extradural hematoma constitute about 1 to 2% of the cases of our head injury. So the maximum incidence of head injuries has been in the working population, that is around 11 to 60. So it is more impact in the family. It's very uncommon. We know that the head injury are very common, but the extradural hematomas are very common on 11 to 60, as I told you. But it's very uncommon in the pediatric age group, because we would be reading from our MBBS days saying that the dura is densely adhered to the periosteum. So we don't get the extradural hematomas so common. So, but whenever there is an extradural hematoma, we always see that there is an overlying skull bone fractures. But in the pediatric age group, even without the skull bone fractures, still we can have an head injury, because there is an elasticity of the bone which is causing this one. And we all know the most important source for this RT, the extradural hematoma, is the middle meningeal artery tear, or sometimes the venous, or sometimes the trauma hematoma. So extradural hematomas, we know to make it infrequent below the age of 18 years, and it's common constitute about 1 to 3% of the pediatric head injury groups. It's very rarely occurs in neonates, but it is sometimes associated with the forceps vacuum extractions. So coming to my study, what we have done, we just to understand how extradural hematomas in the pediatric group. So we made one aims and objectives of our study is to understand the demographic profile of the patients, and we also understand how clinically the correlation of their outcome. So methodology was that it was a prospective analytical randomized prospective study, and the place of study is a tertiary hospital. I did this study, and some part of the initial of the study was done at RML hospital where I graduated, and some after I joined in KIMS in Hyderabad. The study period was more than 6 months, and the sample size was 38 patients. And inclusion criteria was that all the EDH patients, all the extradural hematoma patients who have below the age of 8 years, the exclusion criteria are those who have like non-traumatic EDH, like post-operative EDH or any coagulopathy leading to EDH. Those patients have been excluded from this scale. This is a Glasgow Coma scale, and it is very, you people have to read, and I have to read every time before I take, because though we read adult GCS is very easy, but pediatrics, we cannot just memorize like this. The GC score, Coma scale score is less than infant, this is what, and in the child 1 to 4, and this is what we have applied age more than 4, and ultimately the score comes to 15, what we all know. So what made us to go for surgery? The indications for surgery in extradural hematoma is that in a supratentorial EDH, when the hematoma is more than 25 ml, or there is a midline shifter more than 5 ml, or the thickness of hematoma is more than 50 mm, we have considered the patient for the surgery. When it comes to the infratentorial EDH, means it is in the below the tentorium, in the occipital area, the volume of hematoma, if it's more than 10 ml, and the midline shift more than 5 ml in the form of ventricular shift, or we can see the effacement of the cerebellar cortex, or the clot thickness more than 15 mm with mass effect, has been considered as the indication for surgery. How do you calculate the volume of hematoma? It's all about the cylinders, what we read in our school days, like length into breadth into height by 2. This is how we calculated the hematoma. We used to sit with our radiology technicians so that he will be helping us in the odd hours to calculate hematomas. So what are the follow-up we did is we have done a Glasgow Coma Scale follow-up and how the neurological examination and the non-contrast CT scan has been done based on when required, and the Glasgow Outcome Scale score has been analyzed at 2 weeks, 1, 2 on the 6 months, and based upon them we have categorized them into favorable and unfavorable groups. Those, if you read understand the favorable, 4 and 5 belong to those category which are in the favorable category. So this is what the Glasgow Coma Scale, the good recovery and moderate disability. The rest, like severe disability, coma, and the death are considered the last three, and the 1, 2, 3 are considered as unfavorable outcome. For a the Glasgow Outcome Scale is also with that. There is even for a pediatrics we use that is called KIMS Outcome Scale, which has been modified Glasgow Outcome Scale for the pediatric age group. So what observations have found in my pediatric patients is, so I have already told you that I have 38 total number of patients. In that, the most of patients are belonging to the age of 1 to 5 years. Means I can say that the most of the patients are around 55% of my kids were of 1 to 5 years of age. So coming to the gender distribution, here also the male around 55%, more than 50%, 5%, but not much difference when it comes to the gender distribution. So what is the mode of injury? The most common mode of injury for the child was in fall from the height. It was almost close to 80% of our patients had in fall from the height, which is the cause for the EDH in this child. I think you all know the lucid interval, which we read from our school days as a very fascinating thing. So in our cases, only the 4 children were had extradural hematoma. But that is also, I'm not saying so commonly even extradural hematomas. Around 11% of the children had extradural hematoma with lucid interval as their symptom. So coming to the clinical symptoms, what all the clinical symptoms we evaluated? Well, also the significant loss of consciousness was almost in every child, almost close to 80% of the patients had loss of consciousness, followed by multiple episodes of vomiting, around 52% had, and neurodeficits like in monoparesis or in hemiparesis was very common, very less, unlikely in 5% of the individuals. So based upon the categorization of the severe, mild, moderate, and severe, we categorize the injury, which we know as the GCS scale when we study. In our head injury, there was 87% of the people had fall into the category of mild head injury when it comes to the GCS score calculations. So what is the EDH location? Where did we have our EDH location? Most of our EDH location was in the parietal lobe, followed by the frontal region, around 45% in the parietal region, and around 40% of the individuals were in the frontal regions. So we have very limited in the posterior fossa, like occipital regions, in the infratentorial only constituting around 8% of the children had there. When we calculated the volume, as I told you, the volume of the hematoma was calculated by using the formula ABC by 2. So we had a calculated volume almost from 80 to 40 ml, and the mean volume what we got was 14.81 ml. So based upon the, as per the, we have taken those patients, we have segregated the volume of hematoma into 2 categories, whether it's about 25 ml or less than 25 ml, more than 25 ml. Most of the kids in our group, almost 83% of the people who are in the category of around less than 25 ml of the hematoma, and those people, this categorization is very important because based upon the hematoma volume is one of the criteria where I've told you earlier that is the indication for surgery has been considered. In the posterior fossa EDH, what you call cerebellar hematoma, we have only 3 kids, which I told you only just constituting 88% of our sample size. So it is less than 10 ml, all the children at less than 10 ml. So that I told you earlier, the 10 ml is a cutoff. If more than 10 ml, we have taken for a surgical intervention. So the clot thickness is also important. The clot thickness was ranging from 2 to 20 mm. Mean is about 8.84 mm. But most of the people have a clot thickness less than 15 mm, around constituting around 84% of our individual. Means most of the children have a clot thickness less than 15 mm. Coming to the midline shift, the midline shift is only present in just 37% of the individuals. But all midline shift doesn't mean that with this one, but only those midline shift more than 5 mm we have considered as a significance for the surgical intervention. The midline shift less than 5 mm were just managed conservatively. So intracranial injuries, we had almost equal, the number of patients near equal. Out of 20 patients have intracranial, 18% have only had 18 patients, means constituting around 48% of the individuals have intracranial injuries, but rest 20% doesn't have any intracranial injuries. So means it is nearly every alternate child had intracranial injuries that we can say in this. So coming to the what all the intracranial injuries we had is the most common intracranial injury we found was a brain edema, because whenever even a trivial trauma, we will have some brain edema. And the next one is parenchymal contusions, which constitute almost 22% in our patients. So like a subdural, subarachnoid, and pneumocephalus, they almost constitute less than 8% in the individuals. So what was the skull bone fractures? How many patients? We had almost 20 patients have a skull bone fractures, and the most common skull bone fractures were in the parietal region because it's a high prominent skull. We expect it to be more common, and 23 means almost close to 24% of the individuals had a parietal bone fractures. The rest, like 16%, were in the frontal bone. Occipital and temporal constitutes the 13 and 8% individuals. The basal cistern effacement is very important for a clinical judgment for any surgery to be taken or not. We had only 11% of the individuals who are effaced cisternal space, because based on the cisterns is also one of the criteria for our surgical intervention. So we have operated in the 6 patients, underwent surgery in 38 patients, and they constitute about 13% of individuals had a surgery. This is one of the just video showing this. So this is an extradural hematoma. I operated 17 years boy, and just 10 days back. We can see how he just fell down from the, it is due to the RTA. It had a very complex skull bone fractures. We have removing almost like in this one. But God says everything is doing good and is normal in his lifestyle. But the EDH, the thing is that the timely intervention, the first slide of mine always says the time is brain. That's what our training has been. This is a skull which has been comminuted in a very, this one. This is a large extradural hematoma we are taking out. The moment he was in unconscious state, the next day morning, he will be exactly like all normal. So the more early intervention we do in extradural hematoma, the prognosis is really good. Though it is a fatal disease, still it can be. This is one of the large extradural hematomas we are taking. So you can see that underneath the what you're seeing, that white structure is a dura. It's really lax. It's not like we have no associated brain edema is much, brain contusions, and no associated brain injury. It's more of a head injury, which is a mass effect. What we call it as the compressions is a major factor. Once you take out the compressions, obviously their quality of life will be absolute, because here the brain has not been affected. The only thing is, by doing an early surgery, you are able to prevent out the secondary damage. So you can see that even that taking out small slices of bones means it was a very bad injury. In that bad also, the good is only that it's only an extradural component. It didn't add any this one. So we have just all the at the end of the procedures, we made all the bones to be, we used many plates and we have applied and just kept it back. So this is, so at the end of our study, all the 6 months follow. Most of our patients belong to the category of GOS 5 and 4, means almost have better quality of life rather than this one. So there was no mortality in our study, and one child had irritability at 6 months in 3 children, and one had upper limb monoparesis in the 2 kids. So the GCS score when we come, as I've told you in the previous slide, we almost 94% of the 95% of the children had GCS score better. I mean, out of 38, 36 were there, and very 2 are only disabled. Little that is monoparesis in that form. That's all for a time they will improve. So, but when I went through the literature, what available when it comes to pediatric heterology, I found some discrepancies between them. The discrepancies what we felt, because all the literature what I have gone through this is that they had around 7% to 8%, some had 12% mortality rate. But in our case, we didn't have any mortality. But the thing is that maybe the overall, the presentation of the children, what we have taken our case studies, GC score at the presentation was very good in most of the kids. All I told you, almost 80% had a GCS score of 13 and 14. That may be one of the criteria. And a very short time, that when we reviewed the arrival to the hospital, the injury was very short in time. And we maybe our reasons for early CT, because we worked in a tertiary centers where CT gets very easy. And one thing is where those surgical cases where maybe early intervention. So these are all the reasons for our discrepancy when compared to the previous literature. So limitations of our study is also that we don't have a cognitive functions of the child was not assessed, and it is very sample size. In a big world of head injury, 38 samples is very small. So we need to evaluate further to make conclusions. So to conclusion, always whenever the child with an head injury, there is high suspicious of injury, underlying injury as well has to be interacted. The most common injuries what we fall in children is height. So we always prevention is better than cure. GCS score at the presentation is the most important determining factor when it comes to the prognosis in the long term. And early CT, as and when required, nevertheless, it will be better to do it early. And EDH volume means that volume of EDH may not make the outcome effect, because sometimes the people may have a long length, but it may not be thickness. Thickness also very important. So like an ABC multiplied 2 may not exactly reflect the clinical scenario. Sometimes not only all that sometimes the children will always have an underlying primary brain injuries like in diffuse axonal injury. However, you treat EDH, the children prognosis may not be so good. So these are the references. I can take this one. Happy New Year. These are both the kids. And wishing you happy New Year. Wear helmet and be safe. This one. Thank you. Thank you, everybody. Any questions? I'm free to answer. Thank you, Chair.
Thank you, sir, for sharing your experience.
Thank you.
Thank you, sir. Yes. So we will be stopping our live streaming now because now we are going ahead with the lectures on 2 lectures, but they are completely